Warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, and we are glad to have you today on our next day of Global Health Exhibition. Thank you for being here. Kindly check the agenda updates by scanning the QR code from the digital screens at the entrance. And the coming session is session number 6. Next in health, correct, using digital transformation to realize population health objectives. And the speaker is Dr. Abdurrahman al-Sheikh. He's consultant, Lean for Business, Riyadh KSA. Please join us on the podium.
All right. Assalamu alaikum. Bye. Good morning, everyone. So today I'm going to get you into a journey for the digital transformation and the role in population health management. So we are going through a tremendous transformation in healthcare, and we believe that digital transformation is an essential part of that transformation. So the Vision 2030 lies the way or the path for the transformation. And among that, we have the vibrant society, and then we have some objectives that we're trying to achieve. So we have many challenges in the current situation. We have the increased cost of care, and we have the aging population and the burden of disease. So as of now, we have almost 5% of our population are over 60, and we believe that by 2030, this number will double. So that will come with increased burden of disease and needs of healthcare services. So let me tell you about a journey that mimics a lot of our daily lives here in Saudi. So Ahmed is 53 years old. He felt severe headache, and he went to the ER directly. So at the ER, they stabilized him, and then usually they will send him to an outpatient clinic that is, if far, it will be in 3 or 6 months. So if he missed that appointment, usually nobody will reach out to him. At the same time, his social determinants of health are not taken into consideration. And this gives you an example into how to embrace population health management into increasing the health outcome of our population. So this might be the current situation, but we believe that will change in the next coming years. So this is what we call the quadruple aim of healthcare. And we believe that this will shift the healthcare into an efficient healthcare system that increase the population outcome and enhance the patient experience without compromising the provider wellness. So usually we have a generic framework for population health management. It starts from collecting the data and doing the needs assessment, and then we segment or certify the population, and then we introduce interventions and evaluate them, and it goes like a cycle on and on. So this is the generic framework of how population health management works. Okay, so usually we have this question: what's the difference between public health, population health? So public health is usually concerned with the governmental or national level interventions like vaccines, while population health focuses on subsegment of the population that share specific characteristics, for example, age, gender, geographic location, or health conditions. And then we have population health management, which is another layer that builds on that, utilizes the burden of disease and the social determinants of health to segment and risk stratify and assess the interventions and evaluate their effectiveness. So usually population health management have the aspect of finance into it in addition to the outcomes. So do we have data nowadays or we don't have data? That's really like a question that comes in mind. So throughout the beneficiary's journey, we have a lot of touch points into the healthcare system, starting from the birth registry. So all of these are national registries that currently in place. Some of them like goes back more than 5 years, and some of them are introduced recently. But none of them speaks together. So you might find a child in the vaccination, but he's not in the birth registry. Because like when he was at birth, he did not have a unique health ID, so nobody connect the dots between these registries. So this is one of the challenges that we face in healthcare. Another challenge is when we come to HIMSS AMA or the analytical maturity classification, we have a huge gap in the healthcare system between the Ministry of Health and the other governmental and the private sector. So as you can see, we have only 3 institutions in the kingdom that's certified as level 6 or stage 6 or 7 in the HIMSS AMAM, while for the EMR or electronic health records maturity, we have almost 37 institutes in the kingdom that are certified stage 6 or 7. So most of the hospitals nowadays that runs an electronic health record system, they have fragmented data, not, let's say, structured well, or not used at the right time. So if you go even like to a credible institution and ask like, who are your like diabetic patient population? The answer will take at least maybe like a week or a month, depends on your like criteria. So to have the right information at the right time, usually we recommend that getting like accreditation from HIMSS or having the same requirement for AMAM. So at Lean Company, we have an ecosystem of different platforms that covers the ecosystem of the healthcare. So starting from the practitioners, we have ANAT, which we use as physicians to, let's say, prescribe medications, to see our empanelment or team-based care, and to do telemedicine. And then we have الصحة, which is for organizations. And currently in the kingdom, all the, let's say, sick leaves are issued through الصحة, in addition to other features in the private and the governmental sector. And then we have the mobile app for the beneficiaries, which is صحتي. So through صحتي, the beneficiaries can book an appointment, and it's the official national health platforms currently. So some data sources that we have at Lean that comes in real time, and some comes daily, some we have as references. So for example, we currently operate the HIS for the primary health care, and we have more than 2,000 primary care currently in real time that operates Raqim, which is the HIS in the governmental primary health care. And then we have some like daily data, we have some data from the vaccination systems, and we have some references from registries or from other, let's say, agencies that provide reference data like the General Authority for Statistics and so on. Okay, so the solution that we have for population health management is called Yamama. So currently Yamama takes all the, let's say, discriminations or the differences in the different systems that I show you and try to connect them to give a 360 view of all the beneficiaries. So we can look at the demographics and the health characteristics and so on, and it will enable the decision maker to make appropriate decisions when needed. Okay, so let me introduce you to Yamama more. So at the bottom here, you can see we have like population definition, and these are geocoded for individuals. Currently, almost all the individuals in the kingdom that have, let's say, a national ID or a visa or whatever, they are entered into some systems or some registries that we have access to. So we can know, let's say, at least like 8 information about the demographic, like date of birth, name, and nationality, and so on. And upon that, we have a health assessment. So let's say this is the skeleton, and then you have the flesh and skin and organs. You have the health assessment. You have the social terms of health. That will enable us to make the population segmentation, and then the cohort finding and model of care, and so on. So we have different domains in population health management, and usually population health management relies on the collaboration between different stakeholders. So we have resource management, financial management, and so on. And we know for sure that population health management, it will give a lot of the information for the other domains. So for example, if you want to do like an intervention, usually you will rely on the demographics or the denominator from the population health management output. So there is a lot of like communication between these domains that will give a better picture for the population. So I'm going to take you into the different domains, and usually these are what I show you in the beginning from the generic like population health management framework. So underlying this framework, we have technical capabilities at Lean. As I mentioned earlier, so for the HI system, when you have more than 600,000 encounters per week, usually each encounter will have more than sometimes 1,000 data elements, and it will require big data analytics. So this is from only one source, and to have this capability inside, let's say, a cluster or a healthcare facility, it's really going to be challenging. So we have a cloud system built at Lean that enable us to crunch these data and to apply data quality checks against the national registries. So all the information that we have, we always want to verify against national registry in order to link them with the appropriate individuals. And then we have the validation, and then we transform all the data into the national standards, which is, let's say, ICD codes and so on. This will enable us to make the appropriate analytics in the appropriate time with a robust speed. So we also try to have the autonomy for any user for Yamama. He can like dice and slice between different standards or between data sets. Okay, so I mentioned the geocoding. So in healthcare, some would say you can use the data from the GStat, but unfortunately, we have different distribution or boundaries in healthcare. So if we want to like go by district or governorate or whatever, in healthcare, usually that will not work. For example, in Riyadh, we have 3 clusters. So in order to have the boundaries between the 3 clusters, you have to do a lot of estimations. While in Yamama, we start from the geocode, which is the coordinates, and we move up. So it will enable us to have any distribution. So for example, if we want to like build a primary care in one place, we can know how many individuals will be affected in the area, whether it's like a neighborhood or a radius or even smaller than that. And then we build on that the burden of disease. So we have 2 outputs. One is the crude burden of disease or crude prevalence. And then we have a public health estimation. So currently in the kingdom, if we want to do the crude prevalence for the over 60, for example, we will have some kind of gaps because some people goes to, let's say, other governmental agencies that currently not connected to NAFIS or the National Health Information Exchange. So to fix this gap, we have created some kind of estimations, small area estimation, to understand the gaps in the areas that we don't have a lot of information about. And then building on that, we have the segmentation. So we try to segment the population. So as I say, one size doesn't fit all. So you have to segment your population into meaningful segments that drives interventions. So usually for the healthy, for example, you would do like preventive care, they cost less, and then you have the acutely ill, you're trying to get them to the healthy, and so on. And then we have the analytics that build on that. So if we have the correct and the cleansed data, it will enable us to do advanced analytics. And usually what we do is like driving from descriptive analytics until prescriptive analytics. And this is what we call a foresight model. So this is one of the models that we utilized with the health sector transformation program. There was asked to predict the population for 2030. And we have some challenges in prediction because to predict the population into a linear model, you will miss a lot of opportunities. We know that Vision 2030 have different estimates for population. So that's why we needed to adopt a model that uses system dynamic to enable us to have different futures or multiple futures. And it will enable the decision maker to understand all the scenarios that can happen in the future. So let's go back to Ahmed's story. So we have currently a risk or machine learning for risk certification that identify people with who's high risk in diabetes. So let's say that Ahmed was discovered early and he got an invitation to get tested. He went to the primary care and find out that he have pre-diabetes, and the intervention was early on, so we were able to prevent. I think the mic is not on. Hello. Yes, so we were able to prevent one case of diabetes and to enter the social determinants of health into the criteria of determining the risk of Ahmed was a major part because Ahmed was living in a rural area, so the team was able to introduce more telemedicine or other interventions that will bridge the gaps in his healthcare access. So this is an example why we need population health management to improve the outcomes of our population. Okay, so let me take you to some of the examples that we are working on in population health management. So on the left, you can see the population projection. As I told you earlier, we have the prediction, which is usually a linear with a confidence interval of predicting the population based on previous information. And then we have the foresight, which give us more, let's say, scenarios of what could happen based on other factors that what we call like non-market or environmental, political, and so on. So this is one of the examples that we work in Yamama with the Health Sector Transformation Program. Another thing with the model of care, so in the model of care, we do assess in identifying the baseline for the model of care pathways. So currently, let's say how many diabetic patients that you have, how many underdiagnosed. So enable to have the baseline for the clinical pathway, we do assess with the model of care. And then we have the population health lab. And through the lab, we have different stakeholders that propose a file. So for example, we finished like a file about stroke that identified the community interventions for stroke patient, because currently all these stroke, let's say, interventions are reactive or secondary or tertiary care. So this is one of the files that we tackled. And we have like more files that focus on the population health and the population health management into identifying the health needs. And I'm pleased to announce the Population Health Lab official signing will be today at 11:30, and you all are welcome to attend the signing. We also have the lunch of Yamama. It's going to be at 12 o'clock at the Lean Company booth. So going back to the models that we have or the framework that we have in Yamama, so as I mentioned, we go from the individual level in the patient definition, and then we build on that the health assessment, which is usually like composed of clinical data that are structured, and then we have the social determinants of health, so whether it's behavioral or environmental, and then we have the population segmentation, and then we have the cohort finding, which is the what we call like queries or inclusion and exclusion factors coming from the below like domains. So above on that, we have the model of care, which is the intervention. So we link all the analytics to the intervention, and it is essential to have the intervention, let's say, step, because without the intervention, all of the analytics that we have, they're still like theories. So, and then we have the insights and the foresights. So these are assessing the intervention before introducing the intervention. And the foresight usually, it gives the stakeholder some kind of understanding about the health system in general. So if we want to like introduce an early screening for diabetes, so what's the effect on that, on the resources? How many kits do you need? And then what about the discovered cases? Do you have like the ophthalmology capability like to check them yearly? And then do you have the capabilities that will prevent other people from having this condition, or like treating their obesity or risk factors and so on? And what's the effect on that program on other programs? So are the patient with diabetes going to be affected? Are they going to be having like lack of testing or lack of, let's say, appointments and so on? So this gives you an insights about what's the effect on the intervention or single intervention on the whole health system component that we showed earlier. So we believe that population health management plays a major role into the transformation, and this role is complemented by the collaboration between the stakeholders. So I really would like to invite you all to be part of this, let's say, mission, because we believe that population health management can change people's lives and make them healthier. So it will drive like wellness, and this is one of the approaches that was adopted by the Health Sector Transformation Program, and it is a pillar in the healthcare delivery or the healthcare company, and it is also a mandate in the contracting from the Center of National Health Insurance. So population health management is already like embedded in the health system, and I think it's about time to see some kind of the early result of population health management, and you might see some insights about what's going to happen if you visit us at the booth. So these are some of the stakeholders that we work currently with. So on the left, these are the early adopters. So some of them have already like given access to the data. And on the right, these are the stakeholders that we think that going to be engaged soon. As I mentioned, this is a collaborative work, and we believe that together we can achieve the outcome and the goals of the Vision 2030 and the Health Sector Transformation Program, enabling that using the digital capabilities and infrastructure that we have. Thank you.
Thank you for Dr. Abdurrahman and his interesting speech. We are going to start Precision Innovation, Healthcare with No Limits. The speaker is Mr. Rob Walton, President and CEO, Europe, Middle East and Africa, GE Healthcare, please join us on stage.
Morning. It's a pleasure to be with you here in Riyadh at this fantastic global health exhibition. And I'm going to be talking to you today about precision innovation and what the future of healthcare might hold and how we can create a world where healthcare has no limits. Before I do that, I want to just talk about, what does the future of healthcare look like? And often when we are introduced about this topic, we often see pictures like the one you see here behind me, where it depicts a utopian picture of what healthcare might be with, perfectly available information, seamless data flowing, fantastic intensive care units, operating theaters, things like this. Everybody gets diagnosed with their diseases very early, gets treated and recovers, and everybody lives till 300 years old. Now, that's not really necessarily the reality of what healthcare is today. And often the future of what we think is going to happen doesn't always turn out to be how we envisage. To illustrate this, I want to give you a little bit of a personal example about this. So hopefully some of you may have seen this film, Star Wars. This was a film which was very popular when I was a kid. And you may remember there's a scene within this film where Darth Vader, who is the guy, the father of Luke Skywalker, have a lightsaber battle. And Luke has his hand chopped off, and he has a prosthetic hand fitted by a robot, which creates a fully functioning hand, which is almost identical to the hand that he lost. And for me, when I was a kid watching this, this was a really transformative movie. And this scene in particular actually drove a lot of my personal decisions in terms of what I did after that. It made me want to be an engineer for a start, so I became an engineer after watching this. And secondly, I wanted to go into healthcare after watching this movie, so I could transfer and apply technology to solve healthcare problems. What I thought at the time was that, once it got into the future, once I became an adult, this type of stuff would be widely available. The reality, though, 50 years on from the making of this movie, you still cannot get technology which is at the level that you saw in this movie. And that's despite all of the advances in artificial intelligence, robotics, electronics, software, we still cannot do some of the things that we expected to be able to do into the future. And this reminds me of a quote by a man called Peter Thiel, who was the co-founder of PayPal, and now a venture capital investor. He said this: we wanted flying cars, and often when go back 50 years ago, people expected us to have flying cars in the next 10 years, as you can see from the advert here. The reality was the way technology developed, we got 140 characters. And this is a reference to Twitter, who some of you may be familiar with, which is the social media platform. And so those visions of what we expected to be available in terms of flying cars turned out to be, not quite what we expected. And while it's really fantastic to be able to share with you all what I had for breakfast this morning, it's not really the vision of the technological future that I envisaged when I was a kid. Now, we think about healthcare and where healthcare is today. We expected by this stage healthcare to be perfect. There's been many advances in healthcare over the last 50, even 100 years. But still today, many of the challenges that we're faced with continue to be extremely challenging. If we look at the quality and outcomes, still today, less than 1 in 5 people who are diagnosed with lung cancer survive for more than 5 years post the diagnosis. That's a real surprising statistics considering all of the advances in cancer treatment that's taken place over the years, that was still that level of, less than half of the world's population has access to healthcare. That means half of the people in the world still don't access basic healthcare, which is an amazing statistic, really, when you think about it. And in terms of healthcare resources, there's still a shortage globally of more than 13 million healthcare professionals required to be able to serve all the healthcare needs that we have today. So these are fundamental issues which have existed for a long time in healthcare, but despite all the advances, we haven't quite been able to solve these and bring healthcare to a new level. And then COVID came. So these issues existed before COVID, but COVID was an amplifier and an aggregator and created whole new changes in terms of how healthcare exists. Some of the good things that came out of healthcare was the advances in terms of telemedicine. And because of the pandemic, it was necessary for doctors and patients to be able to interact and doctors to be able to treat patients using telemedicine techniques. And one of the good news is that even post the pandemic, the level of telehealth has remained at more than 10 times the level it was before the pandemic. And that's really fantastic in terms of being able to expand the coverage and expand the reach that doctors have to be able to go and serve patients in much more remote and widespread communities. On the other hand, the pressures that come onto clinicians have become extremely challenging. The amount of reporting, the amount of data, the amount of expectations on healthcare has really been a challenge. And many clinicians are now experiencing significant burnout and actually don't want to stay in the profession. And so despite the fact we have a shortage of clinicians, many are now choosing to leave the profession rather than join it. And so we see statistics that more than 47% of clinicians globally actually plan to leave healthcare in the next couple of years, which is quite a scary statistic. One of the reasons for this is the wave of the expectations, the wave of challenges and pressures that come onto the doctors. One of the biggest aspects is data. If we look at some of the way that data is evolving, if we go back to 2010, the amount of healthcare data that existed on the planet back in 2010, this would double approximately every 3.5 years. That's how quickly the healthcare data would double across the planet. Fast forward to today, the speed at which the healthcare data across the planet doubles happens every 73 days. 73 days, that's less than 2 months. So if you think about that, by the time we get to the end of the year, all of the healthcare data on the planet will have doubled, which is a mind-blowing statistic. And where does this come from? Obviously, advances in terms of medical imaging, diagnostic information, all has added to significant amounts of healthcare data. The other aspect is the fact that we walk around today with medical devices attached to us. We wear smartwatches, we've got other types of diagnostic equipment, blood pressure monitors. All of this is widely available in a way that it was not available in the past. And this is adding to that huge amount of healthcare data that now exists within the world. If we look at how this impacts hospitals, the average hospital today generates more than 50 petabytes of data. Now, I don't know if you know what a petabyte is. I had to look it up, but it's a number that starts with a 1 and it has many, many zeros after it. To translate this 50 petabytes into more common means, this is the equivalent of 8 billion books. If you imagine the normal books that we used to read, 8 billion books. That's more books. That's 50 times the number of books that exists within the British Library where I'm from. And to think about that, that's the amount of data that one hospital creates within 1 year, which is just a phenomenal amount of information. And the reality is that there's no way that the hospitals and the medical profession can make use of this data. And so less than 3% of this data actually gets used in any useful fashion to be able to create better clinical decisions or better operational decisions. So 97% of this data is wasted and just is thrown away. And that's just a huge waste, an opportunity missed for us to be able to deliver better healthcare by leveraging this data. The way that we need to do this is to think about how do we combine human intelligence with artificial intelligence. If you think about within healthcare, the most precious resource that exists within healthcare is the human intelligence, the human resources. This will always be the most powerful and most valuable resource. The judgment that a doctor brings, the intimacy and the empathy that they deliver to the patient, these are things that you cannot replicate with a machine. The doctor is always the most valuable part of our overall healthcare infrastructure. The problem is the average doctor spends almost no more than a quarter of their time actually with the patient, and the remaining 75% of their time is actually spent on administration, managing data, managing workflows, all these other aspects. And so that's just a tremendous waste. And at the same time, as we talked about, this data is an abundant resource which is getting bigger and bigger and bigger all the time. And so the only way that we can kind of square this equation out is to be able to combine clinical science with data science. so that we can actually start to make use of this data, leverage it, and use that to be able to enhance and empower the doctors to be able to spend more time with their patients and deliver better care. This is what we mean by precision care. And to get back to the topic, precision care is about leveraging all of this multimodal sources of data and bringing them together into one place to be able to generate better outcomes for patients ultimately. So multimodal data can be many different forms. We know there's medical imaging data. This is a tremendous amount of information that now exists within every single scan. We also have other diagnostic information, blood analysis data, pathology data, EMR information. All of these are widespread data sources which are not used today in a combined way. The other aspect which is now emerging is genomic information. We now can actually look at the DNA of a patient and understand how the DNA would influence the way that a patient is diagnosed and the way a patient is treated. But to do this, you need to have a sophisticated data platform that can aggregate all of these multimodal sources of data and combine them with sophisticated AI algorithms that can then pull out the magical information that exists within all of that data. If we can do that, we can generate what we show on the right-hand side here, which is precision care. And precision care comes in three forms. The first is precision diagnostics. This is about identifying diseases earlier, more accurately, more specifically, so we can actually understand what is the condition and then be able to plan a treatment more effectively. Then we move on to precision therapy, and that's about characterizing the tumor or characterizing the disease more effectively so that we can then apply a much more targeted and focused type of personalized treatment for that individual patient. This is where the DNA typing can be very powerful. You know, not every patient is going to respond to cancer treatment in the same way, but if we can understand what their genotype is like, we can actually modify the way that the therapy is delivered and achieve a better outcome. And then the final one, which is often forgotten, is that looking after a patient and treating a disease is not just about diagnosis and therapy. It's actually as much about the recovery after the therapy. And this is where the monitoring comes in. Today, you may be surprised that the most dangerous place to be in a hospital is the general care ward. 1,000 times more people die in the general care ward and also in the home care setting than they do in the acute care setting. And the reason for that is because of monitoring. If you're in an intensive care or you're in an operating theater, you are hooked up to many, many different devices. But in the general care ward and certainly in the home care environment, you have no monitoring. And so the ability to extend monitoring to a broader range of patients and extend that coverage of care into the general care and into the home care environment allows us to be able to detect if a patient is deteriorating and then take action to be able to help them recover. So this suite is really where we can start to bring in these concepts of precision care in an effective way. To give you some examples, I'm just going to show you a handful of examples to illustrate this. The first is a simple X-ray. So X-rays are done in the average hospital many, many times a day and thousands per year. Often these are done in the middle of the night, 2 o'clock in the morning, when there's not many people around. But actually, this can be looking for life-threatening conditions. One of the most life-threatening conditions could be pneumothorax, or more commonly known as a collapsed lung. This is a very common condition which comes in, but if it happens at 3 o'clock in the morning, there may not be a radiologist available to be able to read the scan and diagnose the collapsed lung. This is where AI can come in. By embedded artificial intelligence engines onto devices and allowing that to be able to operate at the point of care, we can actually start to see these things much more quickly and much more easily. And so if you look at this, this shows the identification of the pneumothorax, the red section on the scan here. And by showing this up to the technician, we can actually highlight this very quickly and then identify that this is an urgent case that needs to be escalated very quickly through to the radiologist to be able to give a diagnosis and then to the clinicians to be able to drive the treatment. Things like this are very simple. Just brings a flag to the technician's mind so they actually can tag this as an urgent case and then get the treatment that's needed. This is where AI can really enhance the doctor and speed up those workflows in an effective way. A different area of medicine which is now emerging is something called theranostics. And theranostics is a combination of therapeutics and diagnostics. And this is a very early stage form of medicine that is starting to come through. What this does and how this works is to use a radioactive drug, a radioactive tracer, first of all, that is put inside the body and searches out for cancer molecules by having receptors which latch on to the cancer molecule and then having a radioactive emitter that can show up where the cancer is on a PET CT scan. By modifying the tracer and then using a similar but slightly different version of the same molecule, you can actually then treat the cancer. So you then inject a second tracer into the body, which is carrying a radioactive payload. And this payload searches out, finds the cancer, and then delivers the payload directly to the cancer cells. You know, something that really does sound like science fiction, but is something that is now available. And if you look at the bottom part, this is part of what the prostate cancer workflow is starting to evolve into, using a drug called PSMA, prostate-specific membrane antigen. To show how this works in practice, I'll just show you the images. So if we look at this, this is a scan of a patient that has metastatic prostate cancer. So this has been identified using the first radioactive tracer, which is gallium PSMA. And you can see the black dots on this picture is really the cancer. So you can see the cancer is all over this gentleman's body. It's really not a very good condition for the patient. But the magic comes in after less than 3 cycles of the second dose, which is lutetium PSMA. You start to see the black dots evaporate. And so as we get through to the second cycle, and then to the third cycle, and then to the follow-up, literally less than 9 months later, the cancer has disappeared. Which truly is a magical and phenomenal outcome, that with a cycle of using this new strain of medicine called theranostics, you can actually cure prostate cancer in this case. So this is really one of the amazing things that is coming out into the future and really shows what the future of healthcare could look like. Obviously, this is something that needs to be further developed and further tested. It doesn't work for every patient, but it shows the possibilities of how advances in medicine, advances in healthcare can really develop this personalized medicine approach and transform lives in a really amazing way. If we go to a bit more to the primary care end, you know, some of the big advances that take place in healthcare is things like handheld ultrasound. Now today, a handheld ultrasound, which I actually happen to carry in my pocket today, this has the power of an ultrasound machine that would have been almost the size of a fridge less than 10 years ago. But you can fit it all into something that is this small. Think about what that could mean in terms of primary health, being able to give remote services to patients. You know, if we think about midwives in remote areas, the number of patients who could be saved, the number of mothers, the number of babies. This is the scan of a baby, which you can see here. And if you look on the left-hand side, this is a scan of the heart of the baby inside the mother's womb, just using a device like this. And think about that, which rather than having the mother have to come into the hospital to do a scan like this, and we have a doctor who is traveling around carrying a device like this to be able to do that type of scan, think of the amount of possibilities that that exposes and that brings in terms of how we can treat medicine more effectively. You know, the image that most people think about when they think about a doctor is a stethoscope around the neck. The stethoscope is something you can only hear with. This is something you can see with. You can actually see what is taking place inside the body. And so in 10 years' time, in 20 years' time, maybe this will become the thing that everybody recognizes and associates with a doctor into the future. If I talk about another example, ECGs, something which is a really, in the past, has been a fairly complex procedure. You have to have a 12-lead ECG connected to different parts of the body. It takes a long time. You have to have a fairly significant machine next to you to be able to do that. Today, using something as small as this, literally as smaller than a credit card, you can get a high-quality 6-lead ECG, medical grade, capability, which can be done at home. I could do it now on the stage here. We could do it anywhere in the world. And just by putting this onto your body and then putting your thumbs onto it, this can take a high-quality ECG trace. This can be added into the cloud to be read either by an artificial intelligence engine initially and then forwarded on to a clinician for follow-up. Think about the number of people who have cardiac conditions which are never diagnosed. Think about if we could do this once a week or once a month. This would be able to identify issues which kill people every single day. And so advances like this, which literally fit inside my pocket, these are things which you can really see coming through as part of the future of healthcare. So a lot of science fiction is now coming into the world. This is really tremendous aspects which are going to transform the way that we deliver healthcare into the future. And then we think about the enterprise. Some of the aspects within hospitals is we forget about the fact that a hospital is a very complex operation with very significant resources that have to be managed and actually led in a very effective way. By using things like the command center, wall of analytics with AI algorithms built in, we can not only identify where our resources are being used within the hospital, we can actually evaluate when they become overwhelmed. We can look at, for example, critical care beds. When are the critical care beds going to become overutilized? Or when are we going to have a shortage of staff? Or when do we need to be able to have an additional capability to be able to bring in more people into the operating theater? By having walls of analytics which operate a bit like a control tower in an airport. You know, we wouldn't run an airport without having sophisticated analytics. Now we can bring these types of capabilities in which allow us to be able to run the hospital and run the operation, or even run an entire hospital network in a much more effective and efficient manner. And this leads to, key benefits like reducing reducing length of stay, reducing overall costs, increasing the efficiency of the hospital, also improving staff satisfaction. One of the big advantages that I've heard from many clients is that, you can actually create calmness and create a more structured and organized way of operating, and that actually gives more freedom and empowerment to the staff and a better working environment for people to live in. Particularly when we think about those statistics about people leaving the profession and not wanting to come into healthcare, how do we make a much more enjoyable environment for people to come and work in? And so things like this allow us to meet many different objectives and aims throughout this process. So with all these advances in artificial intelligence, and thinking back to my picture of the robot connecting the prosthetic hand to Luke Skywalker, does this mean the end of doctors? That's obviously a big concern for many people in the medical profession, that the AI will replace doctors. I think the answer to that is very clear, though, from my point of view. As I said before, the most important thing in healthcare and the most valuable resource will always be the human. It will always be the human interactions. And there is no way that a computer or a machine can replace that. And we don't want to. This is not about replacing the doctors. This is about enhancing doctors. If you think about in many different walks of lives, think about pilots flying a plane. Today, a plane can happily take off, land, fly without any human intervention. But who's going to fly in a plane without a pilot? That's the same thing in healthcare. We don't expect that to happen. We expect the AI to augment and enhance the doctors and to free up their time. If you think about that 25% of time that they spend with the patient, how do we make that 50%? How do we make that 75%? That's where the AI can really enhance and support doctors. So no, AI does not mean the end for doctors, but doctors who embrace AI and add that into their workflow may replace those doctors that don't, which is maybe a more interesting question. So in terms of the future of healthcare, I think the next 20 years, the next 50 years is going to be a tremendously exciting time. We see an acceleration of technology. We see significant challenges in healthcare that need to be solved. We see a convergence of technologies all coming together, and the AI and the computing power really enhances this and accelerates some of those trends. To make the most of this, though, we have to develop a collaborative ecosystem. You know, it's not about one player who can make this work. This is a combination of technology companies, healthcare providers, ministries of health, technology firms, software providers, universities. All of these different players need to come together and work as a collaborative ecosystem. If we can do that, and we can work together to get the best out of the technology and use it to enhance healthcare, we can really drive better outcomes, lower costs, and ultimately save more lives. And if we can do that together, it's really about creating a world where healthcare has no limits. And so thank you so much for listening. I really look forward to working together, and enjoy the rest of the day. Thank you so much.
Thank you for Mr. Rabb for his speech. And now we're going to have fireside chat roadmap to AMR 2024. And the host is Mr. Rakan bin Duhaish. He is Assistant Deputy Minister for International Collaborations, Ministry of Health, KSA.
The seats. السلام عليكم ورحمة الله وبركاته. شرف بالحضور معاكم اليوم. اسمي راكان بن دهيش، الوكيل المساعد للتعاون الدولي في وزارة الصحة. Ladies and gentlemen, good morning. It is a pleasure to be here with you, and I, in fact, have a special guest who I will be hosting today, Professor Hanan Balkhi of Pediatrics and Patient Safety, who is a special in AMR and have done so much to humanity. So it is a pleasure for me to welcome Dr. Hanan, please.
Assalamu alaikum. Thank you. Assalamu alaikum. Thank you, Rakan. Assalamu alaikum, everybody.
Dr. Hanan, perhaps this time is even more special because you've been elected as a regional director for the Emru region, which will be adding, inshallah, so much to the kingdom and, in fact, to the region as well. So this is a great achievement, and congratulations for that. And I will also, give you maybe some time to educate us on AMR and how we're going to move on that. But perhaps before that, if you can just give us a few remarks on your background.
Thank you, Rakan. And it's a great pleasure to be with colleagues and friends and people whom I've known for many, many years. And congratulations, Dr. Reem, on this amazing event and the whole organizing group that has put a lot of effort into this. So I'm a pediatric infectious diseases by training. So I'm a doctor. And then I trained in infectious diseases after my pediatric subspecialty. Both were done in the US. And when I came back to Saudi Arabia in 1999, I immediately jumped in on the bandwagon of infection prevention and control. And that gave me a bigger perspective about prevention of disease. So not just being a physician treating one patient at a time, but I was immediately starting to develop programs that prevent disease transmission within the healthcare setting. And also it had a major arm in educating the population at a bigger perspective on how to prevent disease transmission. And then when the National Guard developed its research center, I started my research in antimicrobial resistance. So that put me on the path of AMR, where I started looking into the genetic makeup of certain bacteria and the transmission in healthcare setting. And then I became Assistant Director General of AMR, as you know, and here I am.
MashaAllah, this is an impressive career and will benefit from this, inshallah. When I started working with Dr. Hanan maybe 2 years ago, the first day we were talking about antimicrobial resistance. And when she started to explain what is antimicrobial resistant, and I was telling her, well, before I joined health ministry, I used to work in finance. And augmentin was something that I would just take it out of the counter and take it. And she was saying, no, this is the biggest problem, which is awareness, because I was not aware of how antimicrobial is dangerous to your health, to humanity, and even to animal and agriculture. So, Dr. Hanan, if you can describe to us why we're taking so much efforts for antimicrobial resistance fight, and how we're going to move forward on that. But before that, perhaps if you can describe antimicrobial resistance and why it is an urgent crisis.
Thank you, Rakan. And you just reminded me of that conversation, and I remember you were very upset because you said nobody told me. So I think that that's where we have to come together as a whole community, from the human sector, the animal sector, the public health, and it's not just the subspecialized individuals in my field that need to be aware. Every person is accountable to be a champion on this specific topic. But going back so that we don't misunderstand the issue of antibiotics. Antibiotics are what we call them are global goods. We need them. So modern medicine would not be capable of doing the very complex procedures that we do today if we did not have antibiotic. We would not be able to do transplant surgeries. We would not be able to do implants. We would not be able to do open cardiac surgery. So those are the complex ones. But also, there's a lot of people who are dying around the world because they don't have access to antibiotics. So it's two sides of the same coin. Some people are overusing antibiotics, and some people have no access to antibiotics. So in the agenda that is led by the World Health Organization, not only do we want to make sure that antibiotics are used judiciously in the right way so that resistance doesn't develop, we want to make sure also in our agenda that access to affordable, effective antibiotics are good. So that's what antibiotics are. Now, what is antimicrobial resistance? Antimicrobial resistance is a phenomena. It's not a disease like HIV, TB, or malaria. It's a phenomena similar to the climate change, where you have a lot of issues leading to antimicrobial resistance, and a lot of efforts are needed to mitigate antimicrobial resistance. Basically, we're describing bacteria that are sitting on our skin, in our nasopharynx, in our gut, that we can acquire from other people that can develop resistant genes, and they become no longer responsive to the antibiotics, and then those bacteria can potentially lead to severe infection, sepsis. In Arabic, we call it at-tasammum. It can lead to focal infections. It can lead to an infection in any part of the human body. So if we overuse it, we're telling the bacteria, be careful, we want to kill you. But the bacteria is one cell, and that one cell has one mission, survival. And they have a very simple genetic makeup that they are capable, once exposed to an antibiotic, they develop more smart tools within their genetic armamentarium, and they say, no, we're not going to get killed. Now, the scary thing, Rakan, is that bacteria existed before humanity, and most likely they're going to exist after humanity. So we have a big task ahead of us to try to sustain effective antibiotics to treat patients. But at the same time, we need to be aware that this has to be done in a holistic approach.
Well, this is very good point, holistic approach, because from my finance background, economic assessment, I was struck by how much effect this antimicrobial hidden crisis can have on humanity. So when we read more about it, we go into a concept of One Health. So this concept, One Health, could compromise of many areas. So it is not only the health of human.
Yes.
So how would antimicrobial be used in other sectors, and how international organizations and organizations who are responsible for this file would work together?
Excellent. That's a great question. And the One Health approach has been an area that needs to be done in all diseases where transmission occurs between what we call it, the animal-human interface. We're not ever going to put a very clear brick wall between animals and humans. We're always going to be interacting together. We need animal sector also to produce food so that we can sustain humanity. Now, the economical benefit of antimicrobials are huge because in the animal sector, in the agriculture sector, they use antibiotics to sustain the economy, to sustain the animal production and that area of work. However, at the same time, sometimes it's used to compensate for lack of hygiene because antibiotics are going to treat infections. So imagine if you have a huge farm of chicken. Is it easier for you to maintain the hygiene of that chicken farm, or is it easier for you to feed those chicken with a lot of antibiotics so that regardless of the level of hygiene, you're going to sustain that outcome of your farm? And the same is also can be said for the fishery industry. The fish industry uses huge amounts of antibiotics. Another industry where they actually spray the farms of, for example, citrus agriculture. And sometimes it's not even said that we're using antibiotics. It's said that we're using pesticides. So the pesticides, within it is hidden the antibiotics. The growth promotion to feed up and produce more meat or has hormones and has antibiotics. So what our agenda is in working with the different organizations like FAO, WOA, and UNEP is to make sure that there's this bigger concept of understanding the relevance of antibiotics for the human health and also for treating sick animals, but not for growth promotion and not for blindly compensating for lack of hygiene. Then you can ask me, we have UNEP, which is environment. How does the environment cycle into all of this? If you look at the pharmaceutical companies where they produce antibiotics, what we call it the effluent, al-mukhrajat of these pharmaceutical companies, goes into the environment. If these companies don't have very clear indicators and KPIs and quality measures to make sure that the disposal of their effluents into the environment is controlled, then you're exposing the environment to antibiotics. Animals drink the water contaminated by those antibiotics. They develop resistant bacteria. We as humans are in touch again with the animals, and then we acquire these bacteria again. So the circle between humans, animals, environment, and water is continuous. And the exposure to antibiotics, whether you know that you're being exposed, you started the discussion by you taking something you're not aware of. But there are times where you're eating potentially meat or fruits or vegetables that has small quantities of antibiotics in it, and without knowing it, you're creating resistance of your own bacteria. And that's why we say, I lose attention of people usually when we talk about this, because then it gets complex, right? It's like, okay, this is a very long story, it's too complex, let's not go there. And that's why I'm extremely happy that the Kingdom of Saudi Arabia and yourself, you've given yourself a lot of time to learn about this topic, and I think you're doing a phenomenal job, Rakan.
Well, thank you very much. This is a very good explanation. So, from my collection, I think that there is more use of antibiotics in agriculture and animal sector than the human sector.
True.
So the awareness should be more inclusive into this sector. I think 70% perhaps
True.
is used by animal and agriculture sector.
Absolutely.
So what we should do now, and perhaps maybe you can answer this by the role of yourself at the WHO, and how you work with the other international organization on animal and health and agriculture organizations to promote this awareness and to promote this understanding and make us or guide us toward the right approach for antimicrobial resistance.
Thank you, thank you. Again, a great question. So now diving a little bit deeper into what we're actually doing as organizations. So you did say you quoted the accurate percentage. 70% of antibiotics produced globally are used in the animal sector. And some of them are used, as I said, under another name, pesticides or growth promotion. Now, what we've done very solidly over the past few years is that we have been working much closer with these organizations. First of all, to create an alliance. that we as the human health sector, we're not against the other sectors. We're not against the economical growth. We're not against meat production and food production. In fact, we need that. However, the production of antibiotics has not been segregated to say that antibiotic A, B, C, those are for the human sector, and E, F, G are for the animal sector. In fact, that's unfortunately not the case. The antibiotics that are being produced for humans are the same ones that are being used for the animals and the plant sector. And the first thing that we've done is that we've revised with the other sectors the priority list of antibiotics to say that these are the priority lists A, B, C, for example, and we said these are the antibiotics that we do not want them to be used in the animal sector. So we preserve them for the human health. In a way, we want to take care of animals as well. Animals, when they get sick, like humans, like any living being, they need to be treated. But why don't we decide that we will treat them with antibiotics, that I don't lose them and to use them in the human sector? So that's one of the big achievements that we've done over the past few years. We've consolidated our work together. We've identified the priority list. And in the Oman conference, we created targets to start weaning within each country. Now they have to do this exercise. They need to wean the animals and stop using the critical and important antibiotics for human health and stop using them in the animal health. The other big achievement that we've done with the other sectors is that we had the first joint regulatory summit. The regulators, like the FDAs, of the human health and the regulators of the animal health. And interestingly enough, we've learned that the regulators of the two sectors sometimes don't even talk to each other. And each country has a different regulatory process in regulating medicines. So we sat with them, and we did this earlier this year, where we created one agenda item at a time, which is over-the-counter dispensing of antibiotics. And we're going to be working more robustly with them in a way to say that we cannot give antibiotics without a prescription. And the same thing with the animal sector. The animal sector, as the human sector, suffers from the lack of the numbers of veterinarians that are capable of treating and diagnosing the animals. So I think there's a lot of work that needs to be done in the other sectors to ensure that the qualified specialists who can do this work are actually available. So these are two important examples where the four sectors work together.
Well, this is fantastic. And also from my understanding that the WHO would issue some sort of guidance for this. And one example is the National Action Plan, right? And those action plans are implemented by national authorities like the Saudi Wiqaya, the Saudi CDC, or the Public Health Authority, who is doing a phenomenal job in implementing this. And in fact, I think Saudi Arabia is one of the countries who have fully implemented the national action plans on that. So if you can tell us now, for nations, how would they be comfortable in adopting these guidance by the WHO, and how we can take it forward, into implementation?
Yes, that's a great question, and I think the world has started to pay more attention to AMR probably in 2015, 2014. There was the first AMR ministerial conference that led to a resolution at the WHO leading to the Global Action Plan. A year later, there started to become a lot of work in putting the national action plans to be extrapolated from the Global Action Plan. And as you correctly said, Saudi Arabia came out with their second edition of their National Action Plan. We have around over 160 countries that already have a National Action Plan. Our problem, though, is that we actually evaluate National Action Plans. It could be a very generic guide that is not being used, and it's just, ticking a box, we have a National Action Plan. Or it can have times and targets and costed and financing, which is the highest level that we want to achieve with each country, that the National Action Plan has its governance, it has its accountability, but it's also financed so that they can implement what is placed in the National Action Plan. And one of the things that I'm proud of Saudi Arabia, among a few other countries, is that they created الصحة في جميع السياسات, policy in all, health in all policies, or for all policies. And that's extremely important because we go back to the other sectors that they have to be accountable for stopping antibiotics in animals and increasing and improving biosecurity and hygiene in the animal sector. So that's very important. What we would wish for the member states to do is to make sure that they, when they do create their national action plan, they create it based on their country needs, and then they put their targets, and then they end up financing it. And that's what we do through our regional offices and our country offices, where we sit with these multi-sectoral committees, we sit with those who are empowered to do so, and it's usually the health minister that's the driver behind this. What I would aspire to have is that the ministers responsible for the different sectors share the same passion towards mitigating antimicrobial resistance for us to continue to have a safe life for animals and for humans.
This is a very important point because not even in a national level, it should be an international action plan and an international move. You know, the kingdom is involved in many of those international discussions from policy perspective, discussing future pandemics and how we can prepare and mitigate future pandemics. And AMR is, in fact, getting more attraction and creating momentum. So how we can make sure that this agenda is live internationally, and who are the major players when it comes to AMR internationally, so we can make sure that there are policy directions toward the implementation of AMR.
Thank you, Rakan. That's also a critical question. I think the big players in antimicrobial resistance, and that's where it was thought that it is more of a high-income country problem, because they're the ones who in their hospitals can identify resistant genes. They're capable to identify healthcare-associated infections. But the IHME, the International Health Metrics Institute, had produced the global burden of AMR, and we know that now antimicrobial resistance is a problem of high and low and mid-income countries. So the bigger players used to be the Western countries, maybe Japan also, Malaysia, Thailand. But I think when I'm sitting in my position now in Geneva and I have my meetings with all types of member states, they're all concerned, but they're all not knowing how to proceed with addressing this very, very complex problem. So what has happened over the past few years is that the member states have come together since 2015 with the national action plans. Then there was a United Nations resolution in 2016 for the IACG, which you're also familiar with. But it's a lot of political movement. We established the Global Leaders Group also for antimicrobial resistance to continue to bang on the AMR agenda so that we do not forget about it. It's easily to be dropped off. Now, the things that have taken place that are a bit more promising, as you probably know, I think you and other colleagues from Saudi Arabia sit on the international or the governmental body, the INB, to discuss for a pandemic treaty. And you've seen how complex it is to include the AMR agenda within the pandemic preparedness and response. But I think the member states, and Saudi Arabia is one of them, are doing a phenomenal job in ensuring that the different bits and pieces to manage AMR are included in the pandemic treaty. That's going to be very, very important. The other thing is that member states have also asked for the AMR to be on the EB agenda. And now, as happened this year, we're looking forward to the UNGA meeting in September 2024, where there will be a high-level meeting. We would love for us to have, we dream in AMR, to have a civil movement on antimicrobial resistance, the same thing that happened during HIV/AIDS, the same thing that would have happened during TB or polio or during COVID. However, what we're missing in AMR is that you don't have a specific face for AMR. As a clinician, I'm a doctor who dealt with almost every infectious disease type of patient. I've seen what an HIV patient looks like. I've seen what a polio patient looks like. And you can put those pictures on a poster and start advocating to get rid of polio, to get rid of smallpox. But with antimicrobial resistance, you don't have a specific face that you can say, this is what AMR looks like. Because when I try to tell you what does AMR look like, it is a urinary tract infection, it is a bloodstream infection. So then again, I lose the audience. So what we're trying to do is for the 2024 high-level meeting, we're hoping that the member states in developing the resolution will start putting a very explicit language in the resolution that talks about commitments and targets. Because we can do a lot of talk, we can produce a lot of national action plans, but if we are not committed to empower infection prevention and control in hospitals, infections continue to spread. If we do not commit to getting rid of antibiotics as a growth promoter, then the pharma industry, the animal industry will continue to use antibiotics in the meat production, for example. So we need commitments, we need targets, and we need governance and accountability, not only by the ministries of health, but by the ministries of health, environment, water, agriculture. And we need the public, the community, to challenge their doctors a little bit. I'm very worried sometimes if we label antibiotics as a dangerous medicine, because there are times where a patient needs to take an antibiotic. But what I would love for patients to do is to challenge their doctors, do I really need this antibiotic? So there's a few things in the public education. Number one, doctor, do I need it? And if I do need it, then I should get it and complete the full course. And please do not share your antibiotics with family and friends. So those are very, very important things. Now, another thing that we've seen with patients sometimes is that if my doctor does not give me an antibiotic, I'll go to another doctor. And we call that doctor shopping. And that's, because if a patient is convinced that they need an antibiotic, it becomes difficult to convince them. So I moved from the political agenda and how we need to move forward. How can we educate also our community? But for the resolution, and again, I'm sure you're going to, and I would want to ask you about, not only do we have a high-level meeting on AMR, but I'm extremely excited and thankful to the Kingdom of Saudi Arabia for actually hosting the 4th Ministerial Conference in AMR. And I'm very keen to learn more about your preparations for this conference. I'm sure we're going to be working even closer together during the next year or so, even as a regional director. But what have been your preparations? And maybe we can hear a little bit more about that.
Well, thank you very much for this question. And I think the driver is actually what you mentioned about the risks. So it is disease spread, it is severe illness that would lead to death. So it is basically a bottleneck. After all these discoveries in health and how you can do transplant or whatever, and then eventually your body is not receiving this, right? Because of antimicrobial, if my understanding is correct.
They will get an infection and then those surgeries potentially fail.
So,
yes.
So the cure is here and everything is here, but your body is resistant to that. So this is where we got so engaged in the discussion on AMR. And to your question, Saudi Arabia is going to host the AMR high-level conference in November 2024 here in Saudi Arabia, and we're working a lot with the international community and also local authorities in making sure that we have the right priorities for this discussion and ending up with a manifesto that will lead to more concrete actions, and also building on the discussion that have taken place. Oman have hosted this conference in 2024 and resulted with targets that we are implementing. So therefore, we started to work on this momentum. We hosted a side event in Geneva in the last WHA, the World Health assembly meeting where we got attendance by international organizations and experts from around the globe. And we're working on many of these side events and meetings in order to make sure that we talk with colleagues who follow the GLG, for example, the Global Leader Group, where they have even highlighted number of priorities, including political actions and transfer of human, transformation of the human and animal and agriculture, as well financial resources and innovation across all sectors. So those international organizations need to get together with experts, need to get together in many iterations to eventually end up with a resolution, hopefully on AMR and even at the UN high-level meeting as well. The kingdom is very strong and keen into that, and I would thank the Minister of Health on his push and strong commitment on that. So hopefully we will see you again in many of these occasions, and with your help and support, hopefully in your new role as well as a regional director for the Emru region.
Thank you, Rakan. Thank you very much. And indeed, sincere thanks to the leadership of His Excellency, and thank you for joining us as well. We are, as the WHO, we're very keen to, for me now in my new role as regional director and during the election, maybe I'll reveal a little bit of what happened, is some of the countries, even though this is considered one of the most problematic and challenging regions of the 6 WHO regions, I am very impressed by the member states' dedication to continue to build on the health systems and to make sure that their health systems are resilient. And embedded within that is how are they going to be supporting the One Health agenda, which AMR is one of many One Health agendas. So I am very keen to put all the efforts, and I look forward to the Kingdom of Saudi Arabia to be a role model country. My country needs to be, no pressure, but my country needs to be the role model country on One Health, inshallah, and I will do whatever I can to work with you and with all of our member states to make that a reality. So thank you very much.
Thank you very much for being here, and thank you very much, and please inform your relatives and your friends on the AMR issues and how it is very complex issues, and seek advice. Thank you, Dr. Hanan, for being with us here, and thank you everyone for your attendance.
Thank you so much. Thank you.
For Mr. Rakan and Dr. Hanan for their speech, and session 7 is starting, Designing for the Future of Health and Medicine. Where can technology take us? The speaker is Dr. Daniel Kraft, founder of NextMed, Health and Digital.Health, Chair, XPRIZE Health Alliance, Managing Partner, Continuum Health Ventures. Please welcome Dr. Daniel.
Shukran. Thank you very, very much. It's a real honor and privilege to be here. It's my very first time in Saudi Arabia. It's incredible to see the vision, the innovation, and all the convergence of mindsets coming to bring us the future of health and medicine around the planet. And of course, you know, health and medicine in the future, and even today, is becoming much more digital, much more super connected, hopefully more intelligent, data-driven, more precise, more proactive and preventative. And the technologies we see all around us will make healthcare much more democratized and available, not just here in the MENA region, but around the planet. And take us from a world of where we are today, truly still sick care, very much based on intermittent episodic data that's quite reactive, to a future of health and medicine that's much more continuous, personalized, proactive, anytime, anywhere. So I woke up this morning a little bit jet lagged because I came from Silicon Valley, from California, and I did a little bit of art about the future of health here in Saudi and beyond. And of course, I didn't really do that art. I'm not a very good artist. I had some help from our friends at ChatGPT-4 and DALL-E 3. And it's just an example of how these fast-moving technologies can upskill all of us, whether it's to be better artists or better clinicians or even better patients. And of course, technologies like ChatGPT-4 are moving faster than almost any technology on the planet, sometimes faster than our ability to keep up with their abilities, the regulatory, the reimbursement, the ethical implications. So it's our opportunity to see these technologies and move them into the future, because patients are doing it already. Parents, for example, who cannot make the diagnosis for their children after going to 17 different specialists are using ChatGPT to find the diagnosis. Or where I trained at Mass General Hospital in Boston and Boston Children's, or at Stanford, we're starting to hire prompt engineers to integrate ChatGPT into our clinical workflows. And of course, it's still very early times for AI in healthcare. It still can make mistakes. It sometimes has the wrong information. But let's just leap forward a couple of years. It's going to be quite incredible. And even today, as you've seen here at this incredible gathering, we can use generative AI to help us with better communications with our patients, to collect information, to get rid of the friction across healthcare. And I see not just an age of generative AI, but of generative health. Imagine each of us has a personalized health engine, a personal cobot that can help us with our prevention, our wellness, our diagnostics, and our therapy, bringing us to a true era of precision digital health, integrating these new tools. Now, of course, health is wealth, right? We've seen many technologies accelerate over the last 10, 20 years that when they come together, really are giving us an opportunity to rethink healthcare. Back in 2011, I gave my second TED Talk, The Future of Medicine. There's an app for that. And back in 2011, there were only about 10 or 15,000 health apps. Now there are maybe 300,000 health apps. But the theme of that TED Talk, and even of today, is that the future of medicine is not based on any one technology, but the convergence of technologies getting faster, better, cheaper, more available, kind of super converging to give us the opportunity to move things in entirely almost magical ways, right? What used to fit on your desktop computer in 2000, that fits in your smartwatch, which is now FDA cleared and can detect a fall or connect a heart challenge. And so at the bridge of technology in healthcare, we have entirely new tool sets that didn't exist 20 years ago when I was a Stanford medical student, whether it's computational biology or low-cost sequencing or AI meets radiology or robotic surgery or digital therapeutics. These give us new tools to rethink and reimagine healthcare here in Saudi Arabia and the region and around the world. And so my challenge to you is to not have a failure of imagination, but to skate to where the possibilities will be. And of course, it's not just about thinking about the sick care side of the equation. As we'll hear in the next panel, we want to be thinking about longevity and health span. You know, some of us want to live to 120, but we don't want to feel 120. So it's more about quality of life years than just extending our years. In fact, a few months ago, here's my son when he's 6 years old, holding the hand of his 104-year-old grandmother. 98 years difference between them. And a lot of the reason that she's had a long, healthy life is the social determinants of health that have given her a long quality of life. So I think it is an exciting age, not just to think about sick care, but health care and extending our health span and longevity. And the science is just beginning really exciting to bring us into that era. Now, while technology, of course, is important to our health span and our health, we know that it's our social determinants that are more important. Where we live, our zip code is more important than our genetic code. So we need to pay attention to those core social determinants: education, food, diet, social connection, vaccines, some of the basic elements of health. And of course, today we live in this digital age. We all need Wi-Fi, we all need battery life. We need to think about the digital determinants. Can we now provide everybody with high-speed internet and quality connection? Now, we are in the future, 2023, but when I go back and visit Mass General Hospital or Stanford Medical School, where I trained, we're still often using old school technologies, fax machines to communicate between the pharmacy or to public health officials, paper forms filled out for the 100th time. I had my own cardiac study done at Stanford a few weeks ago. I got my results on a CD-ROM. I don't even own a CD-ROM player anymore. So we're sometimes still building our healthcare on the old technology stacks. We're also not practicing precision medicine like we like to. For the top 10 grossing drugs sold in the United States last year, they're only effective for about 1 in 4 to 1 in 24 of the patients who take them. So a long way to go to precision medicine. And we're still basing our healthcare thinking in old-fashioned silos. How we design our medical schools, our pharma companies, our medical departments are based on sometimes body parts and anatomy when we're today in this connected exponential biologic age. So it's our opportunity, particularly with the great leadership and mindset in this room, in this meeting, to start to connect the dots, unsilo healthcare, and create integrated biomedical knowledge that can be shared around the planet almost instantly. So we've seen many fields get disrupted over the last 10, 20 years, from digital banking to digital entertainment, and we've seen them reach the fourth industrial age. We've also seen a great disruption over the last 4 years from the horrible COVID-19 pandemic, which kind of forced us to see that while many fields had reached this fourth industrial age, health and medicine was often stuck in the third or maybe the second industrial age. And so I'm an optimist. I like to see the opportunities that COVID bring for better telemedicine, vaccines, clinical trials as a bit of a catalyst. So just like Sputnik set off the space age, COVID has sparked a bit of a new health age, and we need to take some of the energy and the urgency of innovation that we developed through the pandemic into the next generation. So just last year, I gave another TED Talk, how COVID-19 had transformed the future of medicine, and it gave me an opportunity to look back at that TED Talk from 2011, the TED Talk from 2021, and go, where were we 10 years ago? Where are we now? And where could we be in the next decade ahead? Because the next 10 years will be pretty amazing. I love this quote from Bill Gates. Most people tend to overestimate what they can do in 1 year and underestimate what they can do in 10 years. So we really need to have that 10-year view. I love the Saudi 2030 vision because it brings us forward into this new era, leveraging some of these new tools and technologies. Now, I've been a bit of an accidental futurist. I'm a medical doctor. I'm a hematologist, oncologist. I've been the chair of medicine for something called Singularity University. And for the last 12 years, I've run a program that looks at the convergence of technology in healthcare called Exponential Medicine. It's now called NextMed Health, where we bring together folks from 40 different countries to San Diego every year to look at this interface, to learn from each other, to catalyze new thinking. Because often it's not about the new ideas, it's about escaping them. I love this quote from the head of innovation from National Health Service. It's this old quote, yes, the difficulty lies not in the new ideas, but escaping from the old ones. There's a lot of new ideas here in this room and in our minds. Sometimes our colleagues are still stuck in the past, and we need to bring them along with us into this new health age. So let's look 10 years back, where we are now and where we're going next. 10 years ago, we started to have genomics. Of course, we've had it for 20 years. 10 years ago, a human genome cost about 10,000 US dollars. Now in 2023, it's about 100 to 200 US dollars. In a decade, that might be $10. And we're already seeing here in Saudi and beyond the ability to take our genomics and use that in useful ways. For example, pharmacogenetics, to pick the right drug to match the patient, their other genetics, and the right medications to select. We're seeing examples here in Genomics England to connect the data between individual patients and research so the clinician, the nurse, the pharmacist can use genetic information in real time. And a decade from now, we'll be able to do almost real-time genomics. My colleagues at Stanford can now do a full genome in under 5 hours. So we're going to see the real integration of not just genomics, but many other fields of information. And very common diseases like type 2 diabetes won't just be diabetes, it's going to be at least one of 3 or more distinct genetic subtypes. So we'll learn how to manage patients by their genetic subtype of diabetes using the right medications, exercise, and food as medicine. Now, of course, we're not just in the era of reading DNA, we're in the era of writing DNA, the era of synthetic biology. And that's bringing us this age of CRISPR and the ability to edit genes. We're seeing the first examples of curing things like sickle cell disease, thalassemia, maybe even diseases like HIV. And so we're going to see in the next decade, these become commonplace across the spectrum. In many cases, we may use genetic therapy to treat the patient before they even have the disease. Now, while genomics are in the exponential, we also have low-cost proteome, the exposome, our metabolomics can be measured. Of course, the microbiome, the bugs on our skin and our gut, play a huge role in everything from obesity to diabetes to mental health to cancer risk. And we're going to start to integrate these. We heard earlier today about synthesis and convergence. It's not about any one genomic information set. It's about how we mash them together to build that sort of future digital twin. So each of us and each of our patients and each of our communities will have a digital twin that can be simulated so we can optimize prevention, diagnostics, and therapy. It might be a digital twin of your heart from a diagnostic angiogram, so you can predict the heart flow and whether a patient needs a stent and what kind of stent. Maybe we'll 3D print the stent to truly personalize that therapy. In my world of oncology, we're now having so much data, we need to build the cancer patient digital twin to help me as an oncologist truly manage precise oncology. So these things are coming fast and furious. We live in this now exponential age. And our brains are used to thinking linearly, but it's sometimes hard to appreciate the pace of exponential change. We, of course, all know that the favorite exponential technology, Moore's Law, the power of computing, which is why our smartphones have much more power than a Cray supercomputer from the 1990s. And it's that exponential power that has now taken these technologies that used to be massive and in big pieces that now are become appified. They become digitized, dematerialized, demonetized, and disruptively dematerialized, meaning we can spread our digital tools around the planet in healthcare and beyond at the press of a button. You don't buy a GPS unit anymore or a video camera. They're integrated into our app store. And of course, even while Moore's Law might be ending its reign, quantum computing is coming next, which will play a huge role in making sense of our digital biomarkers and designing next-level drugs. So let's go back to our favorite exponential technology, the smartphone. It has moved remarkably quickly. I didn't get my first cell phone until I was in my 20s. Now every child almost has a digital phone or a wearable device. And of course, these phones are starting to dissolve into our vision, right? The Apple Vision is coming out next year, I think. And that's going to give us the ability to see our environments in whole new ways. In fact, soon on the exponential, our digital tools and vision will shrink into digital contact lenses, and we'll be able to have augmented reality wherever we might go, which will give us new insights as clinicians and as patients. And that brings us to this age of augmented, virtual, and extended reality. 10 years ago, we still had Google Glass. They weren't a great commercial hit. These are very old-fashioned today. But already today, we can take these sorts of augmented reality tools and help the surgeon or the radiologist take very complex information and make it actionable, understandable. While helping surgeons go step by step through a procedure where they can see through their patients and do a smarter job of a surgery, less invasively with better outcomes. And increasingly, these almost feel like magic. We're starting to crowdsource data and insights to help almost any surgeon be upskilled to be an expert surgeon. We can also use augmented reality tools to educate ourselves and our children. When they can see inside their body and understand and appreciate their own physiology, that gives them a new insight into staying healthy. Here's my son Leo wearing his augmented reality t-shirt. He knows his basic heart physiology and lung physiology, and hopefully he'll never smoke or have unhealthy behaviors. So augmented reality is a tool for education. Augmented reality is also something we use in another field that has lessons for healthcare, aviation. I've been a pilot since I was 18. I've been a flight surgeon in F-15 and F-16 squadrons. We use augmented reality in the cockpit. We have the heads-up display. So as a fighter pilot, you're not buried looking at the round dials. You can see outside the cockpit where the bad guy is, who's shooting at you, right? And also the cockpit can talk to you and give you early warning if you're flying too low and about to hit a mountain. It will kind of wake you up. Cool. That's a good clue, right? Imagine we use augmented and virtual reality in our contact lenses of the future for the patient to see their breakfast in one way and maybe now in another way, and then they get another clue, right? Cool. So these will kind of guide our behaviors going forward. So we have lessons from aviation, checklists, crew resource management. I started flying with a round dials and a paper map in a 1970 Cessna 150. Today I fly in a composite airplane with a glass cockpit with touchscreen GPS that gives me instant weather, instant information about who's flying around me, information about the airports. I've got situational awareness. That is the shift that's happening in healthcare from analog dials to real-time GPS, not just in the cockpit and the visor of the fighter pilot, but in almost every doctor, nurse, and healthcare worker. Then, of course, there's virtual reality, right? It's very fun to put grandma on a roller coaster. Virtual reality is great for gaming. It feels so real. But virtual reality is now becoming a tool for therapy, for helping burn patients have no pain or treat pain management. It can engage patients in physical therapy to stay and gamify their physical therapy to heal after an orthopedic surgery. It's being used as a medical medium now for mental health. Video games for mental health have huge opportunities, given that so many folks are playing video games. I heard that the esports is coming here to Riyadh next year. So video games for mental health. And of course, virtual reality is a game changer for medical education, right? At Stanford, we have the virtual heart. So as a patient or as a doctor or as a parent, you can now walk inside that heart and understand its anatomy and its complexity. It's an incredible new way and fast way to learn. Instead of see one, do one, teach one, as I was trained as a physician, now it's going to be see one, simulate, simulate, simulate until you get it right, often collaborating with colleagues from around the planet. So we're now really in this exciting new world of extended reality. My friend Dr. Raphael Grossman is here, one of the founders of that field, that gives us entire new ways to interact with our surgical and other environments. In some cases, you can get mentoring from a surgeon from around the world to help another clinical team learn a procedure or have a challenging case. And increasingly, that's not going to be one-to-one. It's going to be crowdsourcing the knowledge from thousands of surgeries. We're videoing them, we're using AI, and the future of surgery will be ones that are guided step by step, learning from thousands and millions of cases around the world. So just like we now have driver assist, we're going to sort of have surgical assist and clinician assist, upskilling all of us. The theme, I think, of the future of healthcare is all of us can be upskilled by these new technologies. Now, of course, diagnostics is very important to medicine, picking up disease at early stages, stage 0, not stage 3, and diagnostics is shifting. 10 years ago, we had the very first examples of an iPhone connected to a glucometer. That was a decade ago. Now and a decade ago, we had the very first examples of the EKG on the smartphone case. You heard about it earlier. Now you're going to buy a live core case, a six-lead EKG that even fits on your credit card, is FDA cleared. It can pick up all sorts of cardiac issues. So that's an example of how quickly we've moved in the last decade. And again, the smartphone itself is democratizing health and medicine. You can modify the speaker and the microphone now to look in your child's ear and pick up an ear infection without bringing them to the pediatrician. We can use the camera to look at your face and pick up vital signs like heart rate, blood pressure, oxygen saturation. So that could democratize vital signs without wearing anything. So that's part of our new era of invisibles. We're speaking of the camera, it's almost the time of the medical selfie. Instead of bringing your urine to the laboratory, you can use the smartphone camera and AI to dip your urine at home and check for signs of infection or preeclampsia or early kidney disease and take a picture. Boom, you have your instant results that go right to your pharmacy or to your doctor or your health authority. Easy peasy. And I just met a Saudi company yesterday using these sorts of technologies, using digital thermography to look at the skin of, for example, of a diabetic foot. So a lot of these technologies are coming here, are being invented here, and are leveraging the smartphone in interesting ways. The smartphone also has, of course, the microphone. The voice now is a digital biomarker. It can pick up early signs of mental health challenges, neurologic diseases, the sound of your cough. Is that a common cold? Is it croup? Is it tuberculosis? The idea of digital or acoustic epidemiology. In fact, just published this month, a study was showing that voice can predict your blood sugar. So they're now using 10 seconds of voice to predict who has diabetes. So imagine using your smartphone to screen the entire population here for diabetes early before they have challenges. And of course, while many parts of the world do not have enough doctors or nurses and pharmacists, they all have an increasingly number of cell phones and smartphones, and this will become, again, the platform to democratize healthcare. Now, one of the things that our smartphones and wearables can do a great job is giving us insights into our own behaviors. We know that our bad behaviors, smoking, too much, not enough sleep, too much stress, those lead to most of our chronic conditions. And now we're in the early era of being able to measure our behaviors. It was only 13, 14 years ago they had the first Fitbit. I'm now wearing like 14 different wearables, 2 different rings, things on my wrists, several places. Now these sorts of wearables and otherables can measure almost every element of our physiology and behavior. But I'd wonder here in this room, how many of you have ever been prescribed a wearable from your doctor? Or if you're a clinician, how many of you ever prescribed a wearable to your patients? Because these new wearables and otherables are soon going to be part and integrated into all of healthcare, because they're not just sensors on our wrist, they can be a sensor inside our pill to track whether a patient took their medication. They can be, instead of a blood pressure cuff on our wrist, you can fit a blood pressure cuff on our wrist on a phone, on a watch. Soon these are dissolving into smart patches and into our watches that will pick up just on your watch blood pressure and soon even blood sugar. So imagine what we can do with real-time blood pressure, real-time blood sugar from the next generation Fitbit or Apple Watch. That is coming soon. Or the next generation of smart patches. These ones coming to market today can already measure an entire intensive care unit level of data streaming from a small disposable patch. That can lead us to do better hospital-to-home, remote patient monitoring, without ever requiring the patient to come into the hospital or to discharge them sooner. We now have patchables that are powered by movement or have ultrasounds built into them. We have sockables that can track the health of a diabetic foot and find hotspots. We have earables that can not just give you a better hearing aid, but look at your vital signs and give a patient information if they have cognitive issues. We have ingestibles coming that can go through your GI tract and track your GI health. Sweatables, if you're an athlete or have renal disease or cardiac disease, sweat is an interesting element. A decade from now, we'll probably have tattooables You can have your own artistic version of these devices that will measure your pH and your blood sugar evident on your skin. So watch that space. And of course, these sensors are even coming to our underwear. I call them underwearables. These technologies are getting so cheap, these Internet of Medical things, you can get a pack of 10 of these, put them on every pair of underwear, just put them on and you're automatically censored for almost a year. And what's interesting about these sorts of technologies, they started as consumer tools, kind of to measure our stress and our breathing, but now with new incentive models in the United States, payment for remote patient monitoring, these are tools to track COPD and COVID and respiratory issues at home. So of course, the technology needs to align with new payment and incentive models. Wearables can also be therapeutics. This is a technology from Stanford called Kala Health. It measures tremor, and it can reverse out the tremor with electricity as medicine. So don't just think as wearables now as a diagnostic, they can also be a therapeutic as well. We're now just not able to measure our wearable data, but our breath. Breath is a biomarker, can pick up signs of metabolic disease as well as cancer. So the next decade we'll see this era of breathables. Well, you'll have a little device and you might breathe in it before you go on a social engagement and just sort of check your breath, but also might check you for different chronic diseases. Now let's go back to our consumer tools. I'm wearing 2 different kinds of smart rings. Think about all the exponential technology that fits on a ring today. Of course, it's very good at tracking sleep, and today I have a lot of jet lag. It's not just good for tracking sleep. It can give you signs of a woman who's pregnant 5 days before a home pregnancy test. Or in a study at UCSF, the Oura Ring could predict the titer after a COVID vaccine. So these are new tools for public health and understanding reactions to vaccines or disease early. And so small data, simple data from a simple Fitbit can be very useful in our clinical care. For example, if you send a patient home after a total hip replacement or total knee replacement, are they walking more each day as you might expect and doing better? Or something going wrong and they're walking less? If they're walking less, you might intervene early before they have a fall. And if they aren't walking so well, maybe they're going to use the next generation of exoskeletons. I got a chance to try one of these next generation exoskeletons for someone who's paraplegic. These are powered with AI and sensors and optimized to the individual, and really going to be a game changer for those who have super disability. In fact, even if you have pretty normal ability, the next decade will see us for the ability to put on exo boots and be able to climb a mountain whether we're 95 or 105. So incredible convergence of AI, robotics, and wearables. Now my favorite wearable, since I'm a pilot, of course, is the jet suit. And these jet suits are even being used by paramedics to help rescue folks in rural, hard-to-reach mountains. I had a chance to try flying one of these myself. Most of the time, I did not look like James Bond, but those are my better flights. Most of them, I didn't look like this. Most of the time, I look more like that. But that's my favorite wearable. It has some healthcare applications as well. Another important thing we can measure, of course, is our diet. Food is medicine. The famous quote by Hippocrates, let medicine be thy food, let food be thy medicine. Now we can measure with AI the content of your meals. You can scan your meal. Does it have gluten? How many calories does it have? So we can measure input, and increasingly we can start to measure our outputs at home. And these are going to become integrated with our metabolome. Of course, many of you have been trying continuous glucose monitors that can individualize our diets. And the future of nutrition will be precision nutrition, integrating microbiome, metabolomics, wearable, and other data to really use diet proactively to prevent disease or to help treat it. So let's look forward 10 years from now, or even less. By 2030, all of our digital exhausts from our wearable and other wearables will be collected. Who owns that data? How do we manage privacy is still a big concern. But we're going to have the opportunity to collect that data and make meaning out of it. And this blends with the next generation of diagnostics. Of course, imaging. We heard from our friends at GE earlier. Imaging is on the exponential. You can now have a full body MRI done in an hour and give you incredible insights into your health. In fact, these are now being more and more powered by AI and can be done faster and faster. I think in 10 years, you'll be able to go to your corner pharmacy and get your entire body scanned in 10 minutes, read by the AI radiologist. And sometimes you don't need to have an MRI machine. There are new generations of wearable devices that can find brain tumors and evidence of stroke in the ambulance or in the clinic. So imaging is shrinking and getting more and more powerful. So for myself as a doctor, I have my own digital doctor's bag. This can be something I can use in California, or a community healthcare worker could use in rural Saudi Arabia or rural Africa. These are new enabling tools for all of us. We heard from the ability now to upskill anybody to have an ultrasound in their pocket that today still might need an ultrasonographer, but as they're showing in the future, these are now being able to guide anybody to use and do their own guided imagery. So these will democratize access. Every medical student, nurse will have an ultrasound in their pocket, guided and enhanced with AI readings. Part of diagnostics in the future of pandemics and public health will be crowdsourcing. I've been the chair of the X Prize Pandemic and Health Alliance, very active over the pandemic. We actually ran a $10 million X Prize to develop new tools for fast, frequent, cheap, and easy COVID testing. You might remember 2020, 2021 wasn't fast and easy to get COVID testing. We had over 700 teams from 77 countries compete in that competition, and we had incredible winners that come up with very new ways to do diagnostics in the home, not just for COVID, but increasingly for infectious and non-infectious diseases. So I think that's going to increasingly change how we do care, proactive home diagnostics. Now, the challenge and opportunity with all these new tools is they can sort of overwhelm the brain of our patients and our clinicians. So it's not just a matter of AI, but of, I call it IA, intelligence augmentation. We're going to use these new tools in surprising ways. If we look back 12, 13 years ago, we had IBM Watson. We expected AI doctors to be here in 2015, but it took a little longer for AI to hit healthcare. So you need to remember not just Moore's Law, but Amar's Law. We tend to sometimes overhype, overestimate what's possible in 2 years, and underestimate what will be here in a decade. So I think we need to have that long-term 2030 and beyond view to explore what's going to happen next. And already today, these new ChatGPT and generative technologies are doing a better job than most humans. Imagine what they'll be in the next decade. For example, Google's MedPalm already can take a simple X-ray. You can use natural chat and already get your chest X-ray readings. This is going to be more and more available to almost any clinician or patient around the planet. The gastroenterologist can use AI to find lesions that they might have missed otherwise, so it's enhancing our physical exams. It's being used to look at the back of a retina from a simple smartphone to look up and predict a patient's risk of eye disease or hypertension or heart disease. And increasingly, we're going to use AI machine learning to help us make less mistakes. We have huge challenges with medical errors. No clinician can remember everything from medical school or keep up to date with the literature. So these are going to become important co-pilots in our care. And our friends here from pharma are increasingly using AI to build the next generation vaccines or biologics. Our friends at in silico are already being able to use AI to discover drugs and bring them to clinical trials in months rather than years. So as we look to this convergent age, of course it's not man versus machine, it's not human versus robot, it's often collaboration. Bringing the two together give you the best outcomes. In fact, a company that my fund invested in, Sanctuary AI, is starting to blend human use cases and healthcare use cases, particularly where there are not enough doctors or specialists or home care workers. So look at that blend. It's today not quite perfect, but 2, 5, and 10 years by 2030 will be quite incredible. We need to be thinking forward. So I think you've heard this theme, AI is not going to replace your clinician, doctor, or hospital, but those using AI will replace those who don't. So let's see how this all comes together in this new age of what's often called digital health or mobile health or connected health. I think about digital health as this ability to take all these new forms of data and make them useful to the individual patient, doctor, healthcare system, or health community. Because it's not about the data, it's how we make it useful. And today, we're entering an age where we don't just prescribe a drug or a medical device, we can start to prescribe FDA-cleared apps, digital therapeutics, that they might be apps for smoking cessation or managing diabetes, or for mental health, huge opportunities and needs to blend digital and mental health. Or we're now prescribing video games to treat children with ADHD that get better outcomes than they would with just a drug by themselves. In many cases, the video game is better than the drug. So that takes us to this new era where the apps and the data from wearables or other roles go from what's often called quantified self, where we have the data siloed on our smartphones, to an era of quantified health. Our data and information and insights will flow to our doctors and nurses and health systems, so we can use this information in real time to optimize our health and wellness and longevity, to pick up diseases at stage 0, and then to manage smarter feedback loops for therapy. We still don't always know what to do with this data. Verily, which is a spin out from Google, is doing the baseline trial. 10,000 folks sharing their digital data, their wearable exhaust, their genomics, so we can make sense of that in the real world. So as we learn from crowdsourced information, we're going to enter an era of predictalytics. Imagine each of us and our patients had a bit of a FICO score, a wellness index, not just based on their vital signs and their weight, but their social connection, where they've been, their genomics. and we can use that as an integrated score to optimize and measure their health. Almost like a simplified check engine light for the body. Our cars today have hundreds of sensors, but powered with AI, they give us a smart check engine light. That's what we need to bring to each of us in healthcare. That technology is actually already here. My colleagues at Stanford have been building check engines light for the body. They can pick up diabetes early, or infectious disease, or increasingly your wearable can tell you that you have COVID 2 days before your PCR test turns positive. So we're really starting to enter this time of real-time check engine lights for healthcare. So if we, again, go forward to 2030, 2033, we'll almost be in a minority report world where we're going to understand that we have a disease sometimes months and years before it comes to hurt us. And that's the point in time where we can intervene early, when we can cure and stop diseases as opposed to late stage. Now, if you look around this incredible exposition, there are already hundreds and thousands of incredible innovations. How do we make sense of all these new tools and solutions to companies? It's a challenge. I found that challenge hard, so I built a new platform called digital.health. That's the website. If you go to digital.health, it's a bit of a digital health formulary and database. So for example, if you're trying to learn about diagnostics, you might go there and look for a way to look at AFib. You might find the AliveCore device. You might look up the KardioMobile and look at its evidence base. You might save it in your favorites. You might put it in your personal prescription pad and start to use that to prescribe that to patients. So imagine every doctor has a personal prescription pad. Or for diabetes, you might look for therapeutic interventions that use diet. For example, companies and platforms like VertiHealth that can reverse type 2 diabetes using ketone diets and coaching. So I think this future can leverage this digital.health age to give us not just prescribing drugs, but digital solutions. Now, all these, again, are great, but we need to help the clinician integrate this into their workflow and their incentive models. Because many times the technology is fantastic, but unless it's paid for and integrates into the incentive models, it's too much. In fact, we're already in an age of too much. We're in the Internet of Medical Things. 5G today, 6 or 7G by 2030, which will be 1,000 times faster. 50% of the world's population is now going to be connected using internet that did not have it today. So global markets are opening up. So of course our homes will be smarter. We'll have lots of medical data. But data is not enough. I mean, no doctor, what is it, doc? Just as I thought, you're generating too much data. No doctor wants the data. We want the insights. So we've already heard today about the challenges of more and more data, often data that's siloed between one hospital to another, to medical records, to genomics. We don't want just data. We need to turn data into information. Then information needs to translate to the bedside or the website. Today, it already takes often 17 years to be translated. You've heard that quote? We need to accelerate that gap, just like we saw COVID narrow that gap, and use this new field of implementation science. And I think Saudi Arabia and beyond is a great place to do integration implementation science so that future comes faster. So the future of health is really, again, integrating these new tools and technologies, not leaving them siloed. So I see this future of digital, mobile, and connected health connecting all those dots. We can use digital tools, digital prescriptions, Internet of Medical Things data to flow in smart ways, not to overwhelm the patient or the doctor, but to give them the right information at the right time and close that loop. And increasingly, we'll be taking knowledge that's crowdsourced. Remember 15 years ago, we used to drive with paper maps? Now we couldn't imagine driving without Google Maps or Waze. In fact, especially in the traffic in Riyadh, you need Google Maps or Waze to understand how to best get to where you're going. Imagine if we had a Google Maps or Waze for all of us, where each of us could not just be a blood donor or an organ donor, but a data donor, and we could build a Waze for healthcare, learning from other patients like us or patients like ours to guide them on their personal health journeys and speeding up knowledge and sharing. And then again, engages the patient. Each of us should think of ourselves as engaged humans in our own health, not waiting to have disease, but staying proactive. You have a very young population here in Saudi. If you understand that they can get engaged in their health, you'll prevent them from getting diabetes when they're 40, 50, and 60. So let's encourage everyone to have an opt-in to share that data going forward. That comes now to this new age of reinvented clinical trials. You no longer need to come to the hospital or clinic. You can download an app on your smartphone. You can be delivered the drugs or the wearable. In fact, my colleagues at Stanford did the Apple Heart Study. They recruited 400,000 volunteer patients from 50 states in only 8 months. That's more than the Framingham trial did over 30 years. So we have really new ability to collect and engage everybody in the future of medical knowledge. So I encourage you to think about virtualizing and digitizing your trials. So let me close with how this is going to shift the future of care. Of course, we all now experience more telemedicine and virtual care. There's a great virtual hospital from Siha down in the exhibit hall. I think the future is not going to just, of course, be physical care or virtual, but more hybrid, blending the two modalities. We're going to go from today's model of very intermittent episodic data, usually only collected in the four walls of the clinic, and where we have a very reactive mindset. Today, even here, we tend to wait for the patient to show up with a heart attack, or show up with a stroke, or show up with a late-stage cancer. The future, using these new tools that we've been talking about, is to be more continuous with our data, make that data much more personalized, much more proactive, preventative, and start to bring care anywhere, anytime on the planet with better outcomes and even with lower cost. Healthcare does not need to be more expensive. It can be more integrated and more equitable for all. And so that means increasingly we're going to go from hospital to home to phone to even on and inside our bodies, this idea of hospital to hospital, right? So when you're building your next generation hospital, think about the needs for 2030, not the needs for 2023. Where are you going to integrate genomics information? How can you discharge patients to home or never admit them in the first place? Of course, our virtual visits, today you kind of talk on a screen like on a Zoom and a chat with a doctor or nurse or pharmacist. That's 2023 model. The 2030 model will, first you'll talk to the chatbot. That chatbot will know you, your genomics, your medical history, your personality type. It won't ask you the same 20 questions. It's going to give you very insightful care and again be truly personalized to your age, culture, and language. And increasingly our interactions will be interacting with things that feel human, and they're more and more human feeling today. They can be truly personalized to who you want to interact with. It might be an avatar, it might be your own doctor who shows up in the app. So increasingly these tools will again give us new ways to personalize our interactions. I like to call it not the metaverse, but the mediverse. We're going to change the way we interact. It's going to feel quite magical, from using platforms like HoloLens, which can bring people into the same room, to some of the technologies with the next generation Oculus. You might have seen this example from Meta, where now you could feel like you're in the same room. Here's a quick snippet from that. Turn the volume up. Well, they're basically in the same physical space. They're thousands of miles apart, but they see each other interactively, and that's going to be part of our future of clinical care going forward. So we can all be turned into avatars today very easily, and that's going to be interesting ways to interact with our future self as well. So that begs the question, for medical students, nurses, all of us, how do we train the future clinicians? They don't need just good bedside manner, they need good website manner. They need how to interact in the metaverse. So who do we choose for medical school? How do we train them to leverage these new tools and technologies that are moving faster than our educational platforms can keep up with? Finally, we can bring this digital age to hyper-personalization. We can scan a body part and 3D print a brace, or a medical implant, or braces, or a hearing aid. What if we took all these convergent technologies together to solve for big medical issues? For example, a lot of patients take a lot of medicines. Sometimes they're not the right dose, not the right combination. Imagine we use digital 3D printing to not take 10 pills, but to maybe 3D print your own personalized pill. So instead of taking an aspirin, a statin, beta blocker, Synthroid, vitamin D, we can integrate that into one medication that matches you. So I've been working on a platform called telemedicine to 3D print your own personalized medications. You can adjust the dose, and every morning it might print out the medication that really is based on your drug levels, your mood, your symptoms. So that will be part of this future of healthcare. You can watch my TED Talk about the future of personalized medications. That's where these things can go. Print, modify, print medications for longevity or for prevention or for managing chronic disease. So in closing, we have this real opportunity here to think forward collaboratively, to invest in the future of health, proactive prevention as well as sick care. And it's this exciting new age of super convergence. So don't just think about AI or robotics or 3D printing or nanotech or VR or AR or big data. Think about how they all come together and how each of those segments are accelerating and getting faster, cheaper, and better. It's an incredible time now to think about where we're moving from still scattered Internet of medical things to an age of predictalytics, to an age where all this data is seamlessly integrated and personalized in our homes, communities, and beyond. So it's an important time to think about this future and move us from where we are today, which is already incredible. We are here in 2023, but to skate to where the puck is going to be in 2030 and 2033. And to think smartly about investing in taking us from where we are now into this exponential convergent health age, not sick care age. I've been doing work at Continuum Health Ventures. It's a fund that invests in seed stage cutting-edge digital health and longevity companies, along with my partner, Ricky Mera, who's here, to really catalyze that. We would love to work with anybody here who's looking to catalyze and invest in the future of health and medicine. So let's not take incremental steps. Let's take exponential steps. The future, as we've seen around us here, is already here. It's just not evenly distributed. It's our opportunity with incredible vision here in Saudi Arabia and everybody in this community, not to just predict the future of health and medicine, but to boldly create it for all of us here on planet Earth. So with that, thank you very much. Let's create the future of health together. Shukran.
Thank you to Dr. Daniel for his inspiring speech and taking us to the very close future. Fireside chat, Unlocking the Full Potential of Reverse Aging and Longevity. The host is Dr. Mahmoud Khan, CEO, Evolution Foundation, Riyadh KSA, and he is going to join us shortly and present his guests. again, and we are introducing the session, which is Fireside Chat, Unlocking the Full Potential of Reverse Aging and Longevity. And our host is Dr. Mahmoud Khan, CEO, Evolution Foundation, Riyadh KSA. Please welcome to the stage.
Well, thank you. Good afternoon. Assalamu alaikum. Let's touch on probably one of the most exciting topics that we keep hearing about in health and life sciences, which is the whole area of health span, longevity. And I hope today we'll get to hear and get a dialogue from two of the world's experts in this field, both as practitioners and as scientists. To save time, I'm going to do a very brief introduction. Colleagues and friends, Professor Andrea Meyer, their bios are already available to you, and of course, Professor Zhao, good afternoon. Welcome to Riyadh. And it's a little different from England, obviously different to Singapore, but I think if you get a chance, you'll find it's a wonderful, delightful city. Let me kick off, if I may, with a question that we get asked frequently, which is, what is the benefit to an individual and to society in general by extending longevity and extending health span? Why should we be concerned about doing this at a societal level? Maybe we start with yourself, Andrea, and we'll go over.
Yeah, sure. Thank you so much for the invitation. I already had a lovely day yesterday. Hey, it's really amazing how much virtual care is going on, how much technology there is. It's mind-blowing. So thank you so much for the invitation. I'm a clinician. I'm an internal medicine specialist and geriatrician. And as a geriatrician, I always see the individuals at the age of 80 with lots of medications, lots of diseases already who occurred much, of course, earlier in life. So I am seeing individuals with lots of multimorbidity. Why do we have multimorbidities? We have it because we are aging at this moment in time. We are accumulating damage, even in individuals who are called healthy. And the aging process, in the end, will give us the higher odds of having an age-related disease. And it took me, I think, 10 years of my life while doing aging research to really understand that we could prevent the onset of age-related diseases. And what does that mean? That means that we would increase health span rather than extending the lifespan. And the health span is the duration on Earth without age-related diseases. That's a very common definition we are using, whereas the lifespan is the number of years, irrespective of age-related diseases. At this moment in time, in lots of countries, individuals have 30 years of years with age-related diseases. And how beautiful could it be to prevent these kind of diseases and therewith increase the health span and therewith narrowing the gap between lifespan and health span? That would not only give us, but very likely, more productivity, less absenteeism, for example, our workforce, but also would lower costs. And that's being discussed in the longevity dividend, that if we are delaying the aging process, and there with the onset of diseases, while treating just one disease, and that's aging, that also, not only from a societal level, individual level, but also financial level, that would be quite lucrative.
Yes. So yes, hello everyone. It's a pleasure to be here in Saudi Arabia for the first time, and a wonderful conference. So to pick up on that, I think that the argument, and we've heard already today about the aging of the population globally and how worldwide, including in Saudi Arabia, the greatest killers of modern societies are age-related diseases like type 2 diabetes, cardiovascular diseases, cancer, neurodegenerative diseases. And so if we could retard aging, we would retard all of these diseases. You mentioned the longevity dividend. One interesting piece of data from that is that if we could slow down aging by 7 years, what that would mean is that we would cut in half every single age-related disease at every single age. So it would have huge, unprecedented medical and health benefits. And so that's the rationale, is that, as you were saying, instead of targeting one disease at a time, if we could slow down aging, we slow down all and we prevent and retard all age-related diseases, ultimately to allow people to live longer, healthier lives. And that's another important point to emphasize, is that the goal is not just to make people live longer in a period of decrepitude, is to allow people to live longer with good health. In other words, to make a 70-year-old have the health of a 50-year-old. That's the goal.
So we often hear the terms health span and lifespan. And sometimes they're used interchangeably, and clearly what both of you have described is that we're really focusing first and foremost on health span, how long we can live healthily, versus just how long we want to live. Nobody wants to live forever sitting in a bed or a nursing home, not being able to be independent. So given the significant evidence in the scientific field in this space, both at the basic science level, at the clinical level, what's it going to take to translate that evidence and data, and how do we move from data to action? Where's the gap? What's it going to take? Maybe I'll start with yourself, Xiao, and then we'll...
Yes, Bill, so that's the big challenge, of course. So just very brief overview of what are we finding at the biology. So I'm a biologist, although I'm in the medical school in Birmingham, so I'm a basic science. And I mean, what we have learned in recent years, or recent couple of decades actually, is that in animal models, we can retard the process of aging up to a certain degree. So we can change one gene, or we can change the diet, or we can administer the particular drug and allow animals to live significantly longer. So in worms, you can change one gene and animals live 10 times longer. So that's quite remarkable, this ability of just do one tweak and you slow down aging significantly in animal models. In mice, I think the current record of tweaking one single gene is about 50%, but it's still quite impressive. I mean, if we could apply that to humans, we'd be people living 150 years. So we know from animal models that, again, up to a certain degree, we can retard the process of aging. Then the challenge, of course, is how do you translate that to humans? Well, we can't really change human genes that easily. So we have to go via dietary or pharmacological manipulations, for which we know of some already, that slow aging in animal models. But of course, that's a big challenge. Clinical translation, that's still a big gap because it requires clinical trials, it requires much longer, expensive studies, rather than if you use animal models.
So let me push that a little further, and I'll ask Andrea to. So yes, we've got to do clinical trials. Yes, we've got to understand the risk and benefit, and we'll come back to the regulatory and the policy side of this discussion. But you're a practitioner as well as a researcher. So you're seeing patients today, and maybe we don't call them patients. We call them subjects, we call them consumers. They may not be coming to see us because they're unwell. They want to maintain their health. So what do you tell your consumers today? Or are you telling them, hey, come back in 10 years when we've done the trials?
No, absolutely not. So yes, I'm a healthy longevity medicine physician. If you're asking me, does that exist? I would say no, because it's not regulated yet. So that's my disclaimer. But I'm a physician working in a longevity medicine clinic, publicly and privately. So I think the first step is, what is healthy longevity medicine? So we defined that within the Society of Health Longevity Medicine, and I think defining it is very important to then build an ecosystem, and that's what we are doing. So health and longevity medicine is improving and optimizing health and health span by antagonizing aging processes across the lifespan. So what does that mean? That means across the lifespan, everybody here in the room could be a client, a patient, of whatever you call it, a population in the health and longevity medicine arena. So that's very important. We are targeting the aging process. And what we want to do is not waiting until the disease occurs, but we want to optimize the body, that the chance of having an age-related disease in 10 or 20 or 30 years' time is much, much, much lower. So what we are doing is not maintaining, but we are optimizing it. based on, for example, a biological phenotypic characterization. What does that entail? Looking at the genes, the epigenome, the microbiome, all the other blood work, but also clinical parameters. What is the VO2 max at this moment in time? What is the cognition at this moment in time? What is the social interaction? How does the environment look like? So by knowing that, we can optimize individuals in their environment, or we can change the environment, and we have interventions in place really working towards precision medicine within the health and longevity medicine arena. And of course, people ask, I want to now use a rapamycin or rapalog. I want metformin. I want, without having good evidence-based trials at this moment, some are coming, please inject me the stem cells because I heard from my friend that it's good. What we really achieve is an evidence-based medicine arena, not doing these kind of treatments because we first need the evidence on paper, being scientifically proved, being peer-reviewed, before implementing it into clinical practice. So we do all of that, diagnostics, interventions, maintenance, of course diagnostics to optimize the body and hopefully also the mindset while celebrating life.
So let me come to a diagnostic question that we get often in the field. I'd love a biologist perspective and a clinical biologist perspective. People come and say, I want to know my biological age. How old is my body? Not in years, but biology. And yet, I can order a biological age, and I recently had somebody come up to me and said, I got my biological age done by 2 different labs, and the test results I got back were 20 years difference. So it was a big, huge, so what are your thoughts around how we measure biological age? Where are we in the field? And what are you telling, Andrea, to yourself to think about when your subjects come to you, patient comes to you, I just had measure my biological age. What do you tell them? So maybe we start on the mechanistic.
Yes, I think that's still one of the problems we have and one of the challenges we have in the field. I think on one hand, at the mechanistic level, we don't fully understand human aging. I mean, why do we age? What are the cellular molecular drivers of aging? Now, there are some hypotheses, there are some ideas. So, for example, one hypothesis is that telomeres shorten, and telomeres shorten with age. So telomeres are the tips of the chromosomes, and the cells divide, they get shortened, and if they get very short, then cells become senescent, and they stop dividing. So that's one hypothesis, and we do know that if you measure telomere length across the lifespan, they do shorten. But there's a lot of variability there, so I wouldn't say it's a very good biomarker of aging. So that's still one of the challenges we have. Now, there are other biomarkers, for example, epigenetic age, where look at methylation, so chemical modifications of the DNA that don't change the DNA sequence. And you have some of these that correlate very strongly with age and correlate with mortality as well. So those are arguably the most exciting biomarkers of age and of inferring biological age that we have. But as you say, they're not perfect, and I've heard I haven't tried it on myself, but I've heard other people say they do it 2 different companies and they get very different results.
Andrea, do you recommend a biological clock?
Yeah, sure. In clinical practice, we are using at the moment 15 biological clocks, and I think this is great that we have 15, but it's how do we interpret them and how do we use them in clinical practice. And there we need much, much more education also for the consumers, but also the healthcare professionals, how we use it. So the first step is, again, what is biological age and what is a biomarker of aging? So we now have a biomarker of aging consortium, a worldwide network of colleagues of ours, and we defined it. And it's being published a couple of weeks ago in Cell, so please read that paper or contact me if you would like to have more information. But what we described there, and also in subsequent papers, is how do we then validate a biomarker of aging, measuring the biological age or a clock, and then how do we implement that? So we are at the 3rd stage at the moment. How do we implement it? How do we discuss it with regulations, for example, with on individual stages in different countries? Can we actually use this as a diagnostic? Is it FDA approved, yes or no? So there's a huge arena. So my patients get at least a number of clocks, but always this is the explanation that we are measuring the pace of aging of one specific thing inside of the body. And we already know that the pace of aging is very different within our bodies, within one individual. And that's also the reason why the clocks are very different within one individual, and different tests are different and give you different ages. Because it's not as easy as saying you are 5 years younger. No, your heart or certain functions of the heart might be older or younger. And we now are able to disentangle that and using machine learning, AI, etc., to use that information to give a personalized intervention to these individuals.
So you've contributed to this writing just to pursue this a little further, because a lot of individuals, practitioners, and patients come forward increasingly saying, how do I interpret this, right?
Yep.
You've talked about this. But we think of clocks, biological clocks, of having three attributes, right? One is to measure your biological age, whatever tissue or organ. The second is demonstrating reversibility if you stop smoking, start exercising, taking medications. And thirdly, some correlation with the rate at which you're aging, right? Because you want to hopefully not wait until your biological age is advanced, but some evidence that your biological age is accelerated compared to somebody else's. So as you think about what you've just described and putting that into practice in your clinic or using it as a research tool, where is the field now? Where do you think, where's the gap?
I think there's a huge gap in validation of all these clocks and in agreement what is a good clock or not good clock, so in terms of sensitivity, specificities, etc. I am more an optimist in saying having lots of tools at the moment is good, because if we are bringing the data together, we can therefore say if insulin glucose is going down. So these kind of interactions we want to see, what we in diagnostics, in interventions. One of the major, I think, it's not a roadblock, I think it is a collaboration we have to see, is how do you implement it into clinical practice, and what do you implement it on scale into clinical practice. And the conversations with regulators, I can tell you in Singapore we have huge discussions if we can implement epigenetics or the genetics into health and longevity medicine. I think we are at the forefront to really bring it to the agenda, and there was really make a case that there is a use for it.
But Singapore, and I'd like you to comment, Singapore is a diverse population. Chinese, South Asian, Caucasian. How transferable is biology from between races, between species? If we're talking about a common, if you believe in the common biological basis for aging pathways, then how transferable is that?
Yes, so that's another big question. I think when you look at some of the longevity pathways, both genetically and pharmacological, they do work across animal models. They work in worms, in fruit flies, in rats, in mice. So they do work across different model systems. So there is a level of genetic conservation and even pharmacological conservation of some of these longevity pathways and longevity interventions. So that, I mean, of course, we don't know for sure if they're going to work in humans, but there's ongoing trials for rapamycin in dogs, for example, for caloric restriction in monkeys, for example. So there are efforts to see if it translates to longer-lived animals and potentially to human beings, of course. But we still don't know for sure, of course, if that's going to translate to humans. And one of the things I think is quite exciting as well is, for example, when you look at epigenetic clocks, they, as markers of age, they work for different human tissues, and they also work across different species. So there is a level of conservation. And going back to basic biology, I mean, I think one of the exciting discoveries of recent years is that we can rejuvenate cells in vitro, and we can rejuvenate their telomeres and their epigenetic markers with cell reprogramming technology. So here what you use particular genes, particularly 4 transcription factors, called Yamanaka factors, that have been used in regenerative medicine for quite a while, and you can rejuvenate cells. And I think that's quite remarkable. Now, of course, this is something you do in a petri dish in vitro, and whether that translates even to animal models, it's still unknown. But I think it's remarkable that at least at the cell level, you can take an old cell, you can take a cell from a centenarian, and this has been done, and make it young again. So at least in a petri dish, we can rejuvenate cells.
So let me ask you now to look into the future. Look next 5 years to 10 years. What excites you, both of you, and I'll start with yourself, Andrea, about what's on the horizon? If you were investing, what would you be investing in? If you were a consumer, what would make you optimistic over the next 5 years?
So my KPI, my personal one, which I share with lots of my colleagues, is having health and longevity medicine as a recognized specialty within the conventional health service arena. I think that's very important to be recognized. To do that, there's a huge amount of work. So we need to invest into diagnostics, and we have to invest into interventions. And I think this is so exciting now that we fixed mice in C. elegans and Drosophila because they can live 40 to 50% longer. So how do we now learn from the traits we found and bring that into humans? And I think this is what I'm going to do in the next 5 years with lots of colleagues in the entire neuroscience arena, to do the interventions in humans, in actual humans, doing randomized controlled trials, bringing evidence into the field. Once that exists, we are absolutely ready for implementation, hopefully worldwide, into the healthcare systems, and also into, I would say, the wellness sector, which is also not very well defined. But in the end, I think we have to take care of our own body, and we also have to discuss where is healthcare kicking in, or where is the responsibility of a human being. So over 5 years' time, hopefully at this exhibition hall, we have a huge arena just talking about not only prevention, but health optimization of individuals who do not yet have age-related diseases, but who are aging.
What excites you, John?
Yes, so there's two things I'm excited about in terms of translation. One of them is longevity drugs, which we know a lot in animal models. As you say, we still need to translate to humans, but in particular drug repurposing. So taking existing drugs that are used in the clinic already, and that maybe they delay other aspects of aging. So there's some interest in metformin and rapamycin. I mean, we've done some work on an antihypertensive compound called rimedidine. So that's one thing I'm interested in, taking existing compounds, existing drugs, and seeing could they delay other aspects of aging. The other aspect, picking up on cell rejuvenation, is, well, can we apply these cell rejuvenation technologies into the clinic? And that's, of course, a big question. As full disclosure, I'm CSO of a company that works in this space called Youth Biotechnologies. So we are working on cell reprogramming as well, and there's other players as well, like Altos Labs, who was funded by, amongst others, Jeff Bezos from Amazon last year, has billions of dollars. So it's a very timely and very important work, and I think we will have answers, given all the money that's going into it. I think we will have answers of whether cell reprogramming also works in vivo and potentially therapeutically.
So let me ask you to play the role of policymaker, government leader. If you had the chance to talk to the Minister of Health of Singapore, the UK, Kingdom of Saudi Arabia, what policy changes, if any, would you ask for in order to help accelerate this field? Jia?
So one thing which, well, this was a positive outcome of COVID, was in terms of data sharing, which we've heard already today about in this conference. And I think that, you know, the UK government and the NHS recognize that we need better sharing of data. And that's something that can still be improved. But if we want to look retrospectively, for example, in terms of drug repositioning, whether some drugs retard other aspects of aging or they prevent other diseases, then we need to have access to a lot of data. And that's something that has improved a bit because of COVID, as I said, but I think could be improved even further. So that's one aspect that I think would be quite important, is in terms of data sharing. I mean, we do a lot of data mining and AI and machine learning, so that's obviously, my opinion is a bit biased, but that's one of the things I think could be improved.
Andrea?
Yeah, luckily, especially the Ministry of Health is working closely together with the Ministry of Manpower, together with the universities and with our group to actually see what the roadmap could be for a healthier life in Singapore, in Singaporeans, but also with the vision, okay, how can we help other countries? How can we build the networks? That's very important. So there is this interaction already, and one of the roadmaps being discussed at the moment is not only screening children if they're developing well, which is in Singapore under the umbrella for human potential, and then starting again screening individuals at the age of 40 to 50 for colon cancer at the moment, but really bringing a target group of aging individuals from the age of 20 to 50 in to see how are they aging at this moment in time, and building these living labs to not only share data, which is very important, but also measuring new data sources like environmental data, social data, productivity data, and there was employment data, which are huge determinants of health span and lifespan. And I think creating that ecosystem with governments, together with companies and together with the universities is the way to go to create a healthier now. And this is what's happening at this moment in Singapore, but where I see huge potential here in the Kingdom of Saudi Arabia, because there is so much excitement about health, and I think such a need, because age-related diseases like diabetes and hypertension, etc., are high. I see a huge potential of not only prevention, but optimization.
So, as before I conclude, one of the things you've talked about is at a national level, how to bring manpower, health, all of these things that converge on this. But in any society at the national level, we need to make sure there's equitable access for everybody that's going to benefit.
Yep.
And this is one of those nascent fields that lacks standardization, that lacks regulation, but not only that, but there's a whole spectrum of cost implications as well as. So how do we make sure that as we move forward, one of the mandates for Evolution, my organization, is to invest in things that are going to impact as many humans as possible. How are you thinking about equity and accessibility for the technologies that you're developing? Shao, yourself?
Yes.
And
no, that's an absolutely crucial aspect. We need to make sure it's democratized. And, well, in terms of, depends, I suppose, on intervention. Some interventions, well, metformin is very cheap, for example. So there are some longevity drugs that are extremely cheap, and they could be made available in a very democratic way. I suppose when you think of interventions like gene therapies, those would be more expensive. I mean, I'm a big advocate of, technology, and I'm an optimist. That I think, if it's something is going to be so valuable that is retarding aging, then it will be available to the masses, and it will be have a wide appeal, and it will have certainly government support, because from an economic perspective as well, of course, aging and age-related diseases are a big challenge, economic challenge, and if we could reduce those, then there would be huge economic benefits, and I think governments would understand that and recognize it.
Andrea?
Yeah, absolutely. We have to democratize health. We have to give the best level of interventions and diagnostics to everybody. So in Singapore, we launched the first publicly funded longevity clinic in end of August this year, the first worldwide. And I know we have lots of other hospitals working together in our consortium, like Sheba Health in Israel and the Mayo Clinic in the US, who also have the same initiative. So we are writing protocols together. We try to really bring the evidence on paper. We are trialing it. We have to have health economists with us. We have to have implementation scientists with us. And I think implementation scientist is a very undervalued specialty. And I also just got to know quite recently to be able to democratize whatever we come up with and what the SOPs looks like based on the highest level of evidence. So, and that's what we have to do worldwide. And what I really would like to see is worldwide trial networks that we include all ages, populations, ethnicities, and races, and with good data to really do these randomized controlled trials to then see what is not only effective in terms of health outcomes, but especially cost effective on the longer run. because it has to be proven that there is a longevity dividend.
Well, thank you. Just as we close, I think what we heard is the importance of not only understanding the state of the science today, addressing the gaps, putting the resources behind this field to continue to progress, the need to bring different government agencies together and stakeholders, and then ultimately how to think about inclusiveness, equity, and availability, but keeping the recommendations based on objective science, not conjecture. And the science has progressed. It's exciting. We're starting to see around the world clinical centers actually implementing diagnostic and therapeutics in a whole new frontier. The basic science to support that. And now we start to ask ourselves, what are the policy frameworks, the regulatory frameworks, the professional societies? And I think you touched at the end on the need to collaborate across institutions. You're already collaborating between Singapore, the Middle East, and in North America. Given this movement, I think we're right at the cusp of this amazing rapid pace. What we didn't get a chance to touch on is the pharmacology and the fact that investment in industry is now starting to pay a whole different level of attention. In the last 2 years, we've seen capital from venture capital go up by at least double. We're starting to see big pharma come back in. If we think about the research funding in this space, it has attracted not only government, but non-profits, and very few people in the kingdom may appreciate. After the NIH, it is actually a Saudi institution, Evolution, which is the second largest funder of geoscience funding in the science space in this, and continuing to grow. And probably the most important thing we need now is to collaborate, convene, and come together across borders, across disciplines, to make this field not only evidence-based, but to be able to scale and democratize. Thank you, both of you. Thank you for serving as advisors, guiders to Evolution. Andrea, thank you for coming back to the kingdom twice this year. I look forward to seeing you again next month at Evolution's Global Health Summit. Appreciate your presence. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you for Dr. Mahmoud and his guests. And now we are going to start defining the future of kidney care, a PPP success story. And the guests are Mr. Robert Lang, President and CEO, Davita International London, UK, and Mr. Faisal Sabri, Managing Director, Davita Care, KSA, Riyadh, KSA.
Good afternoon. It is absolutely fantastic to be back at the Global Health Exhibition. As was introduced, my name is Robert, and I'm the CEO of Davita International. This is our second year participating in this fantastic event, and it's wonderful to have the opportunity to share with you the progress we've made in a private-public partnership between the Ministry of Health and Davita over 10 years that's impacted so many lives here in the Kingdom. Our partnership, perhaps I would say, one of the most successful I've been involved in anywhere in the world, has been 10 years in the making. And today, we have a partnership capable of creating a lasting positive change on the Kingdom's future generations by reducing the growing impact of end-stage kidney disease. So let me share with you how we got to this point and why it matters so much. It matters because behind every great private and public partnership, there is a strong foundation that does not get built overnight. Successful partnerships don't happen at the signing of a contract or the issuing of a press release. In many ways, the elements of success for such a partnership must be in place before it even commences. In this instance, it involved a willingness from the ministry here in the Kingdom to embrace global best practice from a provider with a demonstrated track record, and most importantly, insist that any provider commit to the highest quality of clinical care. For us, it required shared values, as well as a willingness to see the partnership play out over many, many years. To invest in the local community, local management, infrastructure, and of course to take a long-term financial return framework. What resulted was a deep trusting relationship that's been galvanised over 10 years. It had to start with the fundamental challenges of kidney care in the kingdom before it can evolve to some of the more complex and challenging issues that we are now on the precipice of confronting as partners. On the one side, we had DaVita, a Fortune 500 company with 30 years' experience in the United States and around the world. And on the other side, a visionary government laser-focused on bringing systematic change to the healthcare system for the betterment of its people. Over the course of 10 years, we went through the journey and laid the foundation for what we see today. We created employment and training opportunities for Saudis, offering accelerated pathways into healthcare. And you can see, you can see here, this is a former patient of ours and us, who later became a DaVita teammate. And this is a special moment he had meeting the Minister of Health just last year at this event. We invested in our team and we became part of the community, providing with gusto the unique DaVita culture that's been widely credited around the world with contributing to happier teammates and better patient outcomes. In fact, just here you can see our teammates here in the Kingdom getting involved in some of our most favourite community programs. This is our Walkabout Step Challenge, which takes place all over the world, and Spirit Week, where we celebrate everything that is unique in the bond between our carers and our patients. Our US counterparts are consistently amazed and indeed inspired at the unique way our Saudi caregivers have embraced and now enhanced and evolved this unique DaVita culture into something even more powerful and global. Indeed, after 10 years, I can say that our community here in Saudi is changing DaVita's culture all over the world for the better, and Sabri will say more about this later. And of course, most importantly, we are improving clinical outcomes to the point where they are now a global benchmark. And we can confidently say that the quality of dialysis care here in the Kingdom is as high as anywhere in the world. These outcomes were not an accident, and they were not guaranteed. The MOH held firm in their commitment to their vision that we as their partner not only provided global best care, but did so in a uniquely Saudi way. This meant investing time, energy, and indeed finances to be here for the long term, to understand how healthcare is delivered in the Kingdom, to adapt to it, and if needed, to help improve it. And that's what we've done. To be engaged with local patients, local caregivers, nurses, technicians, physicians. The most valuable ingredient of success in treating this disease is the unique and highly precious bond established over many years between patients, families, caregivers, their clinics, and the local community. This is a highly precious bond that should never be dismantled lightly. Success cannot be built by either partner by treating this as a simple procurement arrangement. This is a serious and long-term disease that can only be solved by serious and long-term partners. And when such a partnership demonstrates this success, when there is earned trust between partners, valued by patients and their families, then something truly groundbreaking can start to occur. The partnership can evolve beyond the mere provision of high-quality clinical services, and both partners can commit to treating this disease holistically. As we first outlined at this conference last year, the opportunity to build a patient-centric chronic disease treatment system, as was outlined by our global chief executive, Javier Rodriguez, who stood on this stage just 12 months ago, has the opportunity for the Kingdom to provide the most sophisticated kidney care pathway in the world today. And Sabri will say more about this in a moment. But one of the examples we've been able to see here in the Kingdom has been the innovation of home care nurse-assisted dialysis. What makes this service unique, and a first for the Kingdom, is the ability to transform a patient's home. You can see here an image of the before and the after, into a personalised dialysis treatment centre. To have the nurse attend the session at all times, so the patient and their family need not be concerned with the treatment session, all the while being monitored by our sophisticated command centre that oversees all the patient's vitals and can coordinate support efforts anywhere in the Kingdom at a moment's notice. When choosing a modality, the answer is different for every patient, based on their needs and that of their family. And while in-centre treatment will continue to be the most appropriate treatment for many, there are significant benefits to treating at home. And this need not compromise the quality of the clinical outcomes, as you can see here. I'm also pleased to say our patients agree. They see home treatment as the reason for a marked improvement in their daily lives, not just in their care treatment, but in their overall quality of life. This kind of kidney care innovation is not simple and certainly not easy to implement. There are multiple challenges to contend with. Converting a patient's home infrastructure, managing the equipment, the water treatment appropriately, which our technicians can plan and execute. Helping the patient transition to a place of increased self-reliance, albeit with the assistance they get, and monitoring the patient's health remotely. None of this is a quick win, either clinically or financially, for the healthcare system. However, it is right for the patient. And DaVita's global experience gives us the confidence that in time, the right innovation and the right treatment for the patient is always the right path for all partners involved in this unique private-public partnership. When you take the world's preeminent kidney care provider and all of our ingredients and develop a partnership with a foresighted and committed ministry, the result is a PPP that can do incredibly powerful work. Our long journey started with the fundamentals of providing dialysis to kidney patients 10 years ago, and it has now evolved into a partnership capable of tackling the most challenging conditions in this chronic disease. And this is the really exciting part, because DaVita is no longer simply a procurement partner fulfilling a tender contract, but a trusted partner proven by our long-term commitment to both patients and the health system here in Saudi. The MOH is now willing to engage us in their broader vision, not just to provide dialysis, but to help tackle this chronic disease holistically. Fortunately, we are not just a simple provider. We are, without question, the global leader in treating kidney disease holistically and can now bring that expertise to the kingdom. And I'm excited to tell you about one of these really innovative and exciting developments that is already underway as we speak. And to do so, I'd like to introduce the Managing Director of DaVita Saudi Arabia, Mr. Sabri.
Mic 2. Assalamu alaikum wa rahmatullah. You guys are with me? Assalamu alaikum wa rahmatullahi wa barakatuh. Very quiet group. My name is Sabri. I'm the Managing Director for DaVita Saudi Arabia. What an honor to be here today. After 10 years of a great relationship with the ministry, I'm here to share with you more specific examples, not things that are ambitions. Those are real examples happening here in the kingdom. For those who have attended the Global Health last year, we've shared with you the holistic approach for kidney care. When we came to the kingdom, we focused mainly on in-center hemodialysis. But then we started to look at more ways to provide a true kidney program for the Saudi population. This holistic approach is the way forward as we navigate through the program in the kingdom. We're focusing today on prevention. I'd like to share with you what we've been able to do in terms of how the execution have taken place and some of the results. But why this is important? As you guys have attended yesterday, the opening remarks by His Excellency, we want to invest in health. And that investment in health is investing in prevention. In order for us to reduce the progression of the kidney, we need to invest in the prevention. So we can know who is going to be at which CKD stage and how to deal with them, to give them the right level of support, but also to make sure that predictability to the healthcare system and the cost is not going excessive and therefore it's going to burden the healthcare system. So what we've done last year, we've launched a program with Medina Cluster and Mecca Cluster. In those two programs, we have been able to do public screening. And what I mean by public screening, events like this. The team has gone to the airports, they've gone to offices, to the malls. There has been a lot of programs developed, VRs for the kids, games, so you can get more people engaged to get to know more about the kidney implications. What we've been able to do is 30,000 impressions that have been done so far in terms of those events. But what's critical is the screening that has taken place. 8,000 participants have gone through this. One of the interesting things I remember when we were in Medina at the Amara, we found about 3 participants that had either hypertension or diabetes, and they did not know that they have it. And that's the beauty of this program, is again, we're investing in health and making sure that the patient is aware of what's happening in terms of their well-being. And why is that important? Because if, God forbids, somebody has a end-stage kidney disease, you would want to give them the right optionality for which modality that they need to pick. But also it gives you predictability on the overall healthcare system. So we project to be at 50,000 participants or 50,000 impressions by the end of the year and 10,000 screened participants. Now, as I mentioned, the program has implications on the healthcare cost. What we've experienced across different programs, there's about 40 to 50% reduction when you have an effective CKD program. So there is a 40 to 50% reduction in cost when you have an effective CKD program. That's why you have to invest in the upstream system. We have spoken about this holistic approach, end-to-end kidney care pathway. We've talked about innovative programs like the kidney care program in Mecca and Medina, and soon will be in Riyadh and in the East. And we have talked about the home innovation that Robert spoke about earlier. But how are we able to bring this to life? Meaning, how are we able to engage with the population? How are we able to engage with the patients? At DaVita, we take pride of our culture. So we have several programs, one of which is our Wall of Fame. This Wall of Fame program is an activity where the patient and the teammate engages in building a Wall of Fame. And it could have a theme of nature or reading and so on. But the beauty of this is that the patients and the teammate come together, build this Wall of Fame using recycled items. And just so you guys know, DaVita has won 40 years in a row worldwide across different DaVita clinics across the globe. This is one of the programs. Another program, how we bring all this to life, is patient as an advocate. We actually hire patients that can help their colleagues in terms of onboarding, in terms of how to improve their clinical performance, and also to make sure that they're comfortable as they go through the dialysis. As some of you may know, the patient spends more than 15 hours a week at the dialysis center. So that is critical to make sure that the patient advocate is there to support the patient. I would encourage you to stop by our booth. We have patients, advocates at there. You can spend time with them, get to know their journey, and they'll get to share a lot of information with you on that. We have talked about the holistic approach. We've talked about the innovation. And we've talked about how we bring this to life. And that's what we refer to as the DeVito way, taking care of each other with the same intensity that we take care of our patients. Thank you very much for taking the time. Assalamu alaikum.
Hi, we're back again, and now we are going for addressing the needs of future healthcare systems. And we are introducing the speaker, Professor Sultan Haidar, founder and head, Innovation Think Tank, Siemens Healthineers, Erlangen, Germany. So please welcome him.
So good morning, everyone. Oh, good afternoon, actually. They told me that most of the people are for lunch, so I hope you are going to enjoy the presentation, and it's not going to be very tiring for you. The topic of the presentation today is how do we address the needs of the future healthcare systems? And we do this with local capacity building and by creating self-innovating infrastructures. So a few weeks before I came to Riyadh, and this is what happened. We did a workshop with the Seha Virtual Hospital, a lot of stakeholders, and when people come together, there are new ideas coming, there are inspirational keynotes, and what we do is we build capacity within the system. And this is one of the prerequisites for a sustainable innovation infrastructure in the organizations. And today and yesterday, a lot of people saw this outcome in the Seha Virtual Hospital stand where we are presenting this together. And new ideas are coming in. So once we come together, new ideas get generated, there is a process needed in order to document these ideas and then to take them to the next state. And for this, we are writing now grant applications together with the different stakeholders. So I'm going to split my talk in 3 points. I think everybody knows these points, but the question is why certain things work and why certain things do not work. Yeah? So why is innovation needed in healthcare? How do we solve this with Innovation Think Tank? What are the activities here in the region? And what are the participation possibilities? Innovation is needed in the healthcare ecosystem everywhere for patients, for healthcare providers, for governments, for other stakeholders, medical device companies like us. But in order to get the information from the different stakeholders, you need to have a mechanism. So it's very interesting to work on challenges, but to work on the right challenges. This is what is making a difference between a real innovation. And this picture that you see on the left side is a picture from Children's Cancer Hospital in Cairo, where for the first time we had kids participating in a workshop, giving ideas about what are the things that they see should be changed in the hospital. So if you want to run such a workshop, it's not that easy. We had to take a lot of permissions within the hospital. We had to take permissions from the family members, and these kids were available only for about 3 hours of time. There were 65 ideas they were created. But in order to start something like this, there is a process that needs to be followed, and I will show this in the next few slides. Here, if you look at the other image, there are certain challenges. There is a surgeon looking behind while he's performing something on the patient. And this is not observed as a problem by a lot of people who are working even in those environments. And in order to do this, about 20 years before we started a program, I was coming up with this in a very simple format that a lot of students, they come with scholarships to Germany, and perhaps we can use these student brain power to solve certain challenges. Over time, we have expanded this program to 90 locations worldwide, including Siemens Healthineers, a lot of universities, hospitals, and governmental institutions. And what we do are 2 main elements. One topic is helping create the requirements for the future products. And the second one is addressing the needs of the host institution to set up their own innovation infrastructure. This results in a lot of knowledge and a lot of experience, which we are also sharing on our website in different white papers, so you can take these frameworks and identify the topics and the process that is relevant for the host institution. So how do you design and implement a self-innovating infrastructures? Especially for the future of healthcare, there are 3 areas where I feel, together with our team, we were able to lay our focus, because this has a very strong impact on the healthcare provider ecosystems. One is education curriculums. So if you design the education curriculum in a way that it's creative, it's making people enjoy what they are doing, research programs, and healthcare services. Last Friday, before I came, I took a short video from our office, and you might be able to experience a little bit the environment, how these things actually speak out. So, an environment plays an important role here. What you see is the models for 3D, models for ecosystems. We have 3D printed solutions models, and this is a very inspiring space. It helps people to come together and to develop know-how that can be reused again, so that if a new institution is starting such a program, you can take the frameworks and further collaborate with the partner sites worldwide. And this is one of the outcomes that we feel that we have created over years, that we have created knowledge frameworks, we have created infrastructure frameworks that could be taken for further improvement of the patient care globally. So we are running capacity building programs, which is meaning that participants from different institutions come together. The only positive thing that happened as a result of the lockdowns was that it was possible to collaborate globally, and there was a willingness to do this. I think this was the only positive thing, other than getting to know the people was a challenge in reality. But here you see a program that we conducted with Imperial College London, where I'm in my office. We had participants sitting, some of them in the hospitals, talking about the challenges, stakeholders coming together, and then creating basically scenarios which we publish also in a white paper. Now, after some time where once we had these programs running successfully, there was a request from the universities to explain what is the process that we follow. And we follow a methodology which is available also on our website with 4 steps, starting with acquiring the mandate, creating a big picture, then creating proposals, and deploying commercialization. I would just go into the first step. Maybe just think about what is the first step for innovation in your mind for a second. So there are many things which people come up with. Getting an idea, looking at a problem, getting motivated. But over the first 10 years of my career running an innovation program, I realized that the first step for innovation process is to get a mandate. A mandate could be an invitation, so that you have the power to work into an area that you would like to bring some change in. And this is very important step for starting an innovation process. So it's somehow reflected in all the steps, and we teach different methodologies. How do you get the grants? How do you make the program self-sustainable? The second thing that we have done, as I mentioned, we have created frameworks, and this is an example here for a disease pathway for stroke. So the most important pain points and the challenges and the solutions are mentioned in these frameworks. And if there is a hospital group or if there is a Ministry of Health that is interested to develop a customized disease pathways, they can download these pathways from our website and adapt it to their needs. We have also, in a similar way, so one thing is our disease pathway framework, life cycle framework, and the other thing, what we have done is we have also built a technology framework, and this technology framework allows making use of all the existing technologies, so 3D printing, AR, VR, and getting a direct feedback from the innovation think tank sites worldwide. So this actually enhances the time to market shortens the time to market for our products. As I mentioned, most of these frameworks are available on our website, almost all of them, I would say. And the ones which are not available, we are compiling them now with Springer into a book with all the experience from different sites in 2 volumes, and this would be available also in the end of this year. The process that we follow for setting up an innovation think tank, it starts with acquiring the mandate, which is meaning getting an invitation to set up the program, running the capacity building program. So capacity building allows identification of the problems, what are the most important problems, bringing the team together, and also prioritizing the problems, which ones we need to work on. Then we support here setting up a lab infrastructure, which is based on the requirements coming for the projects. The next step is enabling commercialization. So we have processes in place where we talk about the experiences that we have made in commercializing the different products. And the newest one is self-innovating hospital. And I would like to spend a few minutes on this topic. So we get lots of visits from all over the world to our labs. And some months before, while I was myself in the hospital with my father spending his last days, I had a visit from many healthcare professionals who came and to visit my father, but also we had discussions, and I was able, in this 6 weeks I spent in the hospital, I was able to see what kind of challenges are really needed to be solved. Yeah, on one side, I love technology, I'm an engineer, but on the other side, you see that there are issues which are not related to technology. Yeah? So, in the same time frame, we had some visits to my office where one of the leading CEOs asked our team, what would be a hospital for 2040? Yeah, so I don't want to say 2030, he specifically said, I want to think about a hospital that is going to be there in 2040. So he kept asking this question to the entire team, and in the end we concluded. And we said we cannot design a hospital for 2040. We can create an infrastructure that is self-innovating. So if there are new requirements that are coming, we can adapt to them. Yeah? And this was something so powerful and at the right time. As I said, I was in the hospital with my father for 1.5 months, and I could see things very closely, and we added this as one of the elements in our portfolio and received 2 projects, one to help in creating a vision for a hospital in Riyadh, and the second one in Germany, where there is a healthcare campus getting formed in the east of Germany. And I'm very glad that our team is having this possibility to experience shaping the roadmap, shaping the vision for creating a healthcare institution with all the experiences. Sometimes we wonder, what is it that drives, as an institution? And when you listen to people why such institutions get formed, there are some hospitals that or hospital groups which created a university because they felt that their workforce is one of the biggest challenges. They need to have workforce, so they created their own institutions. And there are others who first create an education institution, and then they think about how can they ramp up the activities and create an ecosystem that is self-sustaining. So learning these processes is a lot of fun, I would say, for me and our team. At the same time, you meet wonderful people who are interested to change the way healthcare is delivered. And I feel this is a very good learning exercise for everyone if you are into the area of healthcare services, to have strong connections with academia, to see what are the best practices happening in different parts of the world. And we offer these interfaces through our programs, bringing the stakeholders from different universities and hospitals come together. So this is a kind of a workflow that we follow for our programs, bringing it up to a level that we can create a self-innovating hospital. Oops. So ITT at SEA, and things can happen really, really fast. As I would like to take one example here. I had my first meeting with colleagues here from SEA Virtual Hospital last year in Riyadh. I didn't expect things to move so fast. We had a number of workshops where we could participate in the formulation of the innovation pathway for the sandbox. We had participation from the colleagues in Imperial College London. And a month before, we did this exercise for capacity building with the different stakeholders, and we identified the different problems relevant for the SEA Virtual Hospital. And now we are in a process of formulating a grant for setting up an infrastructure that can help in the deep dives, and compiling the outcomes into a book chapter for Springer. Similar examples have taken place in other parts of the world, so, and really, really fast. One is here from Emirates Health Services, where we received a request to perform this capacity building exercise with the healthcare professionals. We had 36 participants, a lot of them heads of departments from the Emirates Health Services. One of the topics that was mentioned to me was that the hospitals have an occupancy rate for 120%, and can we get ideas to reduce this rate? And we had people from departments like rehabilitation. Of course, there were a lot of clinicians, but from dietary department. And it's very interesting to see how people from very different fields could come up with ideas if they are given the resources to work on, and if they are offered the right methodology and the management is supporting it, and things could happen really, really fast. So the teams came together, they came up with 13 different ideas, they created some prototypes, then presented the outcomes in the Arab Health at their stand. And it's something which, for me, is a very low investment for 5 days of, let's say, the training program from our side. But the outcomes that can come with such a small investment cannot be compared if something like this is not seen or experienced before. Another example, and things in all these activities started with just a simple connection with another person. So sometimes I also wonder why some things happen and why some things don't happen, right? So here, another example from Ankara. I was sent to meet Professor Haberal here, the founder and the president of the Bashkent Health Group. And it started with a small lecture, where there was a teaching engagement. We wrote a grant together, and there were some startups that were created out of this program. And then we received another grant to create an incubation center out of this program. So what we do with Innovation Think Tank methodology is we teach about this process of how do you first of all, how do you select the ideas, how do you bring people together, and how do you define the projects and take it into a sustaining process. The programs that we offer today are fellowships. So in Germany, in all our labs worldwide, if you are a researcher, if you're a student, you can apply for this program. And we are offering about 200 fellowships every year, so that the students and researchers can work for a period of 3 months to 4 years in our labs. We also support in developing your own innovation think tank, offering these certification programs, help in shaping the educational curriculums. I would say it's an honor to participate in the educational curriculums because it's more learning than actually giving. Planning the research for an institution, prioritizing them, and helping healthcare institutions to plan their healthcare services. We are not the one to build the hospitals, but we are the ones who help in shaping the vision and roadmap for the hospitals. So summarizing, for the future of healthcare, is strongly driven by self-innovating infrastructures. This is something which can distinguish the hospitals and the healthcare facilities between each other. Local capacity building. We are willing to support this as part of this initiatives worldwide. And happy to inform you about our activities in KSA. And if there is interest to participate, please contact us. Thank you very much.
Thanks to Professor Sultan. And now the session is about panel discussion, healthcare foresight, mega trends impacting healthcare now and in the future. The keynote is Dr. Mahmoud Al-Yamani, Sector Head Health, Wellbeing and Biotic, NEOM KSA. Panel discussion, healthcare foresight, mega trends impacting healthcare now and into the future. The keynote is Dr. Mahmoud Al-Yamani, Sector Head Health, Well-Being and Biotech, NEOM KSA.
Good afternoon, everybody. It's a pleasure and honor to be with you today. Thank you very much for inviting me to this panel today. I guess I'm going to talk a little bit about the future of healthcare from NEOM's perspective, which basically summarizes everything that's happening globally on healthcare. And then we will have the discussion panel on the outcomes of that and where do we take that next. If you look at what's happening in the world today in healthcare, it's a lot of emphasis on digitization, a lot of emphasis on prevention, a lot of emphasis on biotech and innovations, and a lot of emphasis on individualization. And what that collectively does is a few things. One is it puts the human being in the center of this healthcare transformation that's happening globally. And two is it leverages technologies so that it reduces dependence on human beings, because there is always a scarcity in the healthcare providers at the different levels in the different parts of the globe. And the third is it uses all of this to individualize healthcare rather than looking at populations as a mass of people. Now, what's not happening is pulling all of this together in one place for many reasons. One, it's very difficult to come to a population of 500,000 or 1 million or 5 million and try to do that from scratch all together at the same time and provide health care for their acute needs. And so the focus always shifts from prevention to cure when we have a patient in the emergency department or a patient that needs a medical intervention. Two is a lot of us as healthcare providers focus on our niche areas. So we forget about before, we forget about prevention, and we focus on how do we treat people when they become sick. Now, what NEOM is trying to do is put everything together for a small population today of about 5,000 employees and about 50,000 construction workers, collectively about 55,000 to about 60,000 people, and then grow that system as the population grows to 9 million over 3 decades. But the system will grow with the population. Now, this is a unique opportunity that doesn't happen twice. Now, every healthcare system has come to a population that exists and tries to catch up. In NEOM's case, it's the other way around. It's actually building a system along with building the population. And so we're at a big advantage of being able to do what the rest of the world could not do, which is building a system as you build the population and marrying that population to that system. The second thing that we're trying to do is leverage on what the world has achieved in individualization. And so what we do is we identify every individual as that particular individual. We don't look at diabetics as diabetics. We don't look at hypertensives as a population of hypertensives. We look at every individual and identify their risks. And again, here is a key point. Everything that every healthcare system is doing now is identifying your problem, your medical problem, early on, and try to modify the outcome. And so we try to identify if you are pre-diabetic or if you have a borderline hypertension, or a borderline personality disorder, or a predecessor to some particular medical condition, that we try to reduce the impact of that disease on the individual. We're not doing this. We're actually coming much earlier than that. We identify you as a genome sequence. So we identify your genome sequencing, both your basic genome sequencing and based on your demographics, what are the potential genomic problems that you could have. We identify you in the form of data or data points that we capture around the individual 24/7, everywhere, provided they consent for it, of course. And so put that together of environmental data, behaviors, and the genome sequence, and now you have wealth of data that would help you identify problems decades before they happen, and that is the key. So it's not about going to a primary care center to find out whether your blood pressure today is up or down and trying to bring it down. It's actually identifying in you as a child or as an adolescent what could happen to you at the age of 50, 60, 70, 100. And 100 is very close, by the way. Now, what does that need? It needs a huge data platform. It also needs a lot of applications that would be able to detect everything around a human being. It needs quite a bit of a robust artificial intelligence layer that would allow the interpretation of these data in one language, unified language, that would identify multiple risks that could contribute to a disease. What does that mean? It means a huge engine that doesn't exist today in the world. And for those of you who were 10 years or older in the 80s, when the internet came in, this is the internet of healthcare now. This is the engine, the search engine of healthcare that NEOM is trying to build now. This is the transformation of healthcare. This is how you build a personalized healthcare that prevents diseases rather than trying to prevent the complications or the advancement of the disease or the problems after the disease, the so-called secondary and tertiary prevention. Now, we talk a lot about primary care, but in the true sense of primary prevention, nothing is happening today. This is primary prevention, where you identify problems years before they happen, years before the individual is bound to have them, and try to go backwards and prevent those. That is one element of what NEOM is building. What does NEOM need to build that? Tons of collaboration and partnerships with companies that do apps, companies that build platforms, companies that work on AI, companies that work on risk stratification, companies that work on data science, companies that work on actuarial works. And so it's an area where the whole world needs to come together to make that happen. And I assure you, we have the interest from tons of entities in the different areas that want to build this with NEOM. And so it's about time to build this, and hopefully in a very short time, and I don't want to commit to a certain date, but in a short time, we'll see that live. That is our definition of the digital twin. Different from every other digital twin that you see in the market today or hear about, different from the anatomical digital twin where somebody scans your body and puts it on a computer system or on a platform, or take some blood and have some results of investigations. That's anatomical. What we're trying to do is more molecular, is more genetic-based, is more in addition to every other data point. Now, the second difference in NEOM's health digital twin is this is a twin that's going to grow with you as you advance in age. And it's not like the digital twin that you only build once and then have contact points, be it every 3 or 6 or 12 months. This is something that grows with the individual second by second, leave alone hour by hour. And the more of the data points that we collect, the more enhanced the analysis, the more accurate the predictions become, the more likely we are to identify multifactorial risks. We don't understand dementia today. We see a lot of dementia. We don't understand how it happens. And then we say it's multifactorial. Now, what are these factors? We don't know today. But there will be a date very soon where we will identify these multiple factors and we'll be able to prevent them. This is the essence of the future of healthcare. This is the essence of NEOM. We haven't talked about provision of care. We haven't talked about hospitals. That's coming. That's happening. It's actually happening today. But that is only to catch up with the 20%. The 80% of what we do is identifying risks ahead of time, building the environment around the needs of the individual so that we prevent disease by recognizing it decades before it happens. Thank you.
Thank you so much, Dr. Mahmoud. And now we would like to introduce the moderator for the session, which is Mr. Ebele Anidi, Director of Partnerships and Engagement, G20 Global Innovation Hub, for Value in Health, Riyadh KSA, and he will introduce his guest.
Can everyone hear me okay? A thumbs up would be great. Thank you. Great. So thank you, Dr. Al-Yamani, for that insightful address. It's now my pleasure to introduce our distinguished panel. Their collective knowledge and expertise will hopefully shed light on the multifaceted aspects of healthcare's future. We're really honored to have them here with us today. So before I introduce them, I actually invite all of the panelists to join me on stage. You guys can just come up, yeah. We have a packed panel today, so I hope you're excited. So working our way down the line, obviously you already know Dr. Mahmoud Al-Yamani heads up the NEOM Health, Wellbeing, and Biotech sector. We also have Islam Jaber, who is the Core Diagnostics Regional Manager for Middle East and Northeast Africa. We're also joined by Rob Walton, who's the President and CEO, Europe, Middle East, and Africa for GE Healthcare. We're joined by Ms. Renita Das, who's the Partner and Senior Vice President, Healthcare and Life Sciences for Frost & Sullivan, Professor Jed Byrne, Director of Global Health Partnerships for NHS England, and last, certainly not least, Dr. Mark Suchi, who's the founder and Executive Director of the MESH Incubator at Mass General Brigham. So let's kick things off. Let's start with you, Rob, actually, if you don't mind. You know, as we look into the future, what do you consider to be the most transformative technological advancements on the horizon? You know, for example, precision medicine is gaining traction. How will this impact patient care moving forward?
Yeah, great question. And I think as we were just hearing about, the healthcare data is probably one of the largest sources of data on the planet. I think it accounts for about 1/3 of all of the data that's on the planet today. It doubles every 73 days. So there's a tremendous amount of information out there that potentially could be used. And the key aspect of this data is that it's been full of extremely important and valuable information that could be used for either better diagnoses, guiding treatments more effectively, improving the workflows in hospitals. You know, the tragedy is that less than 3% of the data ever gets used, and the rest of it is kind of discarded and thrown away. And so the opportunity, as we were hearing from earlier, is to make use of this data and actually to be able to combine it together. And so one of the things that we're working on together with many other partners is to think about how can we create data platforms that can aggregate this data together. And this is about using multimodal forms of data, whether that's radiomic information from scanned images, whether it's diagnostic data, pathology information, electronic medical records, but also DNA data, genomic information. All of this stuff can then be used to be able to combine together, leveraging data platforms, leveraging artificial intelligence to be able to do three things, really, which is what, in my view, is the form of precision care. And precision care is three things. Precision diagnostics, for a start, so actually being able to identify diseases earlier, identify them more accurately, trying to determine what is the likely response of a patient to a particular type of treatment. And then precision therapy, which is about how do you target and specify the type of treatment. So some patients will not respond well to certain treatments if they've got certain cancers, and others will. And so how do you actually use that DNA information to be able to be more targeted and more specific around how the treatment is delivered? And then the third piece, which is often forgotten, is precision monitoring. You know, we often forget that actually the recovery of a patient is probably the most important part of a treatment. It's not just about diagnosing and providing a therapy. It's actually about the recovery time afterwards. And so if you think about a typical cancer patient, they will have multi-year journey, but the actual therapy piece may only be for the first year. It's the remaining 4 or 5 years afterwards that makes the difference. The challenge, though, with monitoring is outside of the intensive care wards, outside the acute care settings, there is very little monitoring available. So how do you extend that to general care, extend that to the home care environment so you can identify whether the patient is going to recover or deteriorate after their treatment? So putting those three things together to create precision care solutions of monitoring, of diagnostic and therapy together really enables us to be able to unlock all that value of information that's in the data and start to be able to create better outcomes for patients ultimately.
Thank you so much, Rob. And speaking of diagnostics, I want to bring Islam into the conversation. There's a shift toward preventative and holistic healthcare. It's evident. People are abundantly aware. But for the audience and even for myself, I'm just curious, what are the trends and changes that are shaping this shift? And then as you look forward, how do you envision this will impact patient experiences? Kind of building on what Rob was just discussing, how does this fit within this larger paradigm shift towards holistic healthcare and ensuring that we're thinking about not just the cycle of diagnosis and treatment, but the full end of health and well-being?
Thank you so much for your question. And really, it's first of all, thank you for having me here. Dr. Mahmoud, thank you for the inspiring speech. It's really an exciting time to be in Saudi.
Can't hear.
Honestly speaking, as Dr. Mahmoud said, we focus more into the operational excellence and increasing our operational capabilities, physical infrastructure, etc. So we build up more hospitals, right? But the integrated clinical care and what's going across the globe is really important. It is time to start talking about disease prevention. So if I share a few figures, by 2029, $16 trillion will be the healthcare expenditure, which is double the amount it was in 2019. So in 10 years, we're doubling the amount of the healthcare expenditure because, again, we're busy with day-to-day business as usual. The second thing, in Saudi Arabia, 90,000 people are dying because of the chronic disease, which represents 70% of the global death. So honestly speaking, the technology is allowing us to do more and to start answering questions before it happens, right? So if I take diagnostic as example and the blood testing, early blood testing, we can tell, and through the risk stratification program, we can tell what might happen for a person, and instead of targeting people in the emergency department, we should really go for those healthy population, healthy people, and say what may happen in 10 years' time. So whether it's cardiac risk stratification or diabetes risk stratification, it can answer who's in the low risk, moderate risk, and high risk, and started to take action, recommendation. And the beauty of it, as Rob said, if we can get the data into AI and really start to have everything integrated in one platform, it will give us really answers. We started to invent a few things like clinical decision supports, which also will take this data and try to make decisions. And it is the building block of what is coming next, which is AI, was described by Dr. Mohammed Yamani. The last point which I want to say, we invented recently and we started to heavily invest in the wearable devices. And this is really important because it gives you platform of monitoring and getting answers for things before it happens. So for example, we have the Freestyle Libre. It's like a coin, very plastic patch, where the diabetic patient can put it and it can give continuous monitoring for glucose. And our vision is to include and to integrate more tests. And this really, when we get the data and we have this accessibility, I think we're maintaining the long-term sustainability and access to doctors. And this is affordable technology, unlike the classical way of going to hospitals and you know, like the long, I would say, pathway treatment. So that's all from my side. I hope I answered your question.
You did quite thoroughly. And I want to make sure with my panelists, can you hear me better now? Or do you need me to speak up?
No, we can't hear you.
Oh, wow. Okay. I will try to project. Is this okay?
Thank you.
Well, thank you, Renita, because this next question is coming for you.
It's still garbled.
Oh, no.
It's coming out as garbled over here.
Okay. I will try to...
Do you want to switch places?
Can I actually just have a normal microphone, maybe? Or just...
We don't hear him at all.
Not very well, no.
Yeah, so I think we should say it because we can't follow the discussion.
Or maybe, hold on, I can try this. Is this, ooh, sorry, is this better?
Yes.
Okay, I'm just adjusting on the fly. So, Renita, you know, we look around the world, and with innovation, with progression, comes different countries that are faced with aging populations. You know, what strategies should healthcare systems implement to provide quality care, not just for seniors, but you know, from cradle to grave, the end-to-end life cycle? And I know that a lot of your work focuses on access to health, access to healthcare services, especially for women and girls. So we'd just love to get your thoughts on what strategies should countries start looking into and implementing, especially as we think about the extended lifespan for people, not just here, but around the world.
Very good question. Thank you. So far, we have not been practicing healthcare, in my opinion. We've been practicing sick care. And because we've been practicing sick care, 80% of the dollars go to 20% of the population so far. Moving ahead, we're looking at a world in 2030 where 65% of the world will be over 60 years of age. Of course, not in Saudi Arabia, because here we have a very different problem. We have about 80% of the world that's under 50 years. So it's a different set of problems. But in the rest of the world, if you look at it, about 60 to 70% of the world is going to be over the age of 60 years. Also, the dependence on someone who's a senior and someone who's working is going to be much less. There are going to be much more people who are seniors, not productive and contributing, compared to people who are actually the working population. So what we have to do is we really have to move to an age where we are screening well in advance, where we are preventing well in advance, and where we are actually predicting well in advance. So we're looking at shifting the dollars. If we look at healthcare dollars and where dollars are going, and we've done multiple studies on this, 5 years or 10 years ago, 80% of the dollars went on treatment. So whether it was a drug, whether it was a device that was used for a surgery, whatever it may be. But moving forward, we're going to see much more money moving into diagnostics, moving into prevention, and moving into actual wellness and prediction. So I do believe that we're going to an age where there's going to be much more emphasis on holistic healthcare. And when I talk about holistic healthcare, I'm not really talking of just the healthcare providers, that is the hospitals and the clinics, but I'm really talking about the entire ecosystem. We need to get employers involved in healthcare. Employers have a very important role to play in the health and wellness of their employees. We need to look at programs that they can be incentivized to work on so that we can reduce the risk of getting cardiovascular disease, the risk of getting diabetes, the risk of having strokes. Today, a lot of the research we found around cardiovascular disease is that it's not a disease of 60 plus. It's happening as early as 40 plus. So which means we need to get cardiovascular screening into the primary care system and not wait to go and see a cardiologist for a specialist screening. How do we do that? We need to change the primary care setting. We need to have more telemedicine and virtual clinics that can help that to make that transition. So in my opinion, we're actually going into a very, very interesting world where there's going to be many more stakeholders than ever before. In my view, there's never going to be a healthcare company anymore. Anyone can be a healthcare company. It doesn't have to be only focused on someone producing pharma drugs or making devices. It could be so many types of services that are required for the healthcare company. For example, in the US, we work very closely with Uber to provide healthcare services in terms of logistics for senior people who cannot travel. So would one ever imagine a logistics company getting involved in healthcare? Similarly, we have a lot of mobility and automotive companies now getting involved in healthcare as well. So in the future, we're going to see a tremendous convergence of different industries, and the ecosystem of healthcare will not be only be the responsibility of healthcare providers, but the responsibility of many, many different parts of the ecosystem. Healthcare is going to become a community sport, in my opinion. We need to bring healthcare to the people rather than bring the people to healthcare. And that is the transition and change that we have to work to make that infrastructure and that mindset transition.
Thank you so much, Renita. And that example that you gave of Uber is a great example of a new, innovative approach to collaboration and partnership with an eye at trying to close the gap in terms of access to healthcare, even for, and especially for, the aging population. I want to bring Professor Byrne into the conversation. You know, Jed, our organization, the Global Innovation Hub, was actually born out of the pandemic. We were established in 2020, which we all can remember was the start of the COVID-19 pandemic. And as we look ahead, as Renita, you know, Rob, they've all touched on looking into the future, there's going to be an increasing complexity of challenges. And so, you know, what global health challenges do you anticipate, and what role can international collaboration do to better prepare us for those challenges? And, you know, last but not least, I know we were emailing back and forth, I would really also like to know how we can account for the health workforce and capacity building, because we can have these great plans, strategies, but how are we building the capacity of the health workforce to move these very ambitious visions forward?
So a 2-minute answer.
You can go a little bit longer. We have some time.
So let's spell out what the issues are, or the big issues. So we've got the increasing threat to planetary health, climate change, the impact on health and well-being. We've got the global health security issue. We've got equality, access and affordability and decolonisation, which I think is particularly relevant from the system that we've got at the moment. And then we've got workforce and the big gaps in workforce. Now, anybody who thinks that an individual nation on their own can solve those 4 problems is not really living in the real world. And I think reality dictates that collaboration and partnership are the only way forward for universal health coverage, particularly. So what does that look like? Well, certainly I work in one of the oldest and certainly the largest universal health coverage systems in history. And for us, partnership, which we've thought about a lot over the recent years, comes in 3/4 broad forms. So the first is a government-to-government relationship, and the importance of healthcare systems on a national level and a regional national level working together very tightly. There are no 2 health systems that have the same requirements and same demands, but most health systems have the same long-term goals. And therefore, working together to tackle those systems as either bilateral or multilateral government-to-government partnerships is essential for the operationalisation of collaboration underneath that. The second is institution and place-based partnership, which I think is becoming increasingly relevant. And the reality is that health systems that have, and health institutions that have partners across the world are free to exchange ideas, they're free to knowledge exchange, they're free to innovate in both directions to come up with affordable solutions, and they're also able to solve workforce gaps not just in quantity, but also in quality and development of joint educational programs. And then perhaps the most important one, which I think we've learned over the pandemic, is the importance of frontline peer-to-peer informal relationships so that people can communicate in a very simple and open way with their colleagues across country boundaries. And maybe if we'd had that level of communication, we mightn't have been stirring with quite the impact that COVID-19 had in 2019. So the final point, which is the bit about workforce, let's just take a look at Western universal health coverage systems. We've been so good at keeping people alive that we now have median ages in universal health coverage where the average age is such that we don't have enough young people to deliver healthcare at the standard that we want moving forward. In complete contrast to that, we have emerging nations across the world who have sub-educated young populations who, if given the opportunity and time and investment, could help overcome, in partnership with the older universal health coverages, the workforce deficiencies that we see at the moment. And I think partnership is the key, because realistically speaking, one way throwing money at the demand side is non-sustainable. And it's time we paid the transfer fees, effectively, as a football analogy, and made partnerships on a peer-to-peer and an institutional level, which provide sustainability in the medium and the long term.
Thank you, Jed. I want to go back to one of the points that you mentioned, which is in terms of access to this peer-to-peer exchange in communication. And one of the elements that can foster or facilitate that is innovation in how we communicate. And so I want to actually pull in Dr. Suchi into the conversation now and give a preview to the audience as well. I have a few more questions here, but if you would like to ask a question to the panel, we should have time at least for 1 to 2 questions for the panel after this discussion, so you can get those ready. So Dr. Suchi, I think we have a competition here on the audio, but that's okay. One of the innovations that really carried through, especially in the pandemic, was growth and expansion in telehealth, right? So when we think about how that's come to the forefront, what are the opportunities and challenges that presents? And then even more broadly, obviously you're the co-founder and executive director for the Mesh Incubator. How are you thinking about and being strategic in how you identify, foster, and try to support innovation?
It's a great question. Thanks so much for having me, first of all. Great conference, and it's an important question. So whenever we see a trend that in and of itself is a value driver for multiple other trends that we talked about today. So you talk about access to care. Well, if someone lives in a remote area, not in a city, telehealth is going to be the main lever you're pulling on for that. Talk about our aging population. So seniors who might not be able to come to the hospital or leave their house. Telehealth and telemedicine is a way to alleviate that and provide health care. And then we talk about one we're really interested in at Mass General Brigham is hospital at home. So the ability to provide hospital-level care in your home. That means inpatient visits, all the typical monitoring tools, but also telehealth visits around the clock and connecting to your surgeon that you just had surgery with around the clock. So for us, we think this is going to be $400 to $500 billion market in 2030, 2032. We're really interested in it, but there are challenges. In the United States, and it's different between countries and systems, but reimbursement is a huge problem. Before COVID, true parity for telehealth services, there were only 6 states of 50 that offered that. After COVID, we legislated some temporary stuff, but it turns out nowadays there's 14. So if you can't get payment parity as a hospitalist or a doctor, are you going to provide the same level of care and time for a telehealth visit? Maybe, maybe not. One of the issues with getting reimbursement, though, is one of the value drivers for telehealth is it's supposed to be lower cost. And all of a sudden, if we're starting to do payment parity, it loses that value basis. Another one is diagnostic accuracy. So is telehealth as accurate as traditional inpatient care? For bread and butter cases, probably. But there is a subset where it might not be. We also have potential overuse of testing. Someone injures their ankle, sees a telehealth visit, they might be more likely to get a CT if a doctor is not there to evaluate you. But more importantly than that data is that 40% of the population, at least in the United States, has concerns about telehealth visits and the quality of their visit. So when you have a trend, we have a very minimal time when an emerging trend comes to change that mindset before it becomes locked in stone. So it's on us to do the research and to educate the population. Wrapping up, digital literacy is a big one. We can't expect to, even logging on to a Zoom visit could be very difficult for some people. And so there's a digital barrier using digital tools which are necessary for telehealth to actually implementing that care. Lastly, I'll say the technology, so the tools we're putting in the home. I'll give you one example from Mass General. So we have a very large hospital at home program, and we're noticing that when we had patients getting surgery and we sent them for hospital at home care, so home care, sometimes they had catheters, drains, and when you're walking around at home, you're much more likely to snag that drain on a doorknob, pull it out. That means you have to go to the ED. EDs are overcrowded. So we saw that problem that's unique to hospital at home, and we created a special device to allow these drains, when it detects tension, to release. And then they could be reattached by the patient. So knowing the different technological needs of treating patients not in the hospital, identifying those, we patented a device, we licensed it out through the Mesh Incubator. That's going to be very important for this market in the future as well.
Thank you so much. I think we'll round out with one last question for Dr. Al-Yamani. Last night, and actually again today, in both of the speeches that I've heard you give in the past 24 hours, you've talked about this concept of the digital twin. And, we think about the growing trend or interest in the digitalization of health records as a key trend that a lot of health systems are trying to adopt. How can we ensure, or how at NEOM are you thinking about data security and privacy in this ever-connected healthcare world?
Well, thank you very much. Very critical question at a critical time. In fact, while building the system, we have to make sure that we not only abide by the current data security measures, but also predict what's going to change in the future, because with every layer of a system, of a digital system that you add, comes a plethora of risks of data violations and hacking and all of that. And so one major element in what we're building is ensuring that there is data security. Now, just to add to that, this is a tremendous platform. This is a platform that I don't think the world has seen yet. And on top of that, generative AI or even super AI in the near future would be needed to deal with all of that data. I am actually more concerned with the power consumption of that AI than I am with the data security, even though we are heavily concerned with data security. But I would say that we're putting everything in the system to secure data. What we are really worried about is how are we going to generate all of that AI with reasonable cost, with reasonable power consumption that makes it actually practical.
Thank you so much for that. I guess now we can turn to the audience. We have some time here for questions and answers with the panel. Just a quick few points here. Please raise your hand if you have a question. If and when you ask your question, if you can let the panel know whether you're directing it to one, two, or all of the panelists, that would be greatly appreciated. Letting you know in advance, we probably won't get to everyone, but we're hoping to at least get one or two questions before we let this great group of panelists go. I see one hand over there.
Assalamu alaikum. Thank you for today's talk. It has been extremely insightful. So my question is towards the full panel, to whomever chooses to answer. In terms of the current mental health situation at the moment and the future of mental well-being, what policies or tactics or technological integrations are you putting into place? Thank you.
Who would like to start on this one? Just to reiterate or restate the question, it's within the midst of increasing focus on mental health and mental well-being. What policies, practices, resource allocation should be the priority as we think about accounting for mental health and well-being moving forward?
Should I go ahead?
Of course, Renita, you're welcome.
Okay. So I think for the research that I've done, I think the first thing is that we have to build awareness on what is mental health and what is not mental health. And we have to create a community structure towards that. There's a lot of myths and taboos around mental health in every part of the world, I can tell you. And I really believe that we need to have a gender-specific mental health policy, because the way women suffer from mental health is very different to what men suffer from it. Women suffer from postpartum depression. They suffer from depression through menopause, the impact of their hormones. We've done lots of research that show that there's sublying conditions around mental health biologically in a woman compared to a man. Also, the incidence of mental health is more in women today than in men. So I would recommend a gender-specific strategy towards mental health. I also think that there are various ways. There needs to be an omni-channel strategy of mental health, not just mental health in person, mental health in the community, near the mosque, near the school, not just limited to just the hospital. We need to increase the number of therapists and doctors and professionals treating mental health, especially in emerging markets. The numbers are still very low. So we need to increase the number of professionals and clinicians to get into this field. I also believe that there's a lot that needs to happen in terms of education, and that can start from the school level, talking about mental health and wellness. I think one of the work that I'm working on is in the area of self-care. I think we have to reinvent what self-care is. Self-care is not having bubble baths or massages, but really taking a look at how you take care of yourself from a health point of view, from a fitness point of view, from a sleep point of view. We need to start changing the environment around issues on food. Food, in my opinion, today needs to be looked at as medicine. Sleep is medicine. So there are a lot of things from a wellness and self-care perspective that needs to happen, and this, I think, can only happen through awareness and education campaigns.
Dr. Al-Yamani?
And if I may add to that, we're not going to be concerned with cancer and cardiovascular disease when people reach the age of 100. It's actually going to be mental health. And we're trying to put everything together so that we can extend healthy lives. But have we thought of what healthy life is? I mean, mental health is an essential part. And if you look at people when they age, they tend to isolate themselves. Now, what happens when a lot of people are aging and they're isolated? It's actually the pandemic then will be mental health, will be a mental health pandemic. We should be prepared ahead of time on two dimensions. One is on enhancing technologies to detect mental health problems very early on, enhance technologies to even predict mental health problems way before they happen, but also build capabilities to deal with these mental health problems, because I think this is the next pandemic. The next pandemic in a couple of decades is going to be a pandemic of mental health in an aging population.
Jed, please.
Yeah, so just three very brief things. So the first thing is I think it's really important not to confuse the health and well-being paradigm with mental health, even though they're obviously clearly very related. So I think there is an issue that us baby boomers and Generation X have with health and well-being, which actually millennial people have a different mindset about. And I think we have to acknowledge and accept that. So that for Generation X, health and well-being and public health is about all the things that you like doing and then putting do not in front of them. Okay? But millennials don't think like that at all. And I think we should be celebrating and starting to create narratives and culture around the positivity of health and well-being, which I think, I'm going all the way back to very, very early education is key. I think that the mental health issue is a worldwide problem. And I think one of the solutions is not to think about mental health intervention as a siloed professional activity, but as a responsibility for all health professionals. And I think that we need to think about task shifting and skill shifting and making sure that all of our health professionals are aware diagnostically, at least at a basic competence level, to identify deteriorating mental health and to understand the navigation across a mental health system for those people who may need an intervention at one particular time. So those two things, I think, keeping positive about health and well-being and making sure that everybody understands mental health to a degree.
Thank you so much. I think you all touched on the importance of ensuring that mental health is included moving forward into the foundational building blocks of how societies talk about health. And as a result, the health systems are designed to incorporate that within the very fabric of health education, workforce training, and also in the delivery of care. This also connects back to your point, Rob, earlier around thinking beyond treatment and what happens after, and how are we accounting for well-being after someone leaves the hospital, after they receive care. So a more inclusive, holistic approach to health altogether. Yeah. I think I saw one other question in the audience. If you can just raise your hand so they know who to go to, that would be helpful. There you go. There he is. Oh, yeah.
Kurt Kammerer from Data Vaccinator. You were already referring to a situation where we are hitting a dead-end street. Islam was making the point on doubling the cost of the existing system if we continue as is, and Renita was making the point on putting 80% of the budget into sick care instead of healthcare. You already started referring to my question, which is, do you have concrete incentive schemes in mind for the children, for the adults, for the systems as they are, in order to emphasize health and de-emphasize sickness in the scheme itself?
Thank you for the question. I don't know if a panelist wants to take this one on. How are you factoring in effective incentives to, I think, catalyze behavior change across a population as a way of proactively getting individuals to prioritize health, almost incentivizing people before they become patients as a means of taking some ownership in their health, but also reducing the costs that are rising across healthcare systems?
I can contribute if that's okay.
Always welcome.
So some of the work that we've done is largely with employers, companies like IBM, Microsoft, and other companies that incentivize their employees to be able to have take fitness tests on regular basis, which helps to reduce their insurance, but also gives them some amount of bonus dollars to spend on other things. So if you're a non-smoker living in a non-smoker house, you get certain incentives. If you exercise 4 to 5 times a week and are not on any blood pressure medicine, there's certain incentives. So really what we're looking at is an environment of similar to the Air Mile program, the Health Mile program. And so you gather miles as you go along, and those are the incentives to health and well-being. Now this is largely in the employer market that many companies have done it for their employees. I'm not sure if anyone else has other experiences of how this works.
If I may, I'm a bit concerned about the approach of employers incentivizing employees. I mean, what's the life duration of an employee in a company? Quite limited, isn't it? Or what are we talking about, 5 years, a decade? They will be interested in preventions that would serve the employee during their employment. I'm more keen to an overall health system that actually is responsible for these individuals as they age. And so the ultimate goal would be to prevent on a very long term. Now, referring to employers might affect the case if it's a commercial insurance system where the insurance companies would cut deals with employers on certain incentives and certain parameters that their employees are at. But the wider system, the bigger system, and if we're looking at people living to 100 years, I don't think relying on employers' incentives is enough. I think what we need is an insurance system, whether that is a public insurance system or a private insurance system that signs long-term deals to keep people healthy until the age of 100. And that is again, the innovative approach that NEOM is taking in building its own NEOM health insurance system, that even though is a private insurance system, a commercial insurance system, it is responsible for the population over a very long time. So it's not the responsibility of the employer, because we can change employers, but it's the responsibility of the ecosystem.
I may comment in one minute, and I totally agree with you, Doctor. And honestly speaking, the technology started to be there, but I think the culture and the changing mindset was what is needed, really to embed it in people's mind and the new generation that this is what we should invest. And as companies, we need to quantify things. What is the dollar value if we allocate part of the budget instead of treatment into the prevention? Sorry to share this example, but I think the changing mindset is key. I remember when I first bought mobiles for the smartphones to my parents, I was thinking that they will never use it. They will don't know how to use it. But now they use it better than I do. Right? So the changing mindset is really important. Telemedicine and telehealth is what is coming next. And people need to change the ideas of classically going to the hospital into care about their well-being and quality of life. And this is, as Dr. Yamani will say, will come in years and years and generation over generation.
We're going to go with Rob and then Dr. Suchi.
Yeah, just a comment. I can't really speak to the policy side of things in my role, but I think that technology has a key role to play to make things easier and more accessible. And I think that's often one of the aspects that unlocks healthcare and also the experience the patients go through. If you look at mammography scanning, for example, this is well proven to save lives. If a woman has early breast cancer screening, the survival rate for 5 years is extremely high. But it's scary that 40% of women choose not to have scans because the experience and the process they go through is not something that's very enjoyable and actually an intimidating aspect. Similarly, cardiac scanning. I haven't been for a cardiac scan despite the fact that I work in healthcare for years. And I will take my car every year to have a service, but I don't take my body every year because actually I can never find the time, it's too difficult. But with new technology, the ability to be able to do simple ECG scans, to be able to get one-stop rapid clinics where you can actually go and get a whole range of tests done in half a day, these type of things actually give more access to healthcare. And if people are anything like me, it's not that you don't want to do it. It's just you haven't got the time and something always more important to do. And that's encouraging people to actually take more responsibility for their healthcare, but also make it easier for them to take more responsibility as well.
All great points. In some ways, in the US, we do incentivize health systems to provide preventive care. And so, you can't bill for a primary care visit unless you ask specific questions about risk for drinking, smoking, drugs, all this stuff. And so that's, in one way, we do this. It's not necessarily the most effective. I think the problem comes when trying to find people who you don't know about, who aren't in the system, who haven't made it to the hospital. How do you incentivize them to have an outcome that never happens. It's very difficult to get that mindset. And it wouldn't really be fair for government or some sort of organization to say, okay, you stayed out of the hospital for a year again, you're 30 years old, here's, whatever, some dollars. So I think while we ask for concrete incentives, another big trend is the consumerization of medicine and patients as consumers of their own health data. It basically touched on every single speaker's talk today. And so empowering patients with their own health data, which is going to leverage remote monitoring, which is going to leverage telehealth, and of course, which is going to leverage generative AI and AI in general to analyze their own health data. And so from a younger age, at least, giving this health data to the patients or to the patients to be could help extend that trend through to when they come in the hospital system and have general better lifestyles. And the last thing I'll say is, you talk about 23andMe or genetic testing, right? That consumer data, knowing your genetic risk profile, can then be used to alter it, get more mammograms maybe if you have a specific gene, change your diet if you have the ApoE4 gene for Alzheimer's, so stuff like that as well.
Thank you all for those responses. I think in a question around incentivizing behavior change, incentivizing different segments of the population, I think you all also touched on different methods, approaches for developing a more empowered society, a more empowered individual who has access to knowledge, data, resources, so that they can decide whether they want to take the car in for a tune-up, Rob, or if they need to leverage that data, Mark, to think about where and how they need to change in order to ensure they can lead a long and healthy life. And so I did say in advance that we weren't going to have all the time for questions, and so unfortunately I'm seeing a red clock ticking away the seconds until we have to conclude. But on behalf of the organizers for the Global Health Exhibition, I'd really like to take a moment to thank our panelists for their contributions, for their expertise, and for their knowledge. Thank you so much for being with us today. We're going to conclude right now. We'll have a brief break, and then we're going to come back in a little bit for another session to introduce and launch a brand new landmark report on high-value health systems, an investment in the 21st century. So looking forward to seeing you all in a little bit.
Thank you.
Thanks for our guest speakers, and now we are going to start session number 8, High-Value Health Systems in the G20 and Investment in 21st Century Health, Opening Context of the Study and Partnership with Harvard. Our speaker is Dr. Reem Al-Banyan, Executive Director of the Global Innovation Hub.
السلام عليكم. Good afternoon, and hello, everyone. It's really a pleasure to be here to give the opening remarks for this session. I lead the Global Innovation Hub for Improving Value in Health. The hub is an outcome of the work that we did in the G20. It was born in the year 2020. In fact, during the pandemic, we discussed high-value health systems at the G20 table, and we confirmed that health systems globally are facing the same challenges and trying to answer the same questions. The hub is an accelerator. It's a knowledge-sharing entity that is membered by the G20 countries, guest countries, the WHO, the OECD, and the Islamic Development Bank. We serve as a knowledge-sharing entity. We serve as a voice for health system transformation, and we are a connector. And we're delighted to be here today to be launching an important flagship paper that we did in collaboration with Harvard University School of Public Health, and our partner, Professor Atoun, is with us today. This is a landmark paper that it's entitled High Value Health Systems in the G20 plus country. The initiative came after we had the original discussion in the year 2020. And the report done by colleagues at Harvard includes detailed country reports, case studies, and it details the 10 elements of high-value health systems, which we will be hearing about shortly. I would like to thank Professor Atoun for being here and for your partnership and collaboration through the years, and especially in this piece of work that you'll be hearing about. And I'd like to, with that, welcome you, Professor Atoun, to your remarks.
Good afternoon to all of you. It's a real privilege to be here, and thank you, Dr. Rima Al-Bunyan, for inviting me to present our joint study, the Health System Innovation Lab at Harvard University and the Global Innovation Hub. So we undertook a very detailed analysis of the introduction of high-value health systems in G20 plus countries. These are G20 countries plus some other countries that are not members of the G20. And we share with you the findings and the framework that has emerged from this study, including some detailed case studies of some of the innovations that are emerging in this area. So the operative word here is high-value health systems, which is different, related to, but distinctly different from high-value or value-based health care. We heard in the earlier panel the emphasis on prevention. So we focus on health and high-value health systems, not just the care element. So it's instructive to start with understanding of value. What do we mean by value in health systems? And how do we recognize a high-value health system when we see one? Well, 2020, as Dr. Al-Bunyan has mentioned, was an important turning point. Because for the first time at a G20 meeting, value-based healthcare was discussed, and as part of the Ministers of Health and Heads of State declaration, high-value health systems were acknowledged to be a critically important component of achieving universal health coverage, but also ensuring sustainability of health systems. And in the Saudi presidency, the heads of state also called for the establishment of the Global Innovation Hub for improving value in health. And the work I'm going to present is a product of this collaboration with the Global Value Hub. So what is a high-value health system? Well, a high-value health system is one that is able to produce, using the functions that a health system has in terms of organization and governance, in terms of financing, and in terms of effective management of resources, to produce a set of outputs at individual level, individual healthcare services, and at public health level, at individual subpopulation and population level, a set of outputs that are effective, that are delivered efficiently, that are equitable, and that are responsive to needs of the citizens, but also the changing context. We heard in the earlier panel how this context is changing very rapidly with aging populations, multimorbidity, economic crises, political instability in many countries. On the other hand, real innovations coming through in health systems. So these health systems that are able to produce outputs that are effective and efficient create value for money. But if these outputs are also equitable and responsive to citizens' needs and expectations, then we also create value for many. So everyone benefits, not just a few, in order to improve health outcomes, ensure financial protection, and ensure user satisfaction. So using this framework, which is actually the framework we use to teach master's graduate students at Harvard on the health systems courses which I teach, and also the framework which we use when analyzing health system performance and designing health systems, we use this framework to understand how are countries in G20 transitioning to creating value. And the findings were very interesting. We used this is the first time such a study has been undertaken, and the report is being launched. We used interviews from members of G20 countries with detailed case studies that we're developing, also desk research on all the publications related to value-based healthcare or value-based health systems. We also tried to assign a score in relation to the components of a high-value health system, which I will talk about, to try and understand where countries are and what they need to do to improve their transition to high-value health systems. And we are able to present reports at country level and in relation to each of the components. And our analysis at systems level, because we are very interested in ensuring that systems are able to move to creating value for everyone, and not just in one clinic or in one hospital. This is the major emphasis of our study. So what did we find? Well, what we found was something very interesting. Looking at all the countries, looking at the cases that are emerging, we're able to identify that there are 10 components that need to be in place in order to transition to a high-value health system. The first is digital data systems. But that's not enough. We often collect oceans of data, but these data are not analyzed. So second component is analytics, and ideally real-time analytics that can tell us what is happening across the care journey. Third is measurement system for measuring costs. In many countries, these do not exist. Fourth is measurement systems for measuring outcomes to ensure that these are harmonized, so we can compare one outcome with another one. Fifth is benchmarking. Benchmarking how a clinic, how an institution, how a network, or how a health system is doing over time, what we call longitudinal benchmarking, and how that country or an institution is doing relative to others, what we call comparative benchmarking. Sixth is, very important, integrated care pathways with bundling of services. So we're able to move away from episodic reactive care to management of integrated care provision across the whole care journey. Seventh is creation of incentives through value-based payment methods. So we're able to remunerate achievement of good outcomes and high-value outputs as opposed to just paying for inputs, which may not necessarily lead to high-value outputs or the outcomes that we desire. Eighth is value-based procurement. Very few countries have been able to transition to value-based procurement. And my colleague, Gabriela Prada, will talk about this in more detail. Ninth is integration of care provision. This doesn't mean structural integration, but actually integration through care pathways to ensure that the whole journey across the care continuum is managed seamlessly with a focus on the individual, so we can deliver person-centered care at home, in the community, at primary care, at intermediate care, in hospital, or in rehabilitation, or in palliative care. This needs to be seamless through integration. So I won't talk about why these are needed. So what we've done is to map how each country is doing in relation to each of these components, how far they have progressed against best practice or what other countries have been able to achieve. I won't go into detail, but as you can see, some countries are doing fairly well, others are not doing not so well. And you can look at these in the report that will be available on the website at Harvard, but also at the Global Value Hub. But I think the most important findings in our study was when we began to look at case studies, going really deep to understand what is happening at country level. And what we saw is that value-based healthcare is not a rigid set of activities. You have these components, but these components can be brought together at department level, at institution level, at multiple institutional level, through networks, or at system level, and it can be applied using a therapy, or a therapy plus solution, or to a single episode, such as hip surgery, or multiple episodes, pre-hospital, hospital admission, post-hospital admission. Single disease, for example, diabetes, or multi-disease bundle, for example, cardiovascular disease, or for the population as a whole. So what we have is a canvas for innovation in health systems. So the high-value health systems approach enables us to deliver these solutions to achieve high-value outputs in order to improve outcomes for the system as a whole, to create better value for money and better value for many. So we're now completing a series of detailed case studies, which I'll share with you, that are operating at departmental or institutional level and at different levels of interventional bundling. So for example, in Catalonia, in Spain, okay, sorry. So in Catalonia, we have, they've implemented a network of providers that manage arrhythmias, not just the hospital process of implanting these defibrillators, but also pre-admission, but also post-discharge, with data collected real time to manage complications. And the data center is somewhere in Spain, but managing a network of providers. And this has been extended to other parts of Spain, but also other countries. In Singapore, the starting point was with hip fractures, starting with a department, then moving to an institution, now to multiple institutions. In Portugal, there's a network of surgical providers providing cataract surgery, just focusing on a single procedure. In Stockholm County in Sweden, which has been one of the leading centers for high-value models, initially the focus was on spine, hip, and knee surgery at one institution at Karolinska, and this was then extended to other institutions. In Catalonia, again, they have a very interesting approach where they're managing a network of healthcare providers, the operating theaters of healthcare providers, to optimize the capacity with the right surgeon, with the right team, with the right patient, to reduce waste and to improve outcomes. And this is real time. In the Netherlands and also Saudi Arabia, there is a focus on improving diabetes care, initially focusing on type 1 diabetes, to manage complex cases where it's been difficult to achieve care. And in Ontario, Canada, which my colleague will talk about, Ontario has been able to introduce in South Lake Hospital Network a program for strategic purchasing, value-based purchasing for cardiovascular disease, not just for one condition, but for multiple conditions at institutional and multi-institutional level. And in Sweden, they've been able to move from hip, knee, and knee surgery to managing multiple interventions. And finally, in the UK, NHS England, they have transitioned to population level for managing multiple conditions with great incentives for primary care providers. And up to 25% of the income is based on performance. So we're seeing a transition and creation of new approaches that create higher value for money, but greater value for many that leads to better health outcomes, greater financial protection, and better user satisfaction. Thank you very much for your attention.
Thanks to Professor Rifat. Panel discussion, the High Value Health Systems, HVHS study, strengthening health systems and value-based care global outlook. And the moderator for this session is Mr. Ebele Anidi, Director of Partnerships and Engagement, G20 Global Innovation Hub for Value and Health, Riyadh, KSA.
Yeah.
Hello? Okay. Can everyone hear me? Okay, great. Whew. Third time's a charm. Let's see here. We're working our way through. Wow, this was thorough. There we are. Okay. Hi, everyone. Thank you so much, Professor Atun. I'm sure your keynote could have been longer, but you're going to be on stage in a little bit, and you'll be able to speak to a little bit more. But thank you so much for that address. For anyone who's in the audience or new to the audience, my name is Sabele Anidi. I'm the Director of Partnerships and Engagement for the G20 Global Innovation Hub. As Professor Atun noted earlier, we had a wonderful partnership in pulling together this landmark report. And before I introduce the rest of the panelists, I actually invite them to come up stage and join me. So Gabriela, Professor, please. Wherever you sit, you won't be able to avoid my questions. So wherever's the most comfortable for you all. For the audience, we have an amazing, distinguished panel for you today. Their collective knowledge and distinct experiences across academia, government, and the private sector, hopefully, will provide a comprehensive yet diverse range of perspectives on the importance of taking this moment to reimagine health systems with a focus on the principles of value-based care at the center. So today, in addition to Professor Atun, we're joined by Gabriela Ramirez, who's a health policy advisor for the Argentina Ministry of Health and a G20 representative as well. We're also joined by Gabriela Prada, who is the Senior Director of Global Health Systems Policy at Medtronic. So we're going to start with a panel discussion. It'll be followed by a Q&A. And so as you're listening to the dialogue and you're thinking about questions asked for the panel, please hold on to them and we'll get to them in a little bit. But let's dive in. So to start, I'd love to ask both Gabrielas to maybe take a chance to introduce yourselves, your organizations, and provide a brief overview of your respective institution, as well as your perspective on the potential impact for the transition to a high-value health system, what impact that would have within your particular line of work or within your particular context. And I'd actually love to start with you, Gabriela Ramirez, if you don't mind.
Thank you very much. Please first let me thank the incredible hospitality here. I'm really thrilled to be able to join this panel and share with you all about Argentina's health system. Is really a great opportunity to share with other panelists and the audience what our experience is, and also here learn from the Saudi experience and all the other talks and panels that have been so insightful. So really want to thank the Global Innovation Hub for the kind invitation and the Saudi Arabian Kingdom for this generous hospitality. And I'm a health policy advisor, as Abella has introduced me. I work as a G20 representative for my government, and the representative at the health track. I have some experience on public health and public health policies, and I've been working at the Ministry of Health for many years, both on planning, implementing, and monitoring and evaluation of public health programs. And now I get to, for the last years, be an advisor at the Ministers Unit, and also having this possibility to have like the whole picture, you know, of all the different areas where the ministry has established their priorities and their areas of action. So I think it's this discussion, to have the benefit of joining this study was very timely for us, because for the last years, even before COVID, our health system has identified by different stakeholders, all the stakeholders, not just the Ministry of Health or the provincial ministries. There's a demand that needs to be filled, and that is to sit and rethink among all stakeholders, private sector, public sector, academia, and especially the R&D and innovation ecosystem, that, you know, we need to rethink how we can transform and obtain value, not just individual value for patients, users of the health system, but also a community value, you know, for each health subsystem. As a federal country, we have 24 subsystems, and each province is in charge of, and they have their stewardship also, to organize healthcare and healthcare providers and the networks. So the federal level has an oversight and a stewardship role that also needs to address inequalities and disparities among those 24 subsystems. So we are in a very nice time now that when all the different actors and key actors in the system are demanding for a change and a transformation for a more effective, more efficient, high-value health system. So that's the main interest, and that's why I'm really so thrilled to listen to other colleagues here to talk a little bit more about progress on high-value health systems.
Thank you so much, Gabriela. And moving to Gabriela Prada, would just love to, and for the audience, to get a better sense of your work at Medtronic and where and why you think it's so critically important to be not just talking about, but actually working with countries to move the needle towards this new paradigm of high-value health systems.
Thank you. It works? Can you hear me? No? Yes, okay, thanks. I cannot hear myself. So thank you so much for the invitation, and you know, it's a great pleasure being here. So you asked me to introduce myself and to put value-based healthcare into context. I am a physician, but I'm madly in love with policy. I really feel that we can help populations and entire countries if we get healthcare right. So about 15 years ago, I was Director of Health Innovation Policy at a policy think tank, so we did policy research, and I was very interested in understanding what was the benefits of value-based healthcare models and how we could translate value-based healthcare principles into public procurement practices. And why was this important? Because we keep talking about value-based healthcare, but I live in a country, I live in Canada. We have a national health system where it's 99%, almost 100% public, where if everything goes through public procurement. So if we don't have a framework within procurement to start purchasing for value, nothing will ever change in healthcare. And I find that traditional procurement approaches really continue supporting the disease-based frameworks within healthcare, but they don't necessarily purchase value. So this was all my interest. So I was very fortunate. About 7 years ago, I had the tremendous opportunity to start working in the private sector and enjoying the Medtronic family, which now I have the opportunity to see how value-based healthcare looks on the private side. So, happy to share some of the stories. So just to put things into context, Medtronic is a very large medical technology solutions company, over 95,000 employees in over 150 countries, one of the pioneers in value-based healthcare with many clinical care pathways in different streams, and I'm happy to talk about them a little bit further in detail.
Thank you so much, Gabriela. I want to bring Professor Atun back into the conversation. Again, appreciate your keynote. In the wake of COVID-19, which we're still living through, and with an increasing number of complex global health challenges, whether it's AMR or climate change, across all the different avenues that governments should and could explore, why should countries invest in this transition to a high-value health system model?
Yeah, excellent question. I think that's a question every country is trying to answer. Why? Well, the reason is because if a health system produces outputs that are effective and efficient, one can create better value for the resources that are being put in. Secondly, if one can create greater equity and greater responsiveness to the changing context, such as AMR or climate change or a pandemic that we experience while we're doing the G20 here in Saudi Arabia, or citizen expectations, and one can create value for many, for everyone. And that is a prerequisite, that ability to respond is a prerequisite for creating sustainable health systems. A sustainable health system is a system that is able to respond to changing threats or opportunities, but one that is also resilient, that can maintain that responsiveness over time. So jointly, one can develop a sustainable health system. So high-value health system is not a luxury. This is something that every country needs to transition to, because resources are limited and the demand is increasing and the context is ever-changing. But of course, the devil is in the detail. How do we do that? And this is what our joint work is showing us, that countries are approaching this in different ways. So there's a lot of opportunity for innovation to develop made in Saudi Arabia solutions for problems that Saudi Arabia is facing, or made in Canada solutions for challenges that Canada is facing, as I've illustrated in different countries.
Thank you so much, Rifat. I think you're touching on elements that, again, in our shared report, this idea of the future design of health systems needing to be not only efficient, effective, but also responsive and equitable, and that being a fundamental building block and foundation for health system, sustainable health system design moving forward. And to this point of a responsive health system, and maybe even reconnecting back to the the pandemic, I want to actually pull in Gabriela Ramirez. Argentina contributed to the study. Actually, Gabriela was one of the first people to respond to our outreach to contribute to the study. Argentina has been a great involved and engaged member of the Global Innovation Hub from day one. In the country profile, in the report, we purposely introduced a case study and spotlight the National Digital Health Network as an example of some of the strides that Argentina has made in advancing digital health. And so would just love to hear from you, how has this digital platform accelerated improvements in the overall value and quality of care in Argentina?
Well, I'll try to be thorough, but there's so much also that has happened after we provided all the information, because the National Digital Health Network is just one milestone, is a part of the National Digital Health Strategy, which, or a component, if you might say, and the most basic and important one, because it's the one that provides interoperability for all the different stakeholders, just providers and also patients. We have this interoperability bus that allows every single project, such as a digital clinical record. We have already not just legislated, but it's currently ongoing, the use, the massive use of the digital electronic record and digital prescription. So this network allows us to also provide these solutions in a more integrated way, which is definitely something that, of course, had to coexist with prior solutions, prior technological solutions that were being applied by different provinces, public providers, private providers also. They had their own systems. So the first effort, the first national effort was providing that environment so every different information system could be integrated, data could be shared and flow, and also be something useful not just for expanding access for the patients to have their own data and own their own data, but also ensuring the levels of security and privacy according to international standards, and to make providers and physicians also able to harness, all the features of the different apps and health systems. And so we have this very fragmented scenario where there are many solutions that, every province or municipality tries to get, or innovate in the way they can, and they try to look for a good solution, but then we need everything to get connected. So I think we've made tremendous progress, and this has been a benefit also for the training process of the workforce, because it made, I'd like to be very illustrative with a specific project that COVID sort of pushed us through. The human resource department found the opportunity to launch a program, to design quickly and launch a program. Because of COVID, all the ICUs were crowded and were really collapsed. So the idea to train people, especially in the very distant locations and where the health workforce needed that, updated training, and so telehealth was the means to do this. And they had a 24/7 device that was available for different teams all over the country. From, we have a very extensive country and not very connected sometimes. So this allowed all the physicians and therapists and the health teams in charge of ICUs that had the challenge to manage complex cases to be able to push on a button or call a number that was available to make a telehealth joint case management. And this was something that was available thanks to the collaborative work of professional associations, the National Association for Professionals in ICU, that they had retired people that were available to jump in and become volunteered, providers of training, at real-time training, So I think that I'm really very optimistic regarding, I've heard so much about all the innovations that are coming, but I do know that there's a lot of possibilities because of the solutions that were already implemented and all the potential solutions that can be integrated for our national digital health strategy, such as, I won't get too deep into that, but there is a workflow on including AI, and getting and recruiting professionals on AI to help us enhance health outcomes. From the national perspective, this is a challenge because what we know is that we do need to work on providing support for the different provinces to reduce the inequalities, to train the workforce so people, they have available resources wherever they are needed, and especially so that people do not depend on their zip code to get access to quality health services. So this is pretty much a concept of value, and this is why it's so important to think about, especially from a Ministry of Health, of how you can design and implement different interventions that will help you get there, help you get a sustainable system. I don't want to get too much into sustainable financing, but this is sort of like the major, idea for implementing effective policies, to make them sustainable and to make them efficient, and to help the health system be responsive and adaptable, because we are going to face lots of different challenges, from climate change, as was mentioned before, from AMR, different threats, let's just call, that our system has to be prepared and ready to adapt to responding to. So
I think you're outlining the immense opportunity, but also the diverse range of challenges that are in front of us. But I think especially pulling out those examples that you did in terms of how Argentina is still trying to move the needle beyond the digital health network, but the other efforts that you're putting forward within your ministry, it's really encouraging. And it's a perfect example of the number of encouraging examples that came out of the study that are highlighted in the case studies that are included in the report. So thank you for adding that context within what you're experiencing on the ground and the work that you're trying to take on every day within your position in the ministry. You touched on supporting and navigating and expanding innovation. And in the report, we actually lay out 5 enabling or essential enablers for accelerating that transition to a high-value health system. And I want to pull in Gabriela Prada here. One of the enabling conditions is improving the ecosystem for innovation. And so what role or roles can the private sector, specifically when you think about public-private partnerships, what role can that play in nurturing and sustaining innovation in a high-value health system?
Yeah, this is a great question, and I'm so happy that we are talking about it because I find that in many healthcare systems, and that includes the Canadian healthcare system, when you talk about the private sector, it's like a taboo. You know, you don't go there. It's the private sector. Well, I really think that the challenges in any healthcare system are so complex that the public system alone cannot solve them. And I think, you know, we require to bring everything that we have together to solve these challenges. So from a private sector perspective, I mean, the number one is tons of investments in research and development. Companies like Medtronic, that is an innovation-based company, last year alone, we invested over $2 billion in research and development. Every year, we have over 200 clinical trials ongoing. I think last year was about 236 or something like this. So really, it's investing in the next solution. What is the next way that we can find to solve the challenges of today, and how this is going to help us to get to better outcomes. So I think that focus on looking for the next solution and trying to do it better every day is a big important part of the puzzle. Now, when you do this, you create an ecosystem, right? So there is a lot of small and medium enterprises in different areas that might feed from that energy, and they also, you know, enjoy the benefits of working with companies like Medtronic. So it really, there's a spillover effect into the academic circles, the small and medium enterprises, suppliers, you know, hospitals, teams, all of these benefit from that energy into looking for those new solutions to challenges. But I think other than that, there is a big aspect as well on capacity building. The private sector has a lot of know-how and technical expertise that we can transfer to the public sector. In fact, it's a lot of, I mentioned that we have quite a few clinical pathways in different diseases where, you know, we work with the clinical teams trying to identify which patients can benefit from these, trying to select, you know, what are the right technologies for the right patients at the right time, and follow them over time to ensure that not only immediately after a procedure the outcomes are better, but how about 6 months or 2 years from now? So, you know, there is all that technical capacity and expertise into how to document outcomes, how to best build some of the building blocks that Professor Atun mentioned. This is some expertise that the private sector can offer to the public system. And I think that's actually quite fundamental, because in my experience, you know, all those elements are critically important. If I would have to rank them, I would say leadership, have the courage to change a system, because changing healthcare is not easy. So having the right leadership is essential. And then number two is making sure that people have the right tools, the expertise, and the know-how to execute the change. To me, those are the two most important ones. So I will not underestimate the role of the private sector in helping the system get ready for that.
Thank you so much, Gabriela. And actually reminded me of the last time you and I were together with Professor Atun was in in Boston, for the executive education course for high-value surgical systems. And so when we think about capacity building, that's a great example. I think Takeda was involved, Unitar was involved, different partners coming together to bring surgeons from all over the world to learn from one another, to learn from examples from the private sector, from the public sector. And so we can think about the utility of this report, of the knowledge that's garnered within this report, but how are we translating those lessons, those insights into building the capacity for the very people on the ground to push them forward. So thank you so much. I'm being mindful of time here, and I want to ensure that everyone has a chance to engage with our panel. And so if you have a question for our panelists, feel free to raise your hand. Someone will come with you with a microphone, and you can ask a question of our panel on stage.
There is a prize for the best question.
Okay, we have a few. Well, I actually did have another question ready for this eventual potential outcome, but if you do have a question, feel free to raise it as I ask this one, and I'll keep my eyes open and looking to the audience. But to bring you back into the conversation, Professor Toon, the team for the hub and the team, Che and Jonathan aren't here, but from the Health Systems Innovation Lab, we've been working on this for more than a year. Great experience pulling in a number of examples from across G20. The report's finished, we're launching it today. What are your aspirations for where this goes from here? I mean, I believe in the report. I think the insights are compelling and interesting. Obviously, I'm biased, but
yes,
would just be curious.
Well, I think our aspirations, because this is a jointly conceived and jointly implemented initiative, I think what's very important is to really understand what it takes to transition to a high-value health system in different contexts. This is why having detailed understanding of what happens in each country is really instrumental. And learning from these experiences on, for example, what works in country A may work in country B, but the chances are it's not. So Argentina, I work in Argentina as well. You have healthcare at province level, but you have 300 different insurers. It's a very, very complex system. In policy circles, we say it's not for amateurs. So we really need to understand what needs to change in relation to the organization of the system, in relation to the financing, in relation to resource generation and its management to produce these new sets of outputs. And what of these 10 components are in place and what are missing? So we can begin to put in place each of them to transition to changes at system level. Because the danger is that we create point solutions in one institution or in one department or in one province, but the population doesn't benefit. And we actually reinforce the inequalities that exist. In fact, there's a risk that we may widen them even further, especially with application of the digital and AI solutions, which will augment everything and will ensure that everything happens quickly. But the danger is that that divide widens. So objective going forward is to really understand how can these components be put in place in different settings and what the starting point of a journey might be. What is the problem? Where do we start? And how do we move forward? So that cross-learning is going to be the critical next step.
Thank you so much, Rifat. We have a question from the audience. Thank you in advance for your patience. They're coming.
There you go. Here.
Right.
Good afternoon. I treat many patients with knee osteoarthritis. It seems the going rate outcome is to have the knee replacement and not the conservative management, which would be physical therapy, exercise, and bracing with this. And it doesn't seem the conservative management is high value. And I think, sometimes I think it would be a better, because of the outcomes after the surgery are not so good as well. I'm trying to collect data on that, especially here in Saudi Arabia. Many of my patients are second or severe, medium or moderate to severe osteoarthritis, and they're and they're getting sedentary, and they're become sedentary because of the pain or disability and swelling. So, but do you think that the conservative management would be a value
Can I
in the health system?
Yeah, Gabriela?
You want me?
Yeah, please.
So there is always a place for conservative management. Not every patient will benefit from surgery, right? So I think screening the patients appropriately and understanding which patients can benefit from surgical approach and which patients cannot, and then offer different solutions is critical. I think part of this is understanding what is value for the patient for that particular population. And then starting defining, with specific performance indicators, how can you measure value on these patients? And then based on that, choose the pathway accordingly. But I would say absolutely, it all depends on which patient.
Yeah, absolutely. And I gave briefly the example from Singapore that has a graying population, which is the case in many countries. So in Singapore, the problem was hip fractures. It could also be knees because similar issues. Again, the starting point initially was management of the fractures, but then soon they realized that as well as managing the surgical procedure, one had to manage post-surgical discharge to ensure rehabilitation, to ensure functionality of those individuals. But of course, one also has to ensure that upstream activities are in place to ensure that individuals are able to function as long as they can before surgery. So in terms of answering your question, is conservative management, can it create value? The answer is absolutely yes, because one has to look at the value generation over not just for episode of care, but actually across the whole journey. So managing actively the well-being of the individual before the point that individual needs surgery is critically important, as is the surgery itself, to ensure that it is delivered effectively and efficiently, but also post-discharge, managing that rehabilitation process and transition process effectively. That's how we need to think about value, not just a reactive disease management tool, but actually managing the whole process.
Thank you so much, both Gabriela and Rifat. Do we have any other questions from the audience? Oh, that is a very straight hand. I appreciate you. We have someone in the back. Can you keep your hand raised, sir? Thank you so much. Do you see him right there on the other side? Yeah. Okay, someone's coming behind you.
Hi, good afternoon. Thank you for the valued information. My name is Hossam Nasser. I'm one of the clinical educators working at Johns Hopkins Aramco Healthcare. My question to the panel is, when we talk about high value, we talk most of the time about money related. So having said that and having talked about the G20, is there any financial collaboration or financial capital to be distributed among the countries? Like, as you mentioned before, that there are countries doing very well in terms of healthcare, and there are other countries that are somehow struggling. So what is the implication to talk about? Are we focusing on, let's say, care that starts from home, home care visits, or are we only focusing on hospital care, or when talk about acute care in the hospitals? Thank you.
So I think there's a range here, but I think largely if we're talking about, and correct me if I'm wrong, so I'm just going to try to replay back for the panelists. We were talking about high value care, but a dimension of that, especially when we think about the G20 and the collection of countries, is the financial side. And where and how, when we're thinking about moving the needle towards high value care, where and how are countries being strategic and where they're allocating their resources? Are they focusing on at-home care? Are they focusing on acute care? Or better yet, amongst the panelists, what's our perspective on where they should be thinking about the allocation of financial resources in order to achieve high value care? Is that?
Yes, that's correct.
Okay, great.
Yeah, I think that so high value health systems, as the name indicates, is for creating greater value in relation to health. So it's not just managing a disease. So it could be a public health intervention. It could be prevention interventions. It could be interventions related to rehabilitation. It could be delivered at any setting. It could be at home. It could be at the workplace. It could be delivered at intermediate care. It could be delivered at primary care setting, hospital, rehabilitation units. So it depends on the problem one is trying to solve. But the objective is to ensure that the individual is getting the effective care that they need, that is delivered in the right place in the most efficient way, but in an equitable way. So everyone benefits from this intervention equitably, but in a setting and in a way that is responsive to needs of that individual and the setting, because care in a rural area is going to be very different to care in a highly concentrated urban area. So there isn't a one-size-fits-all approach. This applies to all the output services we provide for public health and individual care in all different settings.
If I may add one.
Sure. I'm going to let you respond, but while you're responding, I wanted to just put this up here, only for the fact that we're going to run out of time, but I want people to be able to engage and actively download before we get cut. But please, Gabriela, your thoughts.
No, just to add to what Professor Atoun was saying, I guess that from a government level perspective, what this is for us, it's a great tool. It's an approach that allows us to think of which are the most effective policies. This helps us assess the current scenario and also try to find what are the effective policies that we should be thinking of for the next years, given the health of our population, what we're predicting for our populations, given our demographic growth, the conditions of our geography, but also all the other external, everything that can happen, all the other stimulus that we can have, from pandemic preparedness and response to other lines of care, like chronic care. So it does provide an approach for us to think of how to address the issues that arise from the local or the subnational health systems and how that impacts our health system, our national health system as a whole on the health of our population. But from that point of view, it just gives us like a set of guidelines on our next steps and where to go. So this is what the model represents for us, the opportunity to rethink the system. This is very timely because it has been on our agenda for many years. As I said before COVID, there are structural issues. COVID brought us different challenges, and so we are having many different stakeholders, even from academia, from the pharma industry, laboratories, and also the public sector, have rethinking about how to integrate the very segmented and fragmented health system that we have and how to deliver better care for more people. So that's my
we never have enough time, unfortunately, but I'm, on behalf of the G20 Global Innovation Hub and the Harvard Health Systems Innovation Lab, want to thank our panelists, want to thank all of you for engaging and engaging in this session. We're so proud of this report and launching this report. As you can see behind me, you can download the report directly using the QR code. Feel free to engage with either the Hub or the Health Systems Innovation Lab. We have our website, LinkedIn page. But all in all, Gabriela Prada, Gabriela Ramirez, Rifat Atoun, thank you so much for being with us today, and looking forward to what comes next. Thanks, everyone.
Thank you. Thank you.
session 9, the way forward, challenges to accelerating the transformation of the Saudi health sector. The moderator for the session is Mr. Steve Gardner, Managing Director, Healthcare Board, London, UK.
Right, thank you very much. Hopefully, oh yes, you can definitely hear me. I'm very loud. Good afternoon, everybody. Welcome to the session. So, challenges to accelerating the transformation of the Saudi healthcare sector. So, firstly, for those, oh, crikey, there you go, that's well done. So, firstly, for those of you who don't know who we are, this is Healthcare World. So, we're the world's leading international healthcare business magazine, and I'm lucky enough that I get to speak at events like this all over the world, which is fascinating because it gives me the opportunity to gain a real insight into all sorts of different health systems, payer models, provider models. And I'm really pleased to be here today because I think Saudi Arabia is probably the most interesting healthcare system development in the world. The transformation program in Saudi Arabia, the ability to create what is essentially a brand new healthcare system, digitally enabled, data-driven in the kingdom over the coming years is truly fascinating. And with me today to discuss that transformation, I have a really, really interesting panel. From the far end, we have Duncan Selby, formerly the head of Public Health England, now advising on public health here in Saudi Arabia, advising the Saudi Public Health Authority. We have Hussam Al-Faleh, the acting chief executive of the Centre for National Health Insurance, one of the key bodies involved in creating the new payer model here in Saudi. Dr. Yassin Malawi, who is the chief exec of the King Faisal Specialist Hospital and Research Centre, one of the leading facilities in the country, and Christian Engel. Oh, even better. Old-fashioned, but I like it. And Christian Engel from EY, who will furnish us, I no doubt, with some really interesting insight. So, gents, let's get straight into this. I think my first question, just remind us, if you will, of the overall aims of the transformation program. What are we trying to achieve in Saudi Arabia, and where do we currently sit in terms of the transformation program? Duncan, you made the mistake of nodding, so would you like to come in first on this one?
So I made a mistake. Good morning, everyone. Salam alaikum. I am incredibly proud to be here in Saudi. I'm a resident. I've been living here for almost 3 years now. The ambitions for the kingdom, like everybody knows, to have a healthy people, a prosperous people, and a proud people. And this is what the Health Transformation Program is all about, being part of that transformation. We use health as a term almost thoughtlessly, because when we think about it, what we're really meaning is healthcare, hospitals and specialized services. And these are incredibly important, but more important to health outcomes is to have a job, to have a good, somewhere to live, a nice environment, good schools, the much wider range of factors that affect outcome. And so the entire strategy, 2030, is all about two sides of the same coin, which is if we can improve the health of the people through all these different measures, we can improve the prosperity and the economy of the kingdom. That's the point.
And I think it's always important, isn't it, to draw out that relationship between health and wealth and productivity. Having a strong universal health coverage system, it's been proven in pretty much every economy that has one in the world that affects the prosperity of a nation. Hussam, if I can come to you next, can you outline for us, just very briefly, what the structure of this transformation looks like? You, of course, with the CNHI, but you've also got the Health Holding Company, the Ministry, the clusters. If you could just give us a brief overview, that would be really helpful.
Thank you. I think just to recap on what just Duncan mentioned, just to kind of highlight the objectives of this transformation before we talk about the the structure of how actually we're going to go about doing that. So I think in a nutshell, it's the triple aim, is achieving the triple aim. Better health for the population, a better experience of care, better quality of care for an individual. And then how do we do this sustainably? And so to do that, the first structural change that happened in the system was to try and separate out the various functions of the Ministry of Health, which does provision, regulation, as well as financing healthcare services. Given that having an organization with that kind of setup, with that kind of operational mandate, it won't be able to actually meet these objectives. And it is also important to have these functions separated out to create the right level of tension in the system. So the structural change is to separate out these functions so that the delivery goes to another entity, the health holding company, which was established last year, and the various clusters that are going to be moving under it, around 21 clusters. They are responsible for delivery of care, and regulation is going to be the sole function of Ministry of Health, and then the whole issue around payment and financing of healthcare services will become, or is really the task of the Center for National Health Insurance. The true north for this whole structural change and this transformation is really to achieve value-based healthcare. It's basically value for money, value for many, value over time. And so that is really the objective. That's the structural change. But obviously, there's a lot of work ahead of us.
It's a whole journey that takes us from where we are now to the aim that you're looking to reach. We're going off track slightly here, but let's just examine that concept of value-based healthcare. I mean, Christian, I was lucky enough to be in Johannesburg a couple of weeks ago with a colleague of yours from your African firm, discussing the point of value-based healthcare and what it is and what it means. I'm interested in your definition. What does value-based healthcare mean to you, and what could it mean in the Kingdom of Saudi Arabia?
That's a good one. So first of all, thanks for inviting me, and really vibrant to be in this city here. So and a very professional exhibition, and thanks for having me here. I'm leading Europe, Middle East, and India and Africa for Ernst & Young EY. So I'm happy to be here. Back to your question. I think when you look at value-based healthcare, for me the four main targets in all our markets and countries are that we are first improving patient care in the center of care. Second, that we improve the efficiency of the system. And when you look at a lot of our European systems, we are mostly focusing on improving the efficiency and effectiveness. And third, and this is you have to invest in, is prevention. You know? And what I heard and what I got from my colleagues also in the room, also in your country, you are a lot investing in prevention. You know, when you look in our countries, in NHS, for instance, in England or in Germany, we are not so much investing in prevention because we are using all our budgets and money for patient care. And the final one is digital. You know? I think we have, with AI and others, we have like a fourth gold rush. So we can use that, and all these four targets overall is for me value-based or the improvement of value for healthcare. And as said before, I think healthcare in a country is the most and the biggest purpose of all, because without a healthy population, you cannot grow and cannot innovate.
Okay, it's an interesting definition. I mean, for me, value-based healthcare is about the difference between paying for volume and paying for outcomes. Yes. So at the end of the day, value-based healthcare becomes an important element of any health system on the basis that rather than every time there's an intervention, you're paying for a thing, and you're almost creating an unintended consequence. Yes. Where you end up overpaying, and there's an incentive to almost over-treat rather than looking at what the outcome, what the value of treatment would be. You're seen, you're, as a leading provider in the kingdom already. What's your view of value-based healthcare? Is it something that you are currently practicing? Are you on a journey towards it?
Yeah, thank you very much, and thank you for the invitation. Definitely, I mean, value-based healthcare is global, and everybody should be involved in it. And we, as King Faisal, to provide a comprehensive, efficient, integrated care, we are part of that. And we have to adopt it, because you need to have good outcomes for your population. In the old days, we used to serve patients, and we treat them and achieve certain level of treatment, but we don't think of the other parameters of the total value of the expenses, the cost, and all that. But I think now we are putting all that together. Just one example that we are practicing now in King Faisal for our oncology patient, because we are a very big center for oncology. We take approximately 20% of the kingdom new cancer patients. So that's a lot of cost. So by adopting any new medication without knowing the impact on your patient, how they're going to respond, it's a lot of waste. So now, with collaboration of many industries, we are utilizing the data available to precision medicine to use those medications for patients who will respond. The non-responders will find something else to treat them. So that's how we are adopting it and moving towards that.
Because I think cancer is a really interesting example, isn't it? If you want to create a value-based payment model, how do you define the outcomes that you're going to pay against for a long-term condition like cancer or diabetes? That's the challenge, is it not?
I think there is different definitions, but for us to look to the outcome, it's the total well-being of the patient, starting from preventing or treating, and then having a patient who will go and become functional in the society, not a person who got treated but he go home and he's not functional, he cannot practice, or he has a burden, and we lose his contribution to the economy and to the country. So that's how we should look at it.
Can I just...
Sam, yeah, I was going to come to you anyway. Yeah, go.
Just to add to what was mentioned on value-based healthcare and the context that we're living in right now in Saudi Arabia. So I think the whole concept of value-based healthcare and its implementation here in Saudi Arabia or anywhere else requires this establishment of an ecosystem. We in Saudi Arabia, and I feel that we have an opportunity in this country that others may not have. We don't have a deep legacy here. And so we have an opportunity to actually, I wouldn't say this is a blank canvas, but having a regulator actually assumes certain new roles focused on achieving better outcomes for the population, for example. Addressing the prevention, for example, imperative. Having a payer that is actually very aware of what outcomes need to be achieved, and how do we actually align payment to these outcomes. And at the same time, having a provider that transforms, changes its model of delivery to achieve that as well. So we have an opportunity here in Saudi Arabia, if we have the right mindset, if the momentum continues on, to actually create that ecosystem that fosters implementation of value-based healthcare. So I'm optimistic that that tall order, that difficult task, Saudi Arabia might be the place for opening new horizons in this area.
I couldn't agree more with the comment about opportunity. The opportunity in Saudi Arabia is fantastic. We're talking here about some of the obstacles in the way of the transformation. And if you're creating a transformation that you want to be based on value-based healthcare, then actually you're in quite an interesting position as the payer of the future, because how do you create a payer model against outcomes for things like cancer? And I know Duncan wants to come in on this, because the other question is, how do you create a payer model that encompasses a public health and prevention solution? Duncan, do you want to come in on that? And then Christian, I know you wanted to come in too.
So I don't think anywhere in the world has cracked this. And
couldn't agree more.
The opportunity in the kingdom is immense. I mean, it's a young population. It's a very well-educated population, and it's got a plan for the country. And that plan is predicated on prevention. It is understanding where the risks might lie, so it's also and about value-based health, and not only value-based health care, identifying where the risk might be and intervening early. On the data that we have for the kingdom, just short of 80% of early avoidable death is through non-communicable disease. It's through entirely predictable and mostly preventable poor health. I was a hospital chief executive for a number of years, and I was paid for complicated diabetics when I amputated. I was not paid to avoid that amputation by an intervention, for example, CBT, in order to help people to be more or less chaotic. And we have the opportunity through the system that is now being, it's happening, it's not a theoretical, to create a system where we're looking at the whole person and the whole population. We're recognizing the essential role of the specialist services. We need those, but we need to be intervening much earlier with packages of care and insurance that incentivizes and supports people to. We need to avoid this tsunami that is affecting the rest of the world.
Because it's really interesting. I mean, I was in the US a little bit earlier on this year. Public health in the US is virtually non-existent. It's dealt at state level. There's no real money being put into public health care. And in many ways, that's because you're talking about a very heavily evolved insurance system. How do you create an insurance payer model that pays for public health?
So if I take this and going back to the structural change that we have, and that's something I didn't talk about earlier, which is the delivery side is also transforming significantly from from hospitals that are really very focused on delivery of healthcare to moving outside the bounds of a hospital. So these 21 clusters are going to be responsible for a set population, and that population is going to be with this cluster. They are going to be caring for them from cradle to grave. So this is a long-term relationship, and the way we see what we feel is an incentive from a payment perspective moving forward, once transformation is in full swing, is that payment is going to be capitated, risk-adjusted capitated payment against a contract, a value-based contract that clearly articulates what the outcomes of care are, what the population health outcomes are. And so the hope is that having that kind of payment would incentivize the provider to actually look forward and be proactive in reaching out to the population and addressing not only preventative health, addressing preventative health, but also looking at determinants of other determinants of health within its capabilities. So, I mean, that's the hope, and again, it remains to be seen how that will play out over time. Now, one thing again that is in our favor is the fact that public providers today have not been yet corrupted with, fee-for-service, activity-based funding, and so as opposed to other systems where people expect to do more, to increase their volumes, to actually get more revenue. That is not going to be the case. And so two important areas that need to be addressed by all clusters is how do I manage clinical risk and how do I manage financial risk? And for you to actually manage financial risk and work within that capitated budget, you will have to address the population health. Otherwise, you won't be able to work within that budget.
No, it's a fascinating approach. Christian, you wanted to comment on this point?
Yes, I want to comment on your first statement some minutes ago about the opportunity. I think that's completely right, because what I see in a lot of, I would say, our European countries is the opposite, right? Because the mindset is quite old-fashioned, because we learned the system that more indications, more risk is higher payment.
Yep.
So the muscle memory of the providers and the payers is more risk, more indications, more payment is good. So, and we have to reverse the system. You do not have to reverse the system, so it's a new system. And I think we have to learn also from your country and probably from some of the positive effects of other European countries how to do it. But this is a huge, huge opportunity. So we have to, I would say, make a 180-degree change in some of the European countries. You do not have to do that.
So Duncan, I want to come over to you on this one, because there's an interesting point here, and I think it was a point well made by Hussam, which is, okay, you're going to create an insurance system where there are incentives in place for people to live healthier lives, and therefore we can get some of this kind of preventative stuff going. But at the end of the day, is there not a need for an upfront investment outside of the insurance system in creating the kind of public health messaging around diet, activity, smoking cessation? Where will that come from? How will that be paid for?
So, the first thing I need to say is I'm going to go and get a hearing aid after.
I'll join you with that as well. We're challenged here.
Yeah, it's not great, is it?
What
when Christian was speaking, I was lip reading on the screen. That helps.
Yeah. No. It's an aging thing. So the three.
Well, how we deal with an aging population, we'll get to that later. But yeah.
So I mean, we all know this, right? Is that the most important health outcome we've spoken about are these like wider societal, economic, environmental, some genetics, about half of what matters, the circumstances in which you're born and the fortune that you have or misfortune about that. That's about half of it. And then about 30% are the choices people make about whether to smoke, how much to eat, whether they ever take exercise, and so on. And then at the top end of that is what our healthcare providers offer. So it's not a matter of which is more important, because they all matter. It's just the order in which they matter is important to understand. So if we're concerned, that we are concerned with the wider determinants was my original point about the 2030 strategy, because that pays attention to all of these different factors, that the economy will drive improving health and vice versa. The health sector transformation program that Dr. Shabani has been leading for the last number of years has a terrific strategy. It really is very smart. It's a public health strategy, and it pays attention to all these different elements, along with the organizational changes that are happening in the kingdom. Make 2 quick points. All of this ultimately will depend on finding alternatives to hospital care. How do we help people to stay well for longer? How do we help them to stay out of hospital for longer? When they're in hospital, how to get them out faster? And if they're in a job, to help them to stay in that job, stay in their own home, because this is what will drive the economy. At the heart of it is primary care, which is a huge part of the strategy for the kingdom. The United Kingdom doesn't have a lot to teach the Kingdom of Saudi Arabia. It does, though, do primary care. And 90% of all interventions happen outside of hospital. And we need to try and do something that is going to boost primary care. I think that's the biggest challenge. I know you'll come on to that later, but I think that is the biggest challenge.
Yeah, absolutely. I want to come to you, Yassine, because you are, obviously, if you look at the kind of care that is being delivered, healthcare that's being delivered in the kingdom at the moment, you're the one with your feet on the ground delivering that care at the coalface. How much of that kind of preventative and primary care is there going on in the kingdom at the moment, and how does that need to develop?
Okay. As the colleague mentioned, there is a plan for the prevention and through the primary care. For us as King Faisal, our mandate is to take care of the complicated diseases, tertiary care and quaternary, and whatever new technologies that we can adapt. But through our research and through our genetic, we can help in the prevention by doing mass screening, by doing whole genome sequencing, and even new technologies that emerging in that field, and doing research. We can predict, and also maybe later we'll come to artificial intelligence that we in King Faisal investing a lot at to predict diseases so we can prevent it from happening. So I think that's our role as King Faisal in the way of prevention, is to go to the very complex diseases, find out the reasons, how we can prevent that. One of the examples is that we have the biggest program in the Middle East for the BGD, pre-gestational diagnosis. And that is a way of prevention, but it's very complicated prevention that cannot be done in the primary care. So we do that, and we have fun.
Yeah, that's very good. I want to be a bit challenging with the primary care piece. And it's not because I'm a specialist, I'm a cardiologist. So you are a cardiologist as well, so you have two in the panel here. So that's a disclosure here. I think that primary care is instrumental. But what is, I think, more important is the context by which this system, this primary care works in the system. I don't feel that primary care is going to be effective on its own. It needs to be integrated with the various other levels of care. And unless this integration happens, no matter how much resources you put in primary care, no matter how smart are the doctors, if they are not really integrated with the bigger ecosystem, I do not think that we are going to move forward. And I think part of the challenge, not only here in Saudi Arabia, but also elsewhere, is a focus on primary care in isolation. Yes, we need to develop capabilities. Yeah. Yes, we need to actually have all the right expertise within a primary care. I don't think that alone will actually deliver. It needs to be somehow integrated with the other levels of care. There needs to be accountability that actually transcends all levels of care for us to actually head towards value-based healthcare.
Yeah.
Duncan, to you, and then you.
So this isn't controversial at all. We're in complete agreement, and I mean the key thing is that people get cared for in the right place, in the right environment. So that will often enough be in a specialist centre, where the prevention examples you gave were excellent, but it will more often not be in a hospital setting, provided you can get rapid access and quick referral and quick supervision from the specialist. So the accountable care system, the clusters, integrate around that population that you were, with eventually a fee-based system that will incentivize the specialists to think further down about, okay, maybe if I intervene. Now, the trouble with saying that is it suggests that hospitals don't think like that at the moment. It's just that hospitals deal with what comes through the front door, and they do that fabulously. We need to get them out into the garden, or a bit more widely, but in a fully integrated way, just as you've described.
Yassine, you want to come in?
Yes. The whole component is important, primary, secondary, tertiary. But for those who attended and heard His Excellency, the Minister of Health, yesterday, he mentioned that the population of Kingdom of Saudi Arabia is going to increase by 2040, I think by 25%. Number two, it's going to be aging population. Currently, we have 6% above age of 60. By 2040, I think it's 20% above age of. So if you look to the disease pattern, regardless of what we do in the primary care, chronic diseases will still remain there. Cancer will increase, neuro diseases will increase, cardiac diseases. So primary care is important, and in prevention and doing the early things to prevent complex disease, but we're going to face it. So we have to be ready to face that with all the capability, the technology that we need.
I think the concept of integrated care is a fascinating one, and how you kind of move it down the track. I mean, you talked about prevention, you talked about using data. You know, at the end of the day, this is all about kind of triaging down the line so that you're saving your most precious resources for the people that need it most. I think the stat is, what, 80% of your healthcare spend goes on 20% of your population. But some of this, I want to move on to another topic which has been touched on slightly here, which is the idea of kind of population health management and the use of data. Because at the end of the day, if you're going to do the kind of preventative work that you want to do, then you need to have the data on the health of your population, both the healthy population and the ill population, in sufficient amounts and sufficient quality in order to make those predictive algorithms work and to be able to do that piece on preventative care. I wonder if any of you could comment on where you're at in terms of the quality and volume of data that's available in the health system in Saudi at the moment. Hussam, have you got any insight on that point?
Sure. I think one of the key challenges in our system is data. This is not news. I don't think it's news. And the challenge is basic. We're talking about challenges with data within even the hospital. Activities, coded activities, is an area of great deficiency. I think that there's a strong realization that we need to move fast and we need to leapfrog. The new platform, the new exchange platform, Nafis, I think presents itself as a great opportunity in terms of actually having all of these data in this platform, connecting all the insurance companies, the providers, both private and public, having this unified medical file, which was unveiled here in this conference, in this exhibition. And I think this is going to be, a good starting point for us. Most of the analysis that we do is we always put a disclaimer. We don't have enough data to actually be sure whether this direction is right or not. But I think we need to, live with the fact that we need to actually work with what we have, build fast, and create the right environment, regulation, incentives, be it financial incentive or otherwise, that in order for the system to move fast. One of the things that we've been working with the clusters on, and we've been having these agreements that are, simulations for a contract moving forward, a dress rehearsal, if you like, with these various clusters. So we've had 5 cluster agreements. And one of the key areas that we're trying to actually get across is that you are going to be responsible for financial risk and clinical risk. Without data, you won't be able to actually address this. And we're trying to actually help the clusters actually understand where to start, what to focus on, and hopefully that would help.
Christine, you want to go in?
Yeah, I think also here, a little bit controversial because, we took a lot of, I would say, investments in a lot of our countries in Europe to build electronic patient records over the overall system, like in France, like in Germany, like in Spain. At the end, you have from each and every patient the overall indications, activities, and so on. The challenge is in my world is how do we motivate the doctors, the GPs to use the data, the gold mine we have in the bottom, using this data, how to improve patient pathways, to use the data to find patterns from other patients with the same indications, to improve the patient pathway. How can we really motivate our doctors and nurses and GPs using the data? This is an open question for me. I'm struggling there, really. So if we can make a pilot there, it would be really helpful because, as I said before, we have a lot of data, but the usage is quite limited. Yeah? So it's a positive usage. Yeah?
Duncan, you want to go on?
So I wasn't sure if I was going to contribute to this question. So the kingdom has got an opportunity to understand the profile of health within the kingdom, if you like, a population base, not that people are ill enough to require care, but to know what the health profile is by geography, by age, by various different ways. And the kingdom is beginning to gather this information, and that's going to be extraordinarily powerful. The conversation about clinical coding is then at the heart of how do you understand your outcomes and the costs, and how do you make judgments about value if we're not tracking the data and using that data. And again, there's like lots of really good work going on that in the kingdom. So I think it's at the heart of the challenge that we need to get on. So the thing I wanted, here's across the world, the spend on prevention, crudely understood, but broadly comparable, is about 5% of the spend as against on the treatment of illness. Finland have a strategy to shift that to 50% of the spend. Now that's radical. Now they're going to have to be hugely creative about what they include in that, but they're making a very important point. That if you say something's important, then show me your budget and I'll know whether it is important. If you tell me it matters, but you continue to spend a tiny fraction of your budget on it, it doesn't. So there's a relationship between what you say and what you do. Show me your budget, and then I'll know whether you're serious. And the only example that I know of in the world that is genuinely going in that direction big time is Finland. But Saudi Arabia, with the health sector transformation program, is going to like leapfrog that.
Yeah.
We won't see that maybe for another 2 or 3 years, but all of the preparatory work that's going on with clusters, the insurance system, the regulation, the change, all the new entities that are, is all about getting ready for that. That, for me, is the matter. Don't tell me what you care about, show me, and then I'll believe you.
Yeah. Nobody's shown me the budgets for the Saudi Arabian transformation program. I'm not expecting anybody to. But what I do know is that the conversations that I have so regularly, we're talking about population health, we're talking about data, we're talking about preventative care. So the ambition is clearly there. This question, though, of actually the volume and accuracy of data. You see, and I want to come to you on this because you're an active, existing hospital working in the kingdom. Do you share your patient data with the system? Are there data sharing agreements in place in the kingdom that allow providers in the private and public sectors to share data for the common good of creating those population health models?
Okay. I think with the transformation, since it was started in 2016, because of the rules and regulation, we start sharing data. There is now the Qiyas, which is the e-government, Sadaya, the Saudi Data and Artificial Intelligence Authority. So they are the governing body. So now we feel comfortable and we are obliged sort of to share the data because it's for the benefit of the country. Previously, when there was no rules and regulation, we cannot risk it. So now also there is a national cybersecurity authority. So all that falling together. So yes, now we are sharing the data with the entities that require it, and hopefully it will be beneficial. We have good data in our data warehouse about complex diseases. For example, we are the first entity started cancer registry, and then it was taken by the Saudi Health Council, and we are part of it now, plus many others in heart diseases, in neurosurgical diseases, brain tumors. So there is a wealth of data at King Faisal that now we are sharing.
Hussam, one element of creating a population health data lake, creating population data health models, is actually having data not just on the population who are sick, but also on the population who are well. If you don't have that data as well, then the population health models just don't work. Do you have the right data from your well population to be able to input into these models?
So, short answer is we don't have enough information about the well population. Now, one of the key things that we worked on early on in our setup of the national insurance is to work on developing a strategy for population health management. So we were at the forefront there, and we later on worked with public health authority, with the health holding company to refine it and to come up with a manual for population health management. And one of the key areas that we have tried to implement is having this, implementing the cycle of population health management that starts with a health need assessment. And this is a very alien concept to hospitals. When you start talking about that you need to actually go out and understand the risk profile of your population, regardless of whether they've used healthcare services or not, is a very alien concept. Come to a hospital, come to any physician that works in a hospital. Everybody is comfortable doing what they do every day, but actually thinking of something outside the bounds of that hospital is extremely difficult. And so one of the things that we're trying to focus on is to prototype, to try and create experiences at various clusters, to actually reach out, do some health need assessment, understand the profile of your population, segment them, create plans, interventions, measure, and the cycle continues on. I think there's a dire need to create some prototypes and for people to really understand what looks like a concept, a high-level concept, to something that is tangible and actionable.
Christian, you want to come in and then Duncan?
Yes. Only one comment on that, because I like your comment there. I have one very positive example also from the Nordics. They have a pair has innovated a new application, new app. It's based on iOS and on Android, in which all the young population can type in via a symptom checker their smaller diseases, right? And it's completely integrated with food consumption, with the running app. So you have a lot of, I would say, healthy data of a very young population. And there's a high motivation of younger people to type in and to transfer data in such an environment. So we can probably use it also in here. So it's I would say, a high openness for younger people to share data like food, healthy, and also symptom checkers. Yeah.
Duncan?
Oh, just the Public Health Authority here have begun a pilot to understand, using really quite sophisticated epidemiology and sort of data science and so on, to understand the health of the people. Yeah. And this will contribute in time, because one of the lovely things about here is about just how people are working together and bringing each other's expertise to bear. So Public Health Authority there is a servant to the holdco, to the insurance, to the regulator. It's a very integrated, and it will move faster than any other part of the world of this I'm sure. The future, I think, outside of when you're unwell, will be behavioral science in how you understand and influence or nudge behaviors towards healthier behaviors, yes, which we can incentivize through the new systems being developed. And we have such a young population; they're way ahead of old age pensioners about actually how that's going to transform things. So it's all part. I mean, there's more data than we believe out there. It's how do we
curate it in a way that drives this sort of better, so we can make better data, better decisions, better, and so on.
Outcomes.
I mean, there's a whole thing. We've talked about the idea of prevention. We've touched on primary care. We could probably do another 2 hours talking about all of the other bits and pieces that sit around, but we've only got 14 minutes. I think that the perfect point here is that somebody said to me recently, the bizarre nature of healthcare is that what do we do with sick people? We send them to buildings full of more sick people. You know, one of the things that we're trying to do with preventative care, with data, is A, stop people from coming into the health system in the first place, and B, find ways of treating them remotely. We've only got 15 minutes left, but I want to touch on digital healthcare and the revolution in digital healthcare. And Yassine, you and I were talking about this on the way in. What do you think the key developments in digital health in the kingdom are likely to be? What are the areas of focus in terms of the development of digital healthcare?
There is a lot of areas, but I want to just mention something. I think it's important historically. When King Faisal Hospital established in 1970 and inaugurated in 1975, if you visit our hospital in the corridors or the C office, you will find a very old newspaper from 1975 saying the automatic hospital, which means it was automated at that time. So whatever technology was available in 1975 was brought to King Faisal. And we, by the way, by history, we are the first entity in the country to bring the internet. So you can see that King Faisal invested in technology and digitalization from day one. And we shifted from information technology to health information technology affairs in 2014. So we know the value of digitalization and technology in health. Now we have our health information system since 2000, and we kept integrating and building on that. And we call it within ourselves in the hospital as the total solution, because there is so many things added to the basic one that make it very much workable. And we encourage our patient even to utilize that. So we have a Takhassusi app, we have others that patient participate in their management. They see their data, they book their appointments, they can discuss. So a lot of things going on. Also, we are now bringing any new technology. So everybody talking about home health care, we're investing on that. We're investing in virtual care. We also built a patient flow and command center that looks to data live and make decision on the spot. And we really learned a lot of lesson on that, so it helped us making major decision. And then by putting artificial intelligence with this technology and the IT system, we really have a lot of improvement. I'll just try to remember and mention a few examples. For example, we are predicting the no-shows, so we can act on it. We are predicting the readmission. So because there is always a competition between the average length of stay and discharging patient early, and then they come to the ER and get admitted. So we are putting that in the AI and try to predict and take action in advance. Breast cancer, which is something really we are proud of, because there is a lot of radiological images that read as benign, and then few months later, unfortunately, the lady has a cancer. So our team created an algorithm. So now, with those patients, the population, not the pure benign, but the reported as benign and then become cancer, an algorithm made. So now they are reported as cancer, and the physician get notified. So just to make more focus, bring them early, do more frequent testing, so we can really monitor and move in that. Also, two more things I'll mention. In radiology, there is something called computer visioning now. So we put the images, and with the artificial intelligence, we can decide what the best procedure, what the best approach. Radiation therapy for brain tumor, there is usually 3 to 5 days to decide how you're going to deliver the radiation therapy. With artificial intelligence, now we can do it in 2 hours because it's auto-contouring of the tumor, and then the machine just delivers the therapy there. So really, King Faisal is very digitalized. I think it was mentioned yesterday that we are the first hospital in the world to do robotic liver transplant end-to-end, donor and recipient. Previously, it's done only for the donors and the recipient in the old way. Now it's all robotic. And we did 5 cases as of today. So that's really incorporating both technology and the skills together and the IT. So
that's some great examples.
One last thing,
Go on.
if you allow me, I'll mention, because everybody lived through the COVID pandemic. And we had the command and control center, and we had the business continuity plan. And then our team created a COVID platform. And there is a formula, they were predicting the increase and reduction in cases. On that, we made decision on supply chain, so we never had a zero stock through the pandemic because of the prediction, and also monitoring the zoning of the hospital because of our immunocompromised patient and the transplant. We had the green zone and red zone and so on. So with the prediction of the number of increases in cases and the bed occupancy, we decide to increase or decrease the zones accordingly. And that was really successful story for us, and the whole kingdom was successful during COVID. Now, the team is working on it to be a platform for infectious disease. So any infection can utilize that platform to predict what's happened and what's number of cases gonna come. So,
I mean, some absolutely fantastic examples of the use of digital technology in the acute setting. What about at the primary care level? How much is going on, and Hussam, perhaps you could comment on this, how much work is going on to bring technology like, for example, remote consultation, symptom checkers, treating people in their own homes at the primary care level? Is that something that's happening in the kingdom?
So the question is to me. I thought it was to Duncan.
Well,
No,
Duncan tells me he's a technophobe, so we're not allowed to talk digital technology with him.
So again, the short answer is not as much as we want. We're still struggling in the basics when it comes to the primary care centers establishing the EMRs, the health records. So we're still not there, I don't think. You know, related to this, although not as, related to the examples that Dr. Malawi was mentioning, one of the key things that I personally believe, and I think that this transformation started with the transformation of the model of care, was how do we activate the beneficiary? And I think that technology today, AI included, I think presents itself with a great opportunity in actually activating the individual to care for his health. You know, I personally believe, as a physician, as a cardiologist who sees a lot of non-communicable disease, that there's so much you can do in terms of improving outcomes of people who have established disease. And I feel that, you know, mega projects in Saudi Arabia, such as, for example, the sport lane that is being established right now, which is over 120 kilometers of track, sport track, is probably, is going to be, it's going to create a higher impact than any hospital, any number of hospitals that you would establish. You wouldn't need hospitals, of course, but what I'm trying to say is the impact on public health, the impact on the health of the population is only going to happen if you change the environment in a manner that is conducive to caring for health. I like to run. One of the things that I do, not only for sports, but as a stress reliever, is to run, is to jog. And I think if you, a few years back, it would be really difficult to find a place to go and jog. In my neighborhood, there are new tracks, for people to actually bike, to run. And I feel that these things, alongside a lot of the other regulations that really tackle lifestyle changes, are going to be far more impactful than any technology that you would have in a hospital. But going back to the point again, I think technology, I think what is in the horizon to me is how do we actually leverage technology today to activate the individuals to take better care of their health.
There's almost a point there, isn't there, about actually technology in the health system or technology outside the health system? How many people wear Apple Watches? How many people use wearables? How much data is there that you can track? And indeed, if you had access to that data, what could you do with it in terms of predicting any health conditions? Duncan, you said you weren't going to come in on anything to do with technology, and then you put your hand up. So,
well, yeah, so my best friend here tells it. Primary care will come. It will come because of what Hussam was describing earlier about integrating it within the clusters and the accountable care organisations, and you apply the sort of brain and experience and expertise of a King Faisal and watch what happens. And there are examples around the world, in Scotland, in Australia, where you can see real great remoteness, and there's lots of it going on, but most of that knowledge and know-how is within the hospital sector. It's within the And so there will be like a rolling benefit, and it will speed up, and so you'll see the sort of innovation in primary care coming through this model of integration, not separation. That was the integration.
Just a point I would like to add, and I think it's important for Dr. Hussam to consider. We are talking about wearable and things that will transmit data. I think it's very important because now, for example, glasses, hearing aid is covered by insurance and by the government. But for these things, I think we have to see, can we cover it? Because not everybody can afford it if you go to rural areas and peripheries. So unless it is very cheap and affordable, but now definitely it's not. So if we really want to gather data across the whole population, I think we have to make it easy and easy usable also. Yeah. Because we face in our level, when you give home healthcare monitors, not everybody knows how to use it, the technology. So if they disconnect it from the electricity, then it will not transmit anything to you. So it's useless. So I think educating, explaining the value of this for the people so they can use it, and then we can collect data and use it to prevent.
I think one of the key and most important things in the development of any health system is how you bring the population along. And have you got the will and the understanding amongst the people who are using the healthcare system about what it can do for them and what they need to do with. It comes back, I guess, to the point about public health. We've only got a couple of minutes left. I think we've identified a couple of interesting challenges around data. We've touched on the challenges around primary care and putting healthcare prevention at the centre of the strategy. Just 30 seconds each, gentlemen. What other barriers, issues, problems do you see that will stop Saudi from achieving the goal of the transformation? And I'll start, Christian, with you and make my way down the group. Christian, what other challenges are there in this health system that we've not thought about yet?
I think you said it already before. So for me, with 100% crystal clear, is mindset. Yeah? In a lot of countries, you have this mindset. We have to improve the performance in efficiency and effectiveness of care. It's not the case. So I think from my perspective, it's mindset that the value of health is to make all the citizens, the population healthy. So it's a mindset, really the mindset.
I think the phrase I've heard used in the past is moving from sick care to health care.
Yes,
yeah.
Right, mindset.
You see?
For me, it's the culture change. For people, especially healthcare workers, to adopt the new operating model. Because people tend to resist the change. I think we have to enforce it, make sure people will adapt and become cost conscious. Because previously the government pay, we perform, but we never think of the cost. I think now putting things together, cost is very important to consider.
And also, if you don't bring your workforce with you, then you're not going to achieve anything. Hussam.
So I think I agree with what's mentioned here. So physicians are very tribal. We're very much stuck on our ways of doing things. Changing that is really difficult. And I think that realizing that this isn't sustainable, what we're doing today in our hospitals is not sustainable. I understand that clearly from the patients that come to me in my clinic, the ones that I actually cath. There's no way this can continue on. And I think that having that aha moment that this is not sustainable, that there's another way, might be one way of changing mindset. So it is the biggest barrier, in my view, is this barrier in hospitals, the mindset of the practitioners. However, there's also another constituent here, which is the population, the mindset of the population. Even if you have a great mindset within the healthcare system, if you're unable to actually change also the mindset of an individual in the general population about how he should look at health, I don't think we will be able to be as successful in our transformation. And I think that that is one of the biggest challenges today.
And Duncan, finally to you.
Okay, so I believe this transformation is going to happen. I think it's going to work. I think the ingredients are all there. I'm going to agree, and then I'm going to add something different. I think the two things that I would focus on are choose what you measure and pay for what you measure. So we say it matters. We need, through Dr. Hassam, to make sure that's what we pay for. And that would be radical.
I think that's called value-based healthcare, isn't it? Which kind of takes us back to where we started. Well, look, we're out of time, and I want to thank all four of my panelists. That really fascinating debate, really, really interesting conversation. So what are the challenges that we've identified to the transformation program in Saudi Arabia? Well, we've got to work out how value-based healthcare works and how we create those preventative structures and pay for them. We've got to work out how we get the data together in sufficient quality to allow us to use the predictive models that we've talked about. We've got to get our primary care right. I mean, look, this is the most ambitious healthcare transformation program anywhere in the world. But from the experience I've had at working in Saudi for the last year or two, if there's any country that can do it, it's this country. What I love coming here from the UK is the fact that the Saudi health economy is interested, it wants to listen, it wants to understand what's gone right and what's gone wrong in other parts of the world, adopt that practice and make it better. And do you know what, gentlemen? I think you'll achieve it. Thanks very much. Thank you.
Thank you.
Highly appreciated for the session. It was very interesting, and we would like to thank all our guest speakers for today. You did a great job, and thank you for everyone for being with us in the sessions, and we wish you a great evening.